This score was proposed by American College of Cardiology to calculate 10 years as well as the lifetime risk of atherosclerotic vascular disease in different population. Since these scores were developed out of Western cohorts, their validity in Indian population has not been established. And there are very few studies available validating this risk score assessment tool in population of Indian subcontinent. Correlation of angiography data with ACVD risk score in Indian subcontinent will help us in evaluating the applicability of this scoring system in our population. So to start with my aims and objectives, we aim to assess the correlation between ACVD score, CT calcium score, and severity of coronary artery disease, which was represented with the Gensini and Syntax scores. So objectives were to correlate ACVD risk score with severity of atherosclerotic coronary artery disease, and also to correlate coronary artery calcium scoring with coronary angiographic findings. It was a prospective observational non-intervention study. 100 patients with suspected ischemic heart disease who underwent coronary angiogram as well as coronary artery calcium scoring during the period of September 2020 and October 2021 in our department were included in the study. Exclusion criteria included hemodynamically unstable patients who cannot undergo CT calcium, and those patients who underwent primary PTCA, patients with tachycardia whose heart rate cannot be controlled so that optimal CT calcium scoring cannot be achieved. And patients with history of coronary revascularization, patients with renal dysfunction, technically inadequate CT calcium scoring, such patients were excluded from my study. Informed consent was taken, detailed history and risk factors were documented, and we calculated ACVD risk using the online calculator available at the website. And this was the landing page of the website from which we calculated ACVD risk score. Patient then underwent a CT coronary calcium scoring. Then conventional angiography was done, and standard treatment protocols were followed depending on the coronary angiography findings. Syntax score was calculated using dedicated software that integrates the number of lesions based on the amount of myocardial distal to the lesion, and data collected were analyzed with relevant statistical method. So mean age in our study was 55, and it ranged from 31 to 75. Clinical presentation was mostly transmural myocardial infarction, which was there in 59 out of 100 patients in our study. 20% of the patients presented with the non-ST elevation MI. And the most commonly associated risk factor was diabetes. And distribution of ACVD risk score, 57% of the patient had a score of more than 7.5. 23 patients had a score of less than 7.5. And in 20 patients, we could not calculate the ACVD risk score. I'll be discussing why that was. Correlation between ACVD scoring and syntax categories. So 15 out of the 23 patients with ACVD risk score of less than 7.5 were found to have significant coronary artery disease expressed in terms of ACVD score, and 50 out of 57 patients with ACVD risk score of more than 7.5 had significant coronary artery disease, making ACVD risk score only 53% sensitive, and it was found to be relatively specific. A distribution of calcium scoring, we had patients whose CT calcium scoring varied from 0 to 2,700 and mean was 35.8. So this is a correlation between syntax and coronary artery calcium score. According to Person's correlation, the positive linear correlation was 0.51 for the total calcium scoring, and syntax scoring, which is statistically significant with a p-value of less than 0.01. Similar correlation was found between Gensini score and CT coronary calcium scoring as well. And this is the ROC curve of the calcium scoring against the syntax, where we used either syntax 0 or 1 or more than 1. It had a significant area under curve of 0.890 with a significant p-value. The occurrence of disease based on syntax scoring was predicted at total calcium scoring of 20.3 with a sensitivity of 88.9% and specificity was 79.8%. A similar ROC curve between CT calcium scoring and Gensini had very similar findings, with the area under curve being 0.924, and the occurrence of the disease based on Gensini scoring was predicted at a total calcium of 15.8, and it was sensitivity was 90.2, specificity was little lesser on the lesser side with 52.8% specificity. So similar studies were conducted before. One such study by Garg and et al. Concluded that ACVD risk score does not behave the same way as in Western population. And one other study by Gobardhan et al. Had concluded that CT coronary angiogram against ACVD risk score showed more severe coronary artery calcium in Asian population than the Western population. So in lines with the above studies, in our study also, there was a poor correlation between 10-year ACVD risk score and the presence of coronary artery disease. 20 patients were not eligible for the risk score calculation because they had total cholesterol of less than 130, and that was the limit prescribed by the AHA. So to conclude, ACVD risk scoring is a useful risk assessment tool that can aid in the primary prevention of atherosclerotic coronary vascular disease. However, it may underestimate the risk of CVD in Indian population, and more such studies are needed to validate this scoring system in Indian subcontinent. And coronary artery calcium scoring system, coronary artery calcium scoring, a non-invasive study has statistically significant association in the presence of ACVD in our study. Further large-scale studies are needed so that it can be used as a screening tool in coronary artery disease. The occurrence of disease based on syntax scoring was predicted with a total calcium score of 20.3, and it was relatively sensitive as well as specific. Thank you.
Congrats, very nicely you compared the different scoring systems. And basically the syntax scoring is the complexity of the atherosclerotic lesions, basically the syntax score. And the ASPD scoring is more prediction of the coronary events and all these things. And as we have seen in our day-to-day practice, observations also, in Indian population, especially ACVD score won't correlate with the calcium scoring systems. And of course, they have to incorporate some of these calcium, coronary artery calcium also as one of the additional points in the ASVD scoring systems. In additional, actually, they built in the ASVD. Anyway, a nice thing you presented, and especially the population-based study where you can take the preventive precautions in the presence of coronary artery calcium severe.
Thank you.
You said your objective was to validate ACVD in Indian population. Am I right?
Yes, sir. Yes.
Did you do a sample size calculation?
Yes, sir, we did, sir.
How much did you get?
Sir, there was a study conducted by Shihan and et al. Where,
No, I'm asking, when you did your sample size calculation, what sample size did you get?
Sir, we got 96 as a...
96.
Yes.
Okay. And what population should you take when you worked? As sir said, ACVD is for predicting, no. But it looks like all your patients are already CAD patients.
No, sir. I mean...
Am I right?
Sir, patients admitted with, they were not already diagnosed CAD patients, sir. Suspected CAD patients were taken.
But all of them had something, no? Your thing is showing that...
Sir, many patients had history of chest pain and atypical ECG changes. We were not sure whether they had coronary artery disease or not. In fact, we had 25 patients who had normal coronary, sir. 24 patients.
How many were normal coronary angio's in that?
24 patients. 24. Yes.
And again, same thing, same question to you also. Why do you all make your continuous data into binary data?
Sir, syntax...
I know it's easier to do, but it's always better to take a...
Sir, I did both.
Continuous variable.
I did include continuous as well as discrete data, sir. While calculating, I did put a ROC curve where I used continuous data. Sir.
Okay.
Thank you, sir.
Next presenter, Dr. Varun Mitra from SWIMS Tirupati.
Good morning. Today I'm going to present about observational study, echocardiographic assessment of inter and interventricular dysynchrony in heart failure patients with reduced ejection fraction and normal QRS duration using speckle tracking, tissue Doppler imaging, and M mode. As we all know, management of heart failure patients is an important issue in cardiology, with the duration of QRS being the primary guiding tool on whether to go for cardiac desynchronization therapy or not. Dysynchrony has been reported in patients with normal QRS also, and the duration of QRS need not necessarily correlate with the extent of dysynchrony as demonstrated by many previous single center studies. So, so dysynchrony can be assessed by multiple ways. M-mode echocardiography, tissue Doppler, strain echo, 3D echocardiography, velocity encoded MRI. So in my study, I included 3 modes, strain echocardiography, M mode, and tissue Doppler imaging. Next slide. Well, coming to my aims and objectives. So my aim was to, primary aim was to present, assess the prevalence of the interventricular and intraventricular dysynchrony. And my second objective was to compare the results of various parameters obtained. So my inclusion criteria was primarily heart failure patients with ejection fraction less than or equal to 40% and a narrow QRS complex with a duration of symptoms more than 6 months, irrespective of the etiology. I included both ischemic and non-ischemic patients. And exclusion criteria excluded patients with structural heart disease and narrow QRS complex. And primarily my main exclusion criteria was presence of a left or a right bundle branch block. So sample size, the calculated sample size was actually around 96, but in view of the ongoing COVID pandemic, I made a request to the scientific committee and finally we agreed on a sample size of 50. So totally the average age of the population was 46.44 and coronary artery disease leading to ischemic cardiomyopathy causing the symptoms was there in 19 patients, which was 38%. CKD was present in 18% of the individuals, dilated cardiomyopathy in 48%, which constituted majority of my patients. And the mean LV function was 30%. The average, we also calculated the right ventricular function using TAVI, and the interventricular dysfunction, dysynchrony was primarily measured by the difference in the aortic and pulmonary pre-ejection times. So this was present in around 10 individuals, and various parameters to measure the intraventricular dysynchrony, like septal to posterior wall motion delay and the difference in time to peak systolic velocity, difference in time to peak strain. These were present in between 8 to 13 individuals depending on the parameter. So coming to the strain imaging, according to the criteria for dysynchrony using strain imaging, the time to peak radial strain of greater than 130 milliseconds was taken as the cutoff, and dysynchrony was present in 10 individuals according to this parameter. And if we take the standard deviation on the 12 apical segments peak radial strain, dysynchrony was present in around 12 individuals. So coming to correlations between various parameters used to assess the intraventricular dysynchrony, there was a positive correlation between all the parameters, but the highest was between septal to posterior wall motion delay and time to peak strain and time to peak systolic velocity, the difference between anteroseptal and posterior, and the standard deviation of the time to peak systolic velocity, and also between the standard deviation in time to peak strain and the difference in time to peak systolic velocity between anteroseptal and posterior segments. So coming to correlations between interventricular and intraventricular dysynchrony, there was a correlation, but the correlation coefficient was 0.4371, which was significant. However, the R square was on the lower side. This was probably due to the low sample size. So coming to discussion, this study was undertaken to assess the frequency of electromechanical dysynchrony and the relationship between different indices to one another. And the frequency of interventricular dysynchrony in the study was based on radial on strain imaging, tissue Doppler, and M mode, and the percentages was ranged from 20 to 24%. And previous studies have documented presence of dysynchrony between 29 to 50% in heart failure patients with a narrow QRS. So the correlations was very high between the ones which I mentioned in the previous slide, and a positive, coming to other studies, a positive correlation between septal to posterior motion delay and the parameters assessed by tissue Doppler was previously found, and correlation, there was also good correlation between speckle tracking and pulse wave tissue Doppler imaging. So, and in our study, there was correlation which was statistically significant between inter and intraventricular mechanical dysynchrony. I could find one other study where these two parameters were correlated, and in that study, there wasn't a significant correlation between the two. So to conclude, inter and intraventricular dysynchrony occur in a significant proportion of heart failure patients with a narrow QRS complex. The percentages of the intraventricular dysynchrony have been mentioned, and there was a statistically significant correlation between the various indices. No significant association between QRS duration and ventricular dysynchrony. Thank you.
Who did the echocardiographic study for you? You did it yourself or somebody did it for you?
I did it, sir.
You are trained in that?
Yes, sir. Technician taught me, sir.
Technician taught. I hope your methodology was validated by your guide or somebody to check that you did it rightly, correctly. Second thing is your patients, you did your study, you did yourself.
Yes, sir.
So you are not blinded to the patient, whether he has,
I was not blinded, sir.
So you knew about it. How did you measure the QRS interval? When you used the computer value or you did it yourself?
I did it myself, sir. On the ECG, the QRS duration is mentioned on the computer.
Did you take that value or you again measured it yourself? What did you do?
I mostly took that value.
The computer value.
Yes.
How do you extrapolate your study to the clinical application?
Clinical application. Sir, current guidelines do not recommend CRT in individuals with a narrow QRS complex. Even the latest ESC guidelines of 2021, the cutoff was actually much lower. The class 1 recommendation was over a QRS duration of over 150 with a left bundle branch block morphology. So my study was primarily done in patients with a narrow QRS complex. And the data, it was a small scale study, and the data also doesn't support the use of CRTs.
Thank you.
Dr. Jeevan Babu.
Good morning, respected sirs and madams and dear colleagues. My topic is that assessment of MRI findings in MI patients in correlation with 2D echo findings. So it's very important after the MI that the role of cardiac imaging in assessment of any dysfunctional and viable myocardium and the future risk of MACE, including the risk of ventricular arrhythmias and the need for any anticoagulation. So for this, we need to do cardiac imaging, and each one imaging has its own strengths and weaknesses, like the echo strain imaging and cardiac MRI and SPECT. Nuclear imaging, all this has got their own strengths and weaknesses. So this study aims to study the assess the MRI findings in post-MI patients in correlation to 2D echo findings and to determine their correlation. It's a prospective observational study. It's done in the Department of Cardiology in Ramesh Hospitals from October 2022 to 30 July 2021. And after the reperfusion or revascularization stabilization of the patient, cardiac MRI and 2D echo were performed on the same day within 2 weeks of the acute MI. And the study variables are the type of MI, left ventricular diastolic volumes, left ventricular and systolic volume, MR, thrombus, ejection fraction, and GLS. So the inclusion criteria are within a window period of 24 hours been included who are clinically stable, and the excluded are who are patients with the cardiogenic shock or unstable, any acute mechanical complications, history of any valvular heart disease, non-ischemic cardiomyopathy, history of other comorbidities, and extreme age, extreme BMS. All these have been excluded. So by the sample size is 56 what I calculated, systemic banding sampling method. And this is in sagittal section bright blood imaging of an MRI of one of the patient in my study, showing the Eagle's IV, and the right side table showing all the volumes and ejection fractions, the other parameters. And the strain echo imaging in the same patient showing the volumes and the this is the apical 4-chamber view. There are other 2-chamber view and the 3-chamber view, which are on the average values of those, the GLS has been calculated. And these Eagle's eye view of all the 3 LV 4-chamber, 3-chamber, 2-chamber views and the average of the strain values. So coming to the results, correlation between the MRI and 2D echo findings, the end diastolic volume based on MRI was 89.891, and the mean end diastolic volume by 2D echo was 84.373, and the correlation of coefficient was 0.87. And in the end systolic volume by MRI was 55.332 ml per meter square, and by 2D echo is 52.518 ml per meter square, and the correlation coefficient is 0.855. And the ejection fraction is, mean ejection fraction by MRI is 39.27, and by 2D echo is 39.202, and the correlation coefficient is 0.924. The correlation between the mean EF by MRI and 2D echo, and the correlation with the GLS by 2D echo, sir. So MRI, the ejection fraction of 39.27, mean is the mean EF, and the mean GLS in all the patients is 12.05, and the R value is 0.771, and the 2D echo EF is 39. Mean EF is 39.202, and the GLS is the same by 2D echo, that's 12.05, and there is correlation of coefficient of 0.847. So this is the gist of all the previous studies which have been studied previously, comparing the different values of 2D echo and MRI. So Gardner et al. Have studied the wall motion scores and the echo has underestimated. Li Zhang et al. There was a strong correlation. Gowda et al. Has echo EF has been underestimated. In Schweiger et al., non-interval MI has showed poor correlation, but interval MI has shown good correlation. Martha et al. Showed that the baseline EF had poor correlation, and the follow-up EF in both the investigations showed a good correlation. And Kalam et al. Showed that GLS is a better prognostic value, and Carlson et al. Has showed that GLS is a better diagnostic value. So the summary is that so the mean EDV value was 89.891. The correlation coefficient of EDV is 0.8, and the ESV is 0.855, and the correlation coefficient of mean EF by MRI and 2D echo is about 0.924. So there is a strong positive correlation between the end-diastolic volume and systolic volumes and the ejection fractions by 2 modalities. Also, there was a strong correlation between the global longitudinal strain by 2D echo and the MRI, and that is 0.771. So, however, there was underestimation of the echo by values by the 2D echoes. So, the conclusions is that there is a strong correlation, positive correlation. So, the clinical database for CMR, although considered as a gold standard, is substantially smaller. So, what are the each drawbacks with each of the modality is that though echo, with echo we have got the intra-observer variability and also reproducibility. Depending on the window of acoustic window, maybe also may not be sufficient. And these are some of the drawbacks with the echo. But MRI being the gold standard with better temporal spatial resolutions and has got a better considered as a gold standard. Thank you, sir.
Thank you. A very nice presentation. Can I ask one question? Most important is, okay, you compared both. How whether MRI is superior in getting any additional information apart from echo?
Sir, apart from the echo,
In acute MI?
In acute MI conditions, because in acute MI situation, we cannot do less than 24 hours like that, because shifting of the patient, it will be more cumbersome. So maybe in getting the salvageability of the myocardium.
So the study is purposeless. That is the main thing actually.
Main thing, yes, sir. Yes,
so only one thing is, usually cardiac MRI assessment of viability is more accurate compared to the echo. That is the first purpose. Second one is in acute MI, always you may overestimate the non-viable myocardium in acute MI because of stunned myocardium.
Yes,
and especially we have seen so many cases of late gadolinium enhancements. So that will be overestimated in MRI. So where later we have seen the improvement of that myocardium, which was assessed as a non-viable. So these are the three important parameters, and of course, by comparison, what is going to achieve you?
Yes,
do not want to do MRI. What is the conclusion after correlation?
Yes, sir. And to what extent we have considered the MRI as a gold standard. But to what extent these echo values, can we rely on the echo values in comparison to the MRI values?
You need not do. First of all, you have to revascularize. That is more important.
That's most important. But actually, for salvageability, there are studies undergoing for the based on the GLS, a value below which the myocardium is not salvageable, sir. So I've taken this as the basis for my study.
Only they are coming beyond 24 hours.
Yeah.
And then severe dysfunctions. Then only it is useful. Otherwise, they're not useful comparing within 24 hours.
MRI is done routinely in your center, or it was done only for the purpose of this research project?
No, sir, it's done for the salvageability, mainly for the viable myocardium viability.
Is it done routinely in your center for all patients post-MI, or is it done for this?
Not routinely, sir. Only the patient.
For this project, you have done it?
For my prospective study.
Cleared by the ethics committee, or?
Yes, sir. Yes, sir.
How do they approve a test which is only for the purpose of research when the patient has to pay for it? You're saying it was only for the research purpose? No.
Yes, sir.
Why did the ethics committee approve a test like that where patient has to pay for your research, for your DNB degree? Okay.
Thank you very much.
Sir, all papers completed. I request Dr. Raghav Sharma, sir, to honor the judges. Lavanya.
I should thank Dr. Muralikrishna and Dr. Kapatisa specifically because they too, just now last minute we asked them the question to be judges. They very graciously accepted and responded. Thank you very much, sir.
Okay. Thank you, sir. So we'll start the second session now. I request everyone to, the chairpersons and moderators to take the chair. Dr. H.S. Somnath and Dr. Kamlakar, the chairpersons for the next session, and I invite the moderators, Dr. Gopalakrishna Garu and Dr. K. Srinivas Reddy Garu to be on the dais. Moderators, please take over the session. You are invited to the session.
Start చేస్తారా? Start చేస్తారా? We welcome Dr. Sujata for a live in box case, the left main intervention.
And Sujata doesn't require any introduction. She is a consultant cardiologist in Indus Hospital, Visakhapatnam. And she does a lot of complex angioplasties. And whether she's going to keep it simple today, let us see. Thank you. And I request all of you, we are here only to facilitate the discussion. I request the audience to, if you have any questions in the middle, please get up, keep your hands up, and you are free to discuss the case. And Sujata and myself, moderators, and people chairing the session, welcome it.
You can even SMS and WhatsApp page.
Good morning. So I chose this case for more discussion. I did not do anything dramatic in this patient. So I thought maybe it will stimulate some discussion and help us manage our patients better. You're controlling. Okay. So basically, I had a 56-year-old male who's a diabetic, hypertensive. He presented with anterior STEMI, and he presented with a window period of 5 hours. So basically, actually, he was taken up for a primary angioplasty, and it was the patient came in the early morning. So I'll play the angios meanwhile. So basically the right coronary is normal. So this was the angiogram. It presented early in the morning. So this was the angiogram. Sorry. So basically it's a 011 lesion. We have a proximal LAD occlusion, and the RCA is normal. So I want you to concentrate. The LCX is occluded. There's a proximal ostial disease of the LAD and an occlusion of the proximal occlusion of the LAD and the but the ramus ostial disease, and it's a very good size ramus. The RCA is normal. Team decided to. So at this point of time, patients present we see many of these patients presenting at different times of the day. So if it was in the morning, we generally tend to do an angioplasty. Though my team did a thrombolysis, I would like to ask the panel what you would do. would you go ahead and, but retrospectively, I thought I would do an angioplasty rather than subjecting the patient to thrombolysis. So what do you feel?
Yes. Sujata, the patient has already received thrombolysis, right?
Yes.
Plus, yeah.
I'm saying my team had thrombolized the patient, but I felt that maybe we should have done the angioplasty rather than thrombolize the patient. But this is the situation very commonly we see in the middle of the night and early morning, and you may not have everybody on the team on board. So what should you do? Is it apt to thrombolize such patients, or is it and then keep the patient, take up the patient when the patient is doesn't resolve the symptoms, or should you do the angioplasty, whatever the gear yourself up to do this angioplasty? So that's my question.
Yeah. There is no doubt. No, if depends on the facilities available. Round the clock, if it is there, always we prefer to take the patient to the cath lab, especially anterior MI. That there is no doubt about that. Short of it, if it is not there, obviously thrombolysis is the next. This is after angio, you are asking retrospectively.
Yeah.
So that anybody is guess what will be there. But anterior MI presenting, if you have the lab ready, everything 24 hours on-call people are there, definitely the patient should straight away go to cath lab. Otherwise,
patient with retractase, and we took up the patient for angioplasty the next morning. So what should we do? Should we go ahead and do surgery? The patient has got moderate alveolar dysfunction. So we assessed the syntax score, which was 31. So the SCS mortality you can see is quite significant even with the surgery. The risk of mortality about 2.7% and a very high risk of morbidity and or mortality of 22%.
So yeah, can I? So does the scores and the syntax scores, the trials which have conducted from which this derived have excluded acute MI within first 24 hours.
But after thrombolysis, I calculated the syntax score.
But,
but we should not do the scoring.
In an ACS, when you are talking the syntax score, I think they are not, the trials have excluded this sort of patient in the population. So getting the data from there and trying to extrapolate to data with the patient would have not have been included in those studies. It's a difficult ball game.
You're done in the second day, third day.
Yeah. I've done the next day morning. The next evening, we found that the patient has got again a 0-1-1 lesion. You can see the LED has opened. So the LED is open. We can see that there is a double bifurcation. The left main and it's 0-1-1 bifurcation of the left main. And we also have a LED diagonal bifurcation, which is a 1-1-0 bifurcation. So two bifurcations are involved. So we decided to do angioplasty in this patient because of the presentation of acute coronary syndrome, moderate alveolar dysfunction. So we ongoing came, so we decided to take the patient up for angioplasty. So our strategy, should we do a single stent strategy or should we do a double stent strategy? So we thought we would go ahead in view of the circumflex, the Raymond's disease. We thought we'll do a double stent technique. So basically, either a decay culotte or a decay crush, because LCH and the LPO are of similar size. We thought we'll go ahead with a decay culotte technique. So initially, we wired both the left LED.
Before
you better you stop in between so that some discussion will be there. So that
can you show another view in the caudal?
the angle between left lady LCX angle.
This is the then I did.
So now you are talking about bifurcation lesion, right?
Yes.
And the things have moved on a little bit in the last year, 2021. If you look at the bifurcation, now it has become more objective with the definition 2 criteria. If you look at the definition 2 criteria, you have a side branch. the lesion should be more than 70% in 10 millimeters in side branch and more than 70%. So if you take the circumflex as the side branch, so is it more than 10 millimeters? Hardly falling into that range. So it is a probably, if you don't image, we call it as a 0-1-1 lesion. Probably imaging makes it a 1-1-1 lesion. Either 1-1-1 or 0-1-1 are complex. And if you look at the EBC main data, they said below 6 millimeters itself, there is a subdivision of the 0 to 5, 4 to 7, and more than 7 inside branch. So up to 7 also we can take it. Probably it is a complex lesion, right?
Yes.
Do you agree with that?
Yes, yes.
So in the previous angiogram, is it a ramus or the
No, sir,
circumflex?
it is the ramus. The LCX is occluded.
So
If
we
it's
are
a small
ignoring the
LCX, it's occluded.
we are ignoring the
We're ignoring the LCX.
So a complex, you know, by now, probably a planned EDS is better.
Yes.
If you are doing a planned EDS, if you go by the decay.
Then another thing for juniors, say, how do you select the technique, tap or collate or crush by your angle or whatever it is? What are the criteria you want to select?
Basically, first thing I wanted to do was, because it's an anterior MI, the culprit is the LAD. I wanted to take the LAD as the main branch, obviously, and I wanted to stand from the left main to the LAD and take, because of a good sized circumflex, and I measured by imaging, which I'm going to show. It is the circumflex is 3.5 distally. So a DK culotte or would have been a culotte technique, or a DK culotte would have been a good option in this patient. So in acute coronary syndrome, many times we see this situation also. ACS patient, like anterior MI, I prefer to stent always the main branch first, rather than using the DK crush and doing the side branch, then doing the main branch.
Another point you have to keep in mind is there will be a lot of thrombus also in the vessels.
Of the LAD and the... Shall I run the OCT?
Yes. So you can see the OCT run. So because there was no predilation, there was not very good clearance distally. But as we come proximally, you can see that we got very good images. So basically, it's a very lipid plaque. You can see that distally, it's well visualized. And as we come proximally, predominantly lipid plaque, you can see that there is proximally come proximally. Yeah, there is a plaque erosion and a plaque rupture there. So predominantly fibrous lipid plaque, and there is a very huge left main. The left main is not involved. We measured the left main, it's about 5. So this is the left main LAD ostium. So you can measure the EL to EL here, and you can see it's almost 5. 4.8 is the thing. So then we decided to do a pullback from the circumflex. So we pull back from the circumflex, distal circumflex looks very good. And as we come towards the ostium, we also want to look at the plaque characteristics in the circumflex. So again, you can see it's a predominantly fibrous plaque. Come proximally, there are lipid components. So we decided to measure the length of the lesion of the LCX. So I already measured it is a 8.3 millimeters. From approximately it is from 30 to 20, and the length of the circumflex lesion is around 8.3 millimeters. So, and you can see it's a predominantly fibrous plaque, and you can see, can you measure the this 3.6? So it's a huge circumflex. It's suitable for a decay culotte technique. So the thing is now, I've decided to stent from the left main into the LAD because it is the culprit lesion. And the second thing is the circumflex lesion, surprisingly, is only 8 millimeters in length, and it is predominantly fibrous. Can you run the circumflex again? Only the proximal circumflex.
So you can see that it is predominantly fibrous. The least area came as 1.6. And there is not much plaque rupture or a vulnerable plaque in the circumflex. So there are two options. Should we go ahead with an elective double stenting or should we do the provisional stenting? The important thing is provisional stenting is the way forward. It is rather a philosophy that has been enunciated by the EBC consensus and by the EBC in the EBC main trial. What they say is stent provisional, stent the main vessel, and our patient fits into the EBC trial because the length of the circumflex there, the length of the side branch in the EBC main is only 7 millimeters. So the length of the LCX is only 8 millimeters in our patient. So he can qualify for a provisional strategy and we can do. So meanwhile, the patient developed chest pain. So we decided to wire the LCX and we decided that because it is the culprit, first let us fix the LAD and think about the circumflex later in view of the presence of chest pain. We wired the diagonal also.
You can take the audience opinions also, so we'll have some discussion. So you want to do a provisional stenting because the circumflex size length is not very important. So any others want to have any opinion? Sharma?
It's the
Circumflex is closed.
It's ramus. She's saying circumflex, but it's ramus. You understand it as ramus only.
I neglected the small and occluded. So.
Sujata, you said the patient developed chest pain on the table. I would image this patient only after pre-dilating the LAD. I wouldn't put a PCT catheter in, producing ischemia, which is a tight lesion, and you don't have any clue what is the distal landing zone. And we have problems with the stent expansion. So we have a 5 millimeter artery. Whatever the major stents you take, you need to take a 3.5 or a 4 millimeter stent to get to 5 millimeters. Any stent that is less than 3 or less than 3 will not go more than 4.1 or 4.2.
Yeah.
So if you are looking at the left main at 5, I would have done imaging after the dilatation of the LAD. That would have prevented two things, the ischemia on the table,
yeah,
and not make you hurried in taking a decision. And number two is the distal landing zone, to look at the distal landing zone, which is ideal for land your stent, and also the reference diameter, which is very important. I think that's an important criteria. And the second point I want to make is, in the EBC main or any other trial, whether you take a trials of DK crush trials, the imaging has been done in only less than 40%. And the length of the lesion in the side branch is not based by imaging. It is based by QCA only. So you are saying that I measured it by imaging and it is 8 millimeters. No. If you go by the trial data, you have to use the data that is measured by the trials, that is QCA. And if you look at the EBC main, they have divided subgroup analysis, the length of the lesion. If the length of the lesion is less than 7 millimeters, then it is beneficial to be a provisional. If the length of the lesion is more than 7 in the patients who have done the imaging, then EDS. So this is in the borderline zone, 8 millimeters.
I have two questions, Sujata. Number one, can this procedure be done without imaging? Because patient is acute coronary syndrome, we have to finish it off quickly. That's first thing. Second thing, most of these patients will have comorbidities like renal disease and all those things. Instead of OCT, what is IVAS can be a better option in this particular situation?
Sir, first I wanted to answer Dr. Gopal Krishna's question. Why didn't you pre-dilate? Basically, it's an acute MI situation. I don't want to do a lot of dilatation. I wanted to keep, in fact, I went ahead and did a direct stenting. That's one. And sir's question that we can do without imaging. Yes, it can be done without imaging, but most of the data nowadays says that we do, with our experience now, we know that it is 3.5 stent and we are going to do a 5 in the left main, even without doing the imaging. So I understand that it can be done with without imaging, but the data is pointing out towards a significant reduction in mortality with imaging in complex lesions, especially the left main.
Acute situation also, you have trials.
Acute situation, the data is more limited because in the trials, the ACS patients are very few. If you take the EBC main, it is only 40% and STEMI has been excluded. All trials have excluded the ACS population.
I'm telling only in ACS patients, can we avoid imaging so that we can finish it off fast?
That's
Yes.
right. Yeah, you can do it amazing, but you look at the guidelines, the 2018 ESC ATS guidelines, they say IVUS is 1A in bifurcation, whereas imaging, they don't say IVUS or OCT is 2B. That's what the guidelines say, 2008 and 9.
Regarding
Complex bifurcation. Yeah, I mean, DK crush trials have included, she said in EBC main 40%, in DK crush trial has included 60%.
I put up the EBC main and the DK crush to compare both the trials.
IVUS is
So,
only 40%.
The IVUS use is only 40%. And you can see the upfront to the crossover to the second stent from the provisional stent in the EBC main is only 22%, whereas in the DK crush, it is 41%. DK crush, they have divided into simple and complex bifurcations, but EBC main, there was no such classification. You can see the event rates are totally different, whereas
in EBC main, there is a classification. The main should be either 111 or 011.
I put it up, sir. That I have put up. It's a 111 or a 011 lesion. Most of them, 90% are 111. So, and the clinical endpoints are different, the endpoints. If you see the EBC main, it is death MI and target lesion revascularization, whereas DK crush, it is predominantly the target lesion failure. So the event rates in DK crush are less than in the EBC main. But the EBC main population was older, the mean age was 70, and the endpoints are totally different. But the thing has EBC main published recently has predominantly enunciated the philosophy of provisional stenting.
one moment.
Can you project?
Am
the
I
video?
audible? Yeah, one question to Dr. Sujata. Do we need to predilate to assess the lesion morphology? I mean, like to quantify the lesion?
Yeah, in
The
IVUS,
reference diameter
Right.
means the proximal to the lesion and distal to the lesion. That is the reference diameter.
yeah, it's important when you are stenting to know the distal reference, because the stent diameter depends on the
Yeah,
distal
distal,
reference.
you take it as a normal. I mean, normal to normal. When you're going to stent, it is
No,
normal
the
to
size
normal.
of the diameter.
Size.
Yeah, that if for IVUS, you don't need it because you don't need the contrast. For OCT, the contrast has whatever the
I
saline,
think
whatever
time
you
is up.
have-
We can
has to
finish Sujata quickly.
Okay.
And then because the lesion, so we decided to stent the left main to the LAD. In view of chest pain, we decided to do the main branch, the culprit first. So we wired the diagonal, we stented because we did direct stenting. We have seen on OCT that it is basically we dilated the stent 3.5, 38. The patient significance in 512. We did a pot from the left main diagonal. We did with a 3.7512. We did a pot from the left main, which I chose a 5.6. So we did a proper pot. So this is the pot balloon. We dilated the proximal portion. The culprit is the LAD. First, treat the LAD properly. So I decided to do a dot distal optimization with a 3.512. Basically, one thing before doing the dot, I tried to wire the distal strut. So wiring the distal strut, I did an OCT. So the OCT shows a well-opposed stent.
but at the level of the between, you can see at 20 that there is some under expansion of the stent. Show at 20. So though the MSAs are above 6.5, so in view of the 20% diameter stenosis compared to the distal, so we decided to distal optimization. And you can see next, show the angiogram. So the distal optimization with a 3.512. After the distal optimization, we decided whether to do the circumflex or leave it alone. So I decided to look at the ostium of the circumflex. Basically on OCT, this is prior to optimization. So now the question is, should we do the circumflex ostium? So the circumflex ostium, basically, can you show the pictures of the circumflex ostium on angio? So we decided to look at the 3D bifurcation view of the circumflex. Circumflex, as you can see, is wired through the distal strut. Very good position to do the circumflex ostium. So what we did was, the ostium is open. So easy thing is to put a 3.5 stent into the circumflex from the left main into the circumflex and do the DK culotte, the pot, and then the kissing and the final repot and come out. So, then when we looked at part of the stent and we saw the haziness in, basically what we thought was, should we do at this point, should we stent the second artery or should we leave it? So that was the question. So what the proximal part of the stent, because it looks after the dot and after removing, so this is ostium is open. So is you want to do the circumflex now or would you leave it?
I mean, I would leave it, keep it simple, because the ostium is not covered by the stents. If we believe the imaging, I would leave it.
This is the question. So basically what happened was, as we were doing the case, we noted that there was a distortion of the stent proximally. So we had to do a report. And so basically there was some, and then the strut is pointing towards. So this is the thing. So we had to redo the pot proximally because of some distortion of the stent. So we thought keep the main branch open and keep the side branch open, and we left it with provisional stenting. So
you didn't do the kissing?
I didn't do the kissing. So though the EBC main, the kissing was done in 89% of the patients. According to the data, there is no this thing of kissing. So what you can see the data, I'll show the data. So this is another thing I wanted to tell. I show the correlation of the side branch ostium. So when to do the side branch. So you can see the data is more with the side branch. Anyway, if the side branch length is less than 5 millimeter, the event rates are very less. More than 10, yes, we are doing it. Between 5 to 10, the reasons it is intermediate. And also the predictors, independent predictors of target vessel MIR, long side branch, true bifurcations, vulnerable plaques at the polygon.
Great case. Thank you, Sujata. Thank you for presenting a nice case to make it and kept it very simple. I hope the patient has a long-term good follow-up. What is the follow-up for him? How many days?
It's 3 months, sir. He's doing good.
Yeah, one last point. Can you tell me the difference between DK crush and DK culotte for the benefit of the...
So DK crush and culotte, there is one extra step, that is the one more kissing is there. That's the, so before implantation of the second stent, we do a kissing and then do the second stent implantation.
Thank you.
Are you doing more DK culotte now than
yeah,
DK?
I mean, we do DK culotte. I will keep it in a very simple fashion. You do provisional kissing twice. You do the one branch, you do like provisional, you do the kiss. Then second branch like provisional, you do the provisional, do a parted kiss. So you are doing provisional kiss twice. That makes it decacolot very easy to understand.
Okay. Can you just point the last slide and we'll go.
Final thing.
So I think
Next, Bizu.
so. I think for those of you on Twitter, hurdle is the word way forward. So we'll go back and keep it simple.
Okay, we'll go to the next session by Dr. J.S. and Murthy. Cardiology in Crossroads. It's a Lalita Super Specialty Hospital oration. It is a virtual, I think. It is a virtual program.
Good morning, Dr. Jason Murthy.
Yes, sir. Good morning. Am I audible, please?
Please, before you present your oration, we have somebody who is going to introduce the speaker.
You can introduce.
Good morning, Dr. Jason Murthy.
Yes, sir. Good morning. Am I audible, please? Yeah.
Before you present your oration, somebody who is going to introduce the speaker.
Good morning. Am I audible, please?
Before you present your oration,
This is on. Hello. Murthy garu.
Yes, sir. Am I
How
audible?
are you?
Fine, Somnath.
Good morning.
Good morning, Somnath.
Dr. Somnath, yeah.
Yeah, I know. Am I audible, Somnath? Am I audible, Somnath?
We'll get back to that in a minute.
Am I audible? Fine. Good morning, Somnath.
Yeah. Yeah, you are visible also. You are looking good. Hope you are having a good.
Nice to see you, Somnath, at Guntur from Jaipur.
I know Dr. Murthy garu for a long time. Even now we are in touch. And we were colleagues in Perambur Railway Hospital. In fact, he was senior to me in cardiology there. So he has been there from the beginning of cardiology department in Perambur Hospital, whereas I joined a little later. And he has been with Dr. T.J. Cherian, then later with K.M. Cherian, Girinath and all, he has been there. And then cardiology side, you might have heard of Dr. K. Abraham and Dr. K. Narasimha Reddy garu, you know. He did his MD medicine from Chennai only. Then later he was working in the cardiology department as a physician. He was doing even CATs and all before anywhere it started. Till afterwards, he did his DNB from Perambur only. Okay. And then we were colleagues for a long time, and we were involved in doing both congenital and acquired. And we grew with interventional cardiology later, starting with POBA onwards, stenting, everything. And he has been doing all sorts of complex cases. And then he was a good academician. He used to teach us also. And he's very good hands at interventional cardiology. Later, afterwards, he resigned, and along with Dr. K.R. Balakrishnan, who is a well-known pediatric cardiac surgeon, he shifted to academics in Ramchandra Medical College and teaching. Plus, he was a consultant cardiologist. Later, he became dean of Ramchandra Medical University for quite some time, and he has trained a lot of people and a lot of students all over India. And he has been a DNB examiner, and he is assessor for DNB courses also. And Anything else, and more than anything else, he is one of the best human beings. Very sweet, and how he has come up in life is very simple, straightforward. And I don't think he has got any miss in his life, professionally or otherwise. He is one of the sweetest persons and very good human being. That's what is the main thing which counts, and that's how he has come up in life, being so good. That should be. Anything else I missed, Murthy garu? You can. So nice to meet you.
It is repeating.
Can we start?
You can start off, I think.
Respected chairpersons, Dr. Kamlakar, and my long-term colleague and friend, H.S. Somnath, moderators of the session, Dr. Gopalakrishna Garu and Srinivas Reddy Garu, and Dr. Raghav Sharma Garu of APCSI, and members of the organizing committee. I would like to thank you all for bestowing this unique privilege on me to share some of my thoughts through Lalita Super Speciality Oration. I thought, as Dr. Somnath was telling, that just go through the bird's eye view of what was cardiology in the past, what is cardiology now, and what is going to be in the future in the hands of the next generation. Many of you are aware of this iconic structure, Arc de Triomphe in Paris, to mark the victory of France in the Second World War. Today, cardiology has seen many milestones. As we have just heard, some of the complex procedures are being done. I had divided the subject mainly into three categories: the past, present, and what the future holds. Literally, we are in the crossroads because many of us are confused which way to take forward. I thought briefly I'll go to the past. What has happened in cardiology? Dr. Rastum Jan Vakil has started in Mumbai, and Dr. Sujay Viroy in All India Institute of Medical Sciences. The echocardiogram came in the beginning, in the middle of 1977. The first one came at KEM Hospital, Mumbai.
Sir, we cannot hear you, sir. Murthy, sir.
Yeah, are you now? Are you hearing me now? Hello?
Yes, sir. Yes, sir.
The echocardiogram came in the beginning, in the middle of 1977. Yeah. The first one came at KEM Hospital, Mumbai.
We cannot hear you, sir.
Now? Now am I audible? Yeah. Echocardiogram.
Sir, are you on two?
Yes, audio on.
Sir, there is some echoing, sir. Only one laptop, I think, if you operate, it is here.
Yeah, we switched on to other laptop. Only one is operating.
Start this.
Sir, are you on two?
Hello?
Sir, there is some echoing.
How now? Now?
So there is some problem. I think we will go for the next session, and after that session, should we continue, sir?
How is it now? How is it now? Is it better?
Sir, there is some echoing going on, sir.
No, because it's a studio. There's no echo from our side. It's absolute telemedicine studio of Ramchandra University. Now?
There is some echoing going on, sir.
No, absolutely quiet here. We are quiet here. Absolute telemedicine studio of Ramchandra University. Now? One system is on.
Because of this technical problem, I think instead of wasting the time, we'll go to the next session and we'll come back once things settle, because I think this internet connectivity is also a problem. So the next topic is by Dr. PNS Harita, vascular closure devices need of hour. I request Dr. Harita to come and start the proceedings. I think Dr. Harita needs no introduction. She was the thing, everything behind this conference going on so beautifully. Over to Harita.
Thank you, sir. Sorry for the inconvenience that has happened. My topic is on vascular closure devices. So, which many of the centers now they have started using these closure devices. Recently, since 3-4 months, we started using ProGlide after seeing the TAVI cases and EVAR cases. Next. So why should we go for these vascular closure devices? So most of the times we do see complications post-procedure when we opt for the femoral access. So the commonest thing being the hematomas. So, and retroperitoneal hematomas, AV fistula. We have seen 2 cases of AV fistula, thrombosis and rarely infection. We have to go for surgeries also. Next. Next slide. So it increases the hospital stay. Patient may require blood transfusion post-procedure, which can increase the rates of stent thrombosis. Patient needs surgical repair, and there can be discomfort and increasing nursing time. And so much of the staff, so many staff should be involved for the procedure. Next. So for whom we have to opt for these vascular closure devices. So these are all female patients, obese patients, those who have the risk of hypertension, elderly patients, patients with AR, and those who are having coagulopathy, and patients with presence of distal peripheral vascular disease, and those with CKD, and those who are on anticoagulants and antiplatelets. So why we are not going for these vascular closure devices is because of the cost, predominantly because of the cost, and routinely they are used to do the manual compression. Next. And we do feel that there is the procedures are complicated and it is very difficult to go, and there is a big learning curve for these closure devices. So these are the goals. So early ambulation is the first goal. Next. So what are the methods of hemostasis? So there are 2 types of vascular closure devices, active closure and passive closure. Next. Manual compression, we all know about it very well. So passive closure, it increases, it assists and enhances the coagulation, and there are some techniques of putting pressure and like clamps, and procoagulant devices are designed. Active closure is with closure with suture or clips. Next. So these are the hemostasis methods: manual compression, assisted manual compression, hemostatic patches. They are available now. We do use sometimes, but they are very superficial, not very much useful. And now the recent trend is the vascular closure devices. The device is inserted into the body of the at the femoral arteriotomy site, and there they deliver either the material or the sutures. Next. So this is manual compression. Next.
So what are all the prerequisites to use the vascular closure devices? So the puncture should be below the inferior epigastric artery and above the profunda femoris. So it should be exactly at the common femoral artery in the upper 2/3 of the femoral head. So there should be an ideal puncture site in the common femoral artery. We should not do the Seldinger technique, and there should not be calcification around the artery. And it should not be a high arteriotomy or a low arteriotomy. And the diameter of the common femoral artery should be more than 4 millimeters. And before doing closure device, using the closure device, we have to do the arteriogram and delineate whether it is in the common femoral artery or not. Next. So these are the contraindications for using the vascular closure device. Next. So where we have to use these closure devices means there is a large scope in the interventional cardiology and interventional radiology while doing EVA and neuroradiology, early ambulation of the patient and during vascular surgery. Next. So these are the devices. So the first device is a passive closure device. It is an extravascular device, and there is a small disc, collapsible disc. While withdrawing the sheath, this disc adheres to the arterial wall, and after we ensure that it is completely adhered to the wall, we release the thrombogenic resorbable collagen patch. So we have to give a few minutes of manual compression after the deployment. Next. So MINX is it is apparently a very easy procedure. Through the sheath, we have to keep this device, and while removing the sheath, we have to inflate the distal balloon. The balloon will occlude the arteriotomy site. And through the sheath, we will inject this material, which will slowly resorb over time. Next. For these procedures, there is no need to exchange the sheath. So this is same. Next. So these are the vascular closure devices. Angioseal. Angioseal, it comes in 6 French and 8 French sheaths. Next. So it is used for active closure to attain the rapid hemostasis, and we can mobilize the patient after 1 hour. Next. So there are studies which say that the risk with these devices is less and the primary endpoints are significantly met with. Next. Next. So these are the steps of deployment in Angioseal, wherein we will deliver. We have to locate the arteriotomy site, and we have to introduce the sheath of Angioseal, and we have to anchor the arteriotomy site. Later, we have to release the collagen plug, and the small thread, the residual suture, we have to cut it off. Next. So it gets absorbed in 90 days. Next. So as it is in all other patients, this is also useful in the high-risk subset. Next. So in this, there is both an anchor and a collagen plug so that it adheres tightly to the arteriotomy site and it narrows the arteriotomy site. Next. So the next one which we commonly use is the ProGlide. It is the Perclose technique. So in ProGlide, there are 2 needles that will insert into the foot pads of the device post procedure. Next. While doing the procedure, there are 4 steps. We have to locate the artery, keep the ProGlide accurately into the artery, and then we have to introduce the needles into the artery, and they will go into the foot pads. While we withdraw the device, we will introduce the needles into the artery, and there are threads, 2 threads that come out of the device,
And we have to, that creates a knot inside the artery and decreases the size of the arteriotomy. Next. So star close is one more device. Next. So the complications with ProGlide, AngioSeal and star close, each one has its own advantages and disadvantages. Next. So these, each one is a different entity, de novo, like they are not having, one is with this is a introducer sheath, wherein the sheath is having a small intestinal submucosa of the pig that is, that lodges at the site of the arteriotomy, and while removing the sheath, it gets hugged onto the arteriotomy site. Next. So in summary, patients considered for deployment of VCD should undergo a femoral angiogram before doing the VCD. Use of VCD is reasonable to achieve faster hemostasis, shorter duration of stay of the patient and improves the patient comfort. But still we have to weigh against the risk of increased complications and also the cost of the procedure. Thank you.
What is the general expenditure for this type of devices? What is the best device for us?
The ProGlide we are using, sir.
Regularly you are using?
Yes, sir. It is coming around 18,000.
18. Achha. So only for these TAVI you are using?
TAVI and EVA, sir. Some PCI cases who are obese, we are using the femoral artery now, sir. Yes.
So that is very user friendly and the cheapest.
There is some learning curve, sir.
Oh.
If it is done means it is very easy.
The training is given by the company?
On table itself, bleeding will stop and it is, yes, sir, company guys. Abbott.
Madam, are there any complications of these devices reported?
No,
Or
I didn't see any, but sometimes we may fail in doing the procedure. Like that bleeding may not stop. We have to go for manual compression.
one of my colleagues,
No need, sir. On table itself, bleeding will arrest.
we have AngioSeal at our center. One of our colleague who was using it in his previous institute told if we apply more pressure after closing the vessel with the device, if we apply compression unnecessarily, it may embolize distally.
There are case reports that pad is there in the angioceal that has embolized distally into the popliteal artery.
Yeah, I've used it. Angioceal, I've used plenty those days when we were using 8 French and 7 French. And it's fairly simple, and that compression you should not press too hard. It nicely stops. Immediately it stops, and that thread is there. You can keep it till you are very sure nothing has happened. Then you can cut it. Otherwise, you have that control on that. You cannot pull it back too much hard. Also, it comes off. So it should sit on that surface. The little technical details, but once we started using radial anyway, we stopped using that. Then even femoral also daytime angios, we used to use 5F catheter and all for that after 3-4 hours anyway, without any angioceal also we started here. But nowadays, because of interventions, bigger catheters, those places definitely. And old people, calcified arteries, whatever number you compress, then they will not stop. Those are the areas, otherwise very limited use nowadays.
Commonly used vascular occlusive devices, which is cost effective, is AngioSeal. And AngioSeal is very user friendly, number one. And whenever you are using 8 French sheath for complex interventions or 7 French sheath, you can close and you can achieve very nice hemostasis. And most important is, as Madam beautifully depicted, the common femoral artery is the one which between the anatomical points of inferior epigastric artery and profunda bifurcation point. This is the thing. I think actually the traditional teaching of crease, below the crease, puncture, all these are nonsense actually, to be frank. So that is for learning purpose. But you have to do under fluoroscopy whenever we are into for 5 French sheath, okay, it is immaterial, whether you puncture superficial femoral or a profunda, deep femoral, immaterial. But whenever you want to select a complex with a large bore sheath, minimum 7 to then above 7 plus, then you have to see the fluoroscopic guidance, and femoral head is the one most important. And recently we are practicing ultrasound guided micropuncture needle technique, where it will almost totally negate the vascular complications of the femoral vessels, which we are practicing now. And of course, a little bit cost 12,000 to 15,000 extra. So angiolysis is cost effective, 12,000. Next, Proglide. All the structural
we have performed almost, if you are not comfortable with the ultrasound, what we do is arterial, we will put scale anyhow for tower we require a basic technique and one more thing, for whenever we are using for 7 French, 8 French, even for a tower also, even one proglide will arrest the bleeding sometimes. Without checking after one proglide, sometimes if you not the second proglide, it will result in the femoral artery narrowing. This is very, very important. And once the second, if you ligate the femoral artery with the second proglide, and again he will develop the femoral artery obstruction. So after proglide, again you check if the bleeding is stopped and do the contralateral angio, and there is even mild residual stenosis of the femoral artery, then one proglide will happen. The second proglide without not, we can just take it out from the groin.
Any other from the audience? Sharma?
Yeah, I can use multiple times this angio, especially the most important, it's very user friendly. You can use person walk, then after 8 sheet. But sometimes want to don't press it too much. That's most important because we are anxious that we are
Not here.
Don't press too much because there is underlying of this. What he says, they are using more than 7, 8. That and unfortunately, angiosis doesn't come beyond 8. Roadway requires once you see it.
Okay, as the time is over, we'll conclude this session. So thank you very much for everybody and for the speakers. Excellent discussion. Thank you very much.
I can use this. How to change?
So we have connectivity again with SRMC. So we'll go back to the super specialty hospital operation, cardiology, crossroads, Dr. Jason. Dr. Murthy, can you hear us? Are we audible?
APCSI.
Yeah,
Sorry, sir, we are not hearing you.
not able to hear you.
I hope I hope you are hearing us. Hello?
Yeah, can you hear us? Hello? Can you hear us? Can you hear us? Hello, we are not hearing us. Hello? Something wrong.
I'm able to hear your voice there, sir.
There.
And next topic will be debate in
They are talking something else. Okay, Giggle.
To start this session, imaging coverage.
Hello? Can you hear us? Can you hear us? Hello? Good morning. Can you hear us?
Good morning, everyone.
Dr.
And
Soumnath, can you hear us?
thanks for the organizers and thanks, Harita, for calling me for this talk. And I thank my teachers, my inspiration, Dr. Krishnan and my professor, Dr. Rajshekhar, who is here, and of course my senior colleagues. And with this, I'll start on optical coherence thermography. So, I put it as
No, they're having some other schedule. Can you hear us? No, they're starting some other paper.
They should give you the audio. They should, whenever they want to, whatever they talk, they should give the
Link. No, switch off and put it.
दरवाजा बंद करके करो, आवाज नहीं आना चाहिए उसको बंद, दरवाजा बंद रखो। मेरे बाथरूम का एक लाइट भी चला गया।
can see the echoing shadowing, moving, mobile shadowing. There is a disengage the guiding gate that will make the left main, especially the ostium. And of course, is important in understanding the block morphology. Especially the calcium is there, you have to use the aggressive block modifying devices. And this is one of the case review, 15 years old patient, patient underwent LED angioplasty, premium DES. This patient admitted again in the hospital with new symptoms.
mid circumflex first. The next 3.5 to 16 was implanted in the left main, the direction of the LAD covering the ostium of the circumflex. Then this is followed by a special wire was selected to cross the cell of the stent entering the circumflex, and ultimately the balloon was inflated to open the circumflex ostium, and you put the T-tap technique. You cover the circumflex ostium after adequate rotablation of the calcium in the circumflex to get a good result. So then followed by proximal kissing and followed by part, ultimately to give the good result. These are the steps which you do whenever you want to do the provisional with T-tap. This is the final result. With IVUS, you get a good area of left main, almost to the 8 millimeters, square millimeters. Then the most important CTO, how the IVUS is useful, especially three important steps is important. First one is a proximal cap puncture. This is the patient, you present with infraval MI with a LAD total occlusion or RCA total occlusion, that is thrombotic, and angioplasty primary angio was done to right coronary artery with a good LV function. So this is the one. You can see the LAD almost is the stumpless occlusion where you are unable to identify the cap. And as if LAD is continuing as a diagonal, you can see, visualize. And so this is, you can see the proximal cap between the 6 o'clock position and 9 o'clock position, you can appreciate. And then by means of the crusade catheter, which is a dual lumen catheter, you put the wire in the diagonal, and then with the over the port, that is a central lumen, you can pass the Gaia second. As when is a total occlusion, we directly have taken to conserve the material also. And then with the help of this one, you punctured exactly. You can see, you can appreciate this one. You can appreciate the wide shadow. And then exactly true lumen to true lumen, you can identify the revascularize the LAD. So at this, the IVUS always scores whenever the stumpless occlusions in the CTO. And then second case also, it is almost a stumpless type of occlusion. The patient presents with angina with a single vessel disease and attempted PTC LAD previously failed. And then this is the one, by means of retrograde wire, we keep as a wire marker. And then with the help of real-time IVUS, for real-time IVUS, 8 French guiding catheter you have to take and then put the wire in the side branch and keep the IVUS exact at that one with the fine cross help and Gaia second penetrate the cap, and ultimately we revascularize the LAD and with a good result. Then second important is IVUS guided reverse cart. This is also important, especially whenever you're doing a complex high grade CTO. This is important. This patient is a diabetic hypertensive, already underwent angioplasty LAD, and RCA CTO was an index lesion. So it is a dual lumen dual angiogram, which was showing a RCA mid segment CTO, and we have taken with the help of the Corsair and then the hardwire, we cross the CTO, but still the wire is in the subintima. So we do not want to take the chance, antegradely prepared. Then retrograde, we put the wire, and then ultimately, sorry, you can see the retrogradely we cross it, and ultimately by means of the reverse cart, but means antegrade balloon, we dilated, retrograde wire we have used, and these IVUS, both wires you can see as a, you can see they are in the true lumen. Once from the subintima to intima it came, and once we confirmed by means of IVUS with the reverse cart, then externalize the wire and revascularize the RCA. So this is the entity where IVUS definitely has a role, especially IVUS guided reverse cart we can do. And another important, this is a new concept by Okamura. Actually, he 3D wiring of CTO, especially when you are wiring the CTO. Now the terminology was changed, intra-plaque or extra-plaque rather than intima subintima in CTO terminology. This is the one he coined. So this real meticulous time spending will, should be there. And usually in the IVUS, the shaft will be seen as a dot with a backscatter, whereas the tip will be seen as a thin line with a backscatter. So this is the one, usually this applicable 3D application, 3D wiring in the mid segment of right coronary artery, last madam, it will be there. And of course, here you keep the IVUS in the intra-plaque, and then you keep the second wire. Depending on second wire in the space that is intima, you have to correlate in the brain both sagittal coronary planes of angio and axial sections of the IVUS. So this is the one. Whenever this is at the tip, you can see the tip of the wire. Then as the wire you are entering to the distal cap into the true lumen, almost this is the IVUS is in the false plane. This is in the inside the block. By means of counterclockwise and clockwise rotation, the tip direction, tip distance to the true lumen you can identify, and ultimately you can enter into the true lumen, which is a collapsed lumen. You remember this is a true lumen, which is a collapsed one. This is the wire. By means of counterclockwise, depending upon the orientation, or clockwise, you can enter into the lumen, whichever nearer.
Check.
So with this, I will end this section. So ultimately, if you have OCT enlarged by
check
high
one,
resolution, it is always better and best. But exceptional situations, you have to use the intravascular ultrasound. And second is the cost effective. And another important thing where OCT is very sleek. Sometimes in calcific lesions, you can't push. We have seen so many times, in spite of plaque modification, depending on angulated calcific lesions, you can't do the OCT. In that way, OCT is unable to navigate, then you have to take the IVUS. Definitely IVUS will pass through after a lesion modification. So these are the situations. Whenever the contrast is a limitation, take IVUS is better, because still it is a saline contrast OCT is still in the developing phase, not an established one like a contrast OCT. The second important is the iotartial left main. Always IVUS is better. OCT can't displace because it needs a lot of forcible injection to displace the blood. So iotartial lesions limitation. Third one, CTO. Yes, IVUS plays important role for guidance actually to your hardware and your wires you can navigate. And of course, fourth one, where the OCT, it can't negotiate across the calcific angulated lesions. Then because it has sleekness, we have seen so many times in the practically, then IVUS after adequate block modification, you can negotiate and give the optimal image. Thank you.
Thank you, Dr. Kapati, for your excellent talk. Both speakers highlighted as how important coronary interventions, how this co-registration of both with IVUS and OCT is the key factor, not by just mere angiography, knowing the results and ways of the intervention. So many questions you can take, one or two couple of questions.
Ravikant, you can come on to the dais.
Just to add, so definitely there are few things which are tough with OCT. I have seen practically if you try to do 5 times in a patient, the 5th time the catheter will be broken. It is very tough to negotiate it because the pushability is not there, and that stiffness is not there in the catheter yet. So what I do is usually, and there is nothing like G here. If G people are using extremely less, you can only do one run, and then you will end up with not doing the second run. So that is why if you are intended to do 4 or 5 runs, you are planning for 4 or 5 runs in a bifurcation lesion or something. So try to do it with one is 7 French catheter anyway would be there. Another thing is you should use a guide liner to deliver this OCT. And as Dr. Kapardi was saying, if it is a calcified angulated lesion and very pinhole kind of situation, unless you dilate it properly, you cannot negotiate the OCT catheter in. Again, the guide liner would help in delivering the OCT catheter. And I would put it this way, I would try combining both. For example, aorta-ostial lesions. Aorta-ostial lesions, I am in left main lesions, for example, left main bifurcation you are doing. So there is an ostial lesion as well as distal left main and everywhere. So if you are trying to do along only IVUS, you would be not getting benefit of a OCT. But if you are trying to do only OCT, you would end up not doing well at the ostium. So combining the IVUS and OCT in this kind of situations where you will have an advantage would also help us, but I don't know the logistics, how it would be here. But in present situation, a lot of people are affording this imaging if you explain them well. So combining the IVUS with OCT would be one more thing rather than fighting against each other. I think combining both in particular situations. And saline contrast, I have given total saline in without a contrast at all in 5 cases till now, and I had a good imaging result. And as you were telling, the problem would be only where you have a large vessel. Large vessel, I couldn't clear the blood properly. But if it is a 2.5 mm, 3 mm vessels, it would happen. And I was forced to do for the first time. Actually, it was in a patient where the creatinine was 4.5. And there was a restenosis happened within 6 months, and it was 5 stents inside. So I tried a saline contrast in this patient, and I succeeded in imaging well. So that is why, that's how I started doing saline as a contrast, but I am not doing it regularly. It is only in patients where this kind of situation happens.
I want to add 2 points. I also tried saline, but the image is suboptimal. Decision making is difficult. And second important thing, if you want cost effectiveness, IVUS is always better. You can use infinite times, actually, G catheter.
Ravikant, in acute coronary syndromes, IVUS when to differ the stenting depending on the morphology with OCT. When to differ the stenting by OCT morphology in imaging in acute coronary syndromes.
I can one thing, I have done only one case in acute coronary syndrome, AOCT. As far as possible, I try to come out as early as possible without doing anything. So in that particular case, there was a plaque erosion and lot of thrombus, and we could clear it and then put a stent properly. But my intention of doing it in that particular patient is, he is an youngster, around 25-year-old. So I thought if there is something only thrombus with no plaque, I would come out without stenting. That was my intention. That's why I've done that particular case. But in any ACS, I try to minimize imaging as far as possible. I don't know the take of others.
Dr. Sivananda, for you, the important one is, as we know, the ACS is caused by rupture, erosion, and of course, scad and nodule. In small percentage of young patients where haziness will be seen on the angio, if you do the OCT for those patients, just plaque erosion, that will plaque erosion means you won't see the rupture, whatever the thing, just only some adherent small white clot will be there. So in those patients, you can confidently, you can live without any stenting, and definitely long-term results will be very good. And vessel has its own repair in the natural mechanisms. Only thing you have to give some 2B3A blockers along with an aggressive these Procedural, so that the patient long-term MACE rates will be also less.
Ravikant, last question. For the landing zone of the stent, usually you are shown in the slide less than 50% of the lipid pool and less than 50% of the plaque burden. But usually people say normal to normal. So
as far as
do you practically follow the landing with less than 50% of the lipid pool and
no, actually, as far as possible, normal. But you can have a diffuse disease, then you need to search for the landing zone. There you end up this way. So a lot of times I do like this in especially diffuse disease. See, for example, nowadays we are putting 2.5 into 48 stents, and you have a lesion down as well, extending into distal LAD and kind of thing. So in this case, I am doing that such a way, less than 50% lesion.
I want to answer Dr. Seman regarding your question. Most important, as Dr. Ravikant told, healthy is okay. But suppose in diffuse disease, whenever you are landing, what he told is correct, but only vulnerable plaque you see. Whenever you are landing, if vulnerable plaque, don't land in that one, even though 50% plaque, 50% normal is there. Suppose if the fibrous plaque, yes, you can land. Okay, that is the one. Vulnerable plaque, don't land there. Again, it may produce itself again acute coronary syndrome.
I prefer OCT because I was well trained in OCT and doing OCT more. I will also suggest OCT only. If you want, ideally for a doctor, if you want a good thing, you have to do only OCT. Except these exceptional situations where you have to use IOS. Because you can't take a decision with natural black and white movie same. Eastman color and colorful movie is different. Everybody knows.
I thank you, moderators and chairpersons. We will have the Dr. IAV Prasad Lal oration next, but I request the chairpersons and moderators to remain seated for Professor Dr. Vijay Bang, who will be speaking to us virtually. As we all know, I have his CV here. It's a pretty long CV, so I'll quickly read up. Meanwhile, the connection is made. I request the chairpersons to continue to be seated. Yeah. So Professor Vijay Bang is, as we know, is the president-elect of the CSI. He is the honorary professor and head of the cardiology at the Grant Medical College and Sir JJ Group of Hospitals of Mumbai from 85 to 2015, and currently he is a honorary consultant intervention cardiologist at the Lilavati Hospital and Research Center, Mumbai. He also has a lot of administrative. He has had a lot of administrative roles in the past in the CSA Mumbai chapter and CSA headquarters as a national executive member. He has a founding president. He has a lot of academic credentials to him as well. He is the founding president of the Cardiovascular Academic and Research Foundation, the founding chair and course director of the India ACT conference. He is also the founding director and moderator of International College of CME. He also has plenty of publications. He is an invited faculty in multiple conferences all over the globe. He also has awards from the Foreign Minister of Kenya for starting an angioplasty program at Nairobi, Kenya in 2000. He also has multiple awards, again from India and elsewhere. He's a fellow of the CSI, fellow of the ESC, fellow of the ACC, and fellow of SKY. I would welcome Professor Dr. Vijay Bang to give the IAV Prasad Lal oration. The topic is advances in percutaneous therapeutics of adult structural heart disease. If the connection is on, let us have the oration.
Thank you very much for your kind introduction. Can you hear me?
Yeah, you're audible, sir. Please go ahead.
Okay. Shall I share my screen?
Yes, we are ready.
Okay. One minute. Okay. Can you see my slide? Hello? Can you see my slides?
Yeah, we can see your slides, sir. Please go full screen.
Okay. Thank you very much for inviting me to be delivering the prestigious IV Prasad oration. And topic is advances in percutaneous therapeutics of adult structural heart disease. We have come the long way from coronary to structural, and now situation is slowly building up. Almost all structural heart problem we could solve with the catheter. Particularly, there was unmet need because there are several patients not fit for surgery due to high ST scores. So in structural heart, common conditions are left atrial fibrillation and left atrial appendage closure, patent foramen oval closure, then valve through the transcatheter valve replacement in the aortic position, we all know has grown up very well. and then mitral valve, and then coming to tricuspid valve. So everywhere there is a growth, but slowly in next decade, you will see plethora of valves being approved for all positions of the mitral tricuspid, and they will be evolved over a period of time to be useful in all these locations. TAVI is already established its role. So coming to left atrial appendage closure, we know atrial fibrillation is one very common and dreaded problem. We all face it. And we have a situation, a case, suppose, whose CHA2DS2-VASc score is very high, 7, and has bled score, the bleeding score is 4. This patient we will find it difficult to continue on the anticoagulants, oral anticoagulants, warfarin or NOAC for that matter, because if they develop hemorrhagic bleeding, it will be a disabling stroke. So what are the problems we have? How to prevent stroke in atrial fibrillation? One is therapeutic, the pharmacological intervention, warfarin and NOAC. And second is a closure device for the left atrial appendage. Currently, Watchman is the one which is approved by the US FDA for use. And what we need to look at is the sufficient risk for the stroke if we are convinced. And there are limitations to continue oral anticoagulation, and risk is acceptable, procedural risk is acceptable. No other indication for oral anticoagulation is there apart from atrial fibrillation to prevent the stroke. It's mainly preventing the stroke. So we have large experience with warfarin. On the trial, it showed 1 to 3% chance of bleeding, but in the real world, the annual bleeding rate was 6 to 8% with warfarin. We know warfarin can be very notorious, and most patients don't follow the INR regularly. So compliance issue is big with the warfarin. Coming to then NOACs. NOACs were tried, and clearly apixaban is superior in terms of stroke reduction and even in bleeding reduction. So NOAC has taken over, particularly the non-valvular AF. So what do we have? If we have an AF, we have several things. We have to control rate, rhythm, and mainly the stroke prevention. That is thromboembolism for stroke prevention and risk factors. These patients have several comorbidities because most of these patients are elderly. And if the CHA2DS2-VASc score is 2 or equal to 2 or 2, then we can consider oral anticoagulants. But now, in addition to warfarin, NOAC, we have this option of considering the left atrial appendage closure, which will reduce which will eliminate the chance of bleeding and stroke. So, and the issues with the oral anticoagulant is almost 50% patients are not taking anticoagulant for some or the other reason. Out of those who take, 30% will discontinue in 2 years because of the compliance issues. And bleeding risk is 2% per year. Average bleeding risk is 2% per year in this patient while they are on the treatment. And 90% of the strokes are from dislodgement of thromboembolus from the left atrial appendage. So surgically it was closed, but unfortunately there is no clear-cut data available how good it was and how well it was preventing the stroke. But now, of course, they are collecting the data. So there is a lack of data on surgical closure of the left atrial appendage. So we have come a long way and we are using Amplatz device. Amplatz device, and it's a very simple technique. Transseptal, of course, we have to do transseptal puncture using broken burrow needle, go into the left atrial appendage, inject a dye there, see the shape can be different. So accordingly, we have to use, so it's demonstrating the shape of the intra-arterial, of the left atrial appendage is very important by angio, so that we can use the appropriate device for closure. Now device is positioned here under the guidance of T. All these procedures are under GA and guidance of T. And it's positioned here and then gets deployed. after it's get deployed, some patients do get thrombotic thrombus developing on the device itself over a period of time, and that will defeat the purpose of deploying the left atrial appendage closure device. So then there is a ridge. We all know that this ridge is usually septal the atrial fibrillation ablation procedure is done around this ridge, and which is very close to the left atrial appendage. So when you do a procedure of ablation, usually there is a scar and there may be some erosion which may be prothrombotic. So we have to be careful in deploying the Watchman device in those patients first, and then we can delay the Watchman device deployment. So basically, once the device is deployed, 45 days we continue with the oral anticoagulant and aspirin. After that, we do T. And on the T, if we demonstrate that there is no thrombus, no leak, then we can go on DAPT for 6 months. By the time the device will be endothelialized, and then we can continue aspirin for lifelong. So what has Watchman device done in last 6,000 patients or 15 years? It has reduced the bleeding risk by 55% and reduced the mortality by 27%, predominantly due to the reduction in hemorrhagic stroke, which was occurring due to oral anticoagulants, and non-procedure related bleeding. So what do we have? The success rate of deployment is very good, 95%, but with the current Watchman Flex device, which is called as Watchman Flex, the improved device, the implant success rate is 99%. And the complication rate is 0.5%. So it's remarkably reduced. And once this device is deployed, we can discontinue oral anticoagulant in 92% of the patient. And 99% patient will be discontinued after a year. So what are the problems with the device? It can have a peri-device leak. If it is more than 5 millimeter, we need to do something about it. Then it is significant and need to close it either by coil or some other technique. And then if you have a device-related thrombosis, which can occur in 1 to 6% of the patient, like it is shown here, and then it can get dislodged, and then purpose of putting the device is defeated. Then we have a device embolization, which can occur in up to 2% of the patient over a period of time. We can see this device is lying across the mitral valve in the LV. So basically, after the results of the Watchman, ACC and AHA has given a guideline-based approval to this procedure, and it is 2B and evidence, the level of evidence B. So it can be done in patients can be considered for patient with atrial fibrillation, increased risk of stroke, and contraindication from long-term anticoagulation. So this is where we can consider the left atrial appendage device. And indication, as I said, a high Chadwick score, bleeding risk, all these things are very, very important. So now coming to Flex device, which is the latest device, the profile of the device is lowered. So it can fit even in shallow left atrial appendage, 1. 2, it is covered so that thrombus is not formed, plus multiple struts are deployed so that it gives a better seal, so there is no leaking. So overall stability is also good, number of struts are increased. So this device seems to be working very well. And there is a Pinnacle study done in America, which says that the 400 patient study done, and the primary endpoint was considered as a 5 millimeter leak or more due to at 12 months. So that was not seen at all in all 100% patient of 400 cases. And the safety was 0.5%, as I said. Implant success 99%. And the thrombus on the device was 1.8% in new device as compared to 3.7% in the previous Watchman device. So 90% implants have identifiable, don't have any identifiable leaks on 12 months. And compared to the old device, this is far better, and it is used very safely, the Flex device. Knowing the results of Flex device, 2 new trials have started. One is Option, and second is Champion trial, about which I will discuss in greater detail later. So who do we consider this Watchman device? Which patient do we consider? With the Chadwick score of 5 and Hasbled score of 4, this patient has to go off anticoagulation. So such patient is what we need to look at and then consider if there is a risk of stroke, to prevent the risk of stroke. So as we said, this kind of Chadwick score and Hasbled score, the Chadwick score of 7 will lead to 9.6% annual rate of stroke. And bleeding risk with 4 Hasbled score, it will cause 8.9%, which is unacceptable for clinical recommendation. So these patients are very suitable for left atrial appendage closure. Now, initial experience suggested that this device is working very well, no major bleeding during the course of OAC. While 45 days they have to be on OAC after the device is deployed, there was no major bleeding. So, but there has to be a multidisciplinary approach if we consider left atrial appendage closure. Urologist, gastroenterologist, neurologist, and vascular medicine person, and cardiologist, of course, should be an EP person should be available to discuss this case, and on the team should decide whether this case is suitable or not. Then what we have achieved, if we have no oral anticoagulant, oral anticoagulant, then risk of stroke is 12%. With warfarin, it is 4%. With Watchman device, it comes to 2.8%. So some patients do have a recurrent atrial fibrillation despite having a treatment for control of atrial fibrillation. Such patients are suitable for the atrial fibrillation ablation procedure or made surgically, if not suitable for the catheter intervention. And this combined procedure can be considered in certain group of patients, but it has to be backed by the trials. So we have to do trial, and these trials will decide. Option trial and Champion trial will tell us whether this is suitable or not. But the results of Option trial will come in 2024, and Champion in 2025. So this is very important development that is happening in terms of in the space of atrial fibrillation and left atrial appendage closure device. So what is Option trial? Option trial in one arm is a RCT. It's in one arm atrial the AF ablation procedure plus Watchman device, 2 together, 800 patients. And in another arm, the atrial fibrillation ablation plus oral anticoagulant. The result has to be awaited in 2024, and that will tell whether which one to go for, because using atrial ablation will reduce the number of episodes of atrial fibrillation. We know that it cannot completely cure it, but definitely it will reduce the number of atrial fibrillation episodes. So that also helps in reducing the formation of thrombus or risk of stroke. Now, another trial, which is Champion trial, 3,000 patients. And in this, there is a Watchman Flex device in one arm, 1,500 patients, and they will be randomized 1-to-1, and NOAC in another arm. And they will be monitored 36 months, and the result of the trial will come in 2025. And several other trials are ongoing to answer unanswered questions, that these are unanswered issues with the left atrial appendage closure device. One is anticoagulation regimen. Second is imaging. Third is high-risk patient and procedural issues. So several such trials over a period of time will answer all these issues, all these issues. The advantage with the device is reduces the risk of the stroke and the bleeding associated with long-term anticoagulation use. And it has several advantages. It's very safe. Mortality benefit is direct. So after awaiting results of this clinical trial, if they come favorable, then set it and forget about it. I mean, this is what the slogan is for left atrial appendage closure in terms of atrial fibrillation, which is a very common problem clinically. And combined procedure of the atrial ablation, atrial fibrillation ablation, and the appendage closure device. Then coming to foramen oval, the another important area which can lead to stroke and embolization into paradoxical embolization into the brain, and that can lead to stroke. So PFO incidence in autopsy, various age group, it's almost 20, average will be 20 to 25% incidence of PFO in general population. And the annualized ischemic stroke in US are 6 lakhs. And in the world, it is 1,15 lakh patients have annualized ischemic stroke, which is a very large number. And out of these, 20% are ischemic stroke between the age of 18 to 60. And these are the patients, 30% of these patients can have a cryptogenic stroke, and 50% will have PFO and 50% no PFO. So these are the patients suitable for left atrial appendage closure, which are young and middle-aged. And of course, old age also, if they are not, if they are sensitive to anticoagulation therapy. So similar numbers are noted in the world also. So it's identical, annualized incidence of cryptogenic stroke. So what do we have epidemiologically? 20 to 25% incidence. Out of that, septal aneurysm and atrial septal aneurysm is seen in 2.2%. And 83% of these patients of aneurysm of septum will have PFO, 83%. So young patient, 50 to 60%, if they develop stroke, 50 to 60% of them will have a PFO. And if you go to see if cryptogenic stroke in this age group, PFO is causative in 73%. And some other cause can be there in 27%. So PFO closure also forms a big, large area, but incidence, but it's uncommon to have a paradoxical stroke, paradoxical embolization and stroke. So we have to carefully consider closing the PFO. All patients cannot be closed with PFO. So incidence of ischemic stroke is 88%. Out of that, 40% is cryptogenic, and hemorrhagic stroke 12%. Now, what are the parameters which can lead to clinical parameter which can lead to paradoxical embolization? One is DVT, migraine, sleep apnea, and of course, Valsalva. These are the maneuvers which can initiate the mechanism of paradoxical embolization into the brain. And these thrombi can come from aortic valve, mitral valve, left atrium, left ventricle, and of course, paradoxical emboli. So we have to rule out these sources of emboli completely, and we should be thoroughly convinced that it is only the paradoxical embolus which is causing a stroke in PFO, incidentally found PFO. Then those patients can be considered for left atrial appendage closure device. Now, once we have a stroke, which is cryptogenic, thorough evaluation is very necessary in terms of echocardiography for structural heart problems. Cerebrovascular disease imaging has to be done in some way. And of course, the coagulation pathway has to be studied. We need to also see, is there any atheroma which is leading to embolization into the brain and causing stroke. And third is arrhythmia, which is commonly atrial fibrillation. Interestingly, 24 hours monitoring, Holter monitoring will manifest only 2.2% of AF. But if we continue the Holter monitoring for 4 weeks, we can detect as many as 15% patient having atrial fibrillation. So how do we study them? Do a T with a bubble. And if you see the bubble coming on in the left atrium, that means this patient could have a paradoxical stroke if there is no paradoxical embolization causing stroke. If there is no other cause after studying everything, if no other cause can be explained for the stroke or embolization. There's interesting investigation, transcranial Doppler. After giving the bubble, you can do a transcranial Doppler IV bubbles, and normally you don't see any disruption. But if these bubbles are crossing into the brain, you will see this disturbance in the velocity flow, and it is being graded into 5. Higher the grade, more is the chance that it could be a paradoxical stroke, paradoxical embolization from the left atrium. So there are now 2 devices which are studied. One is StarFlex, which is called as closure study, and this revealed that there is 51% relative risk reduction, but it is not statistically significant. Whereas RESPECT trial used the Antiplatelet device for the PFO closure and 73% relative reduction, and this is statistically significant. So comparing the closure and the RESPECT is far better, the Antiplatelet is far better than the StarFlex device. And ultimate conclusion is closure with a is superior to medical therapy alone in pre-specified per protocol as treated analysis. So it has to be carefully assessed and then take a call. All patients cannot be considered for PFO closure. That we have to remember. And a teamwork should be there so that there is no, now coming to patients having PFO, but some other cause is there. In that, if we close the PFO, there is 45% risk reduction, which is also statistically significant, better than medical management. Similarly, if you have an unknown cause, cryptogenic stroke, as I said, cryptogenic stroke, if we close with the Antiplatelet or the PFO, if it is there, then the 62% risk reduction, which is statistically highly significant. So in both these arms, it looks like it works. So there is meta-analysis done using this odd ratio, which suggests that transcatheter closure is superior to medical therapy, clearly. So we can consider closure of PFO, not in all patients. Patients of cryptogenic stroke, no other cause is found. And this latest device, that is Watchman Flex, is supposed to be very safe, as stated earlier, very safe. So we can consider this patient for the such patient who have cryptogenic stroke, and there is a PFO, and all this bubble study shows that there is a contrast going from right atrium to the left atrium. That suggests that perhaps there may be a paradoxical embolism from the PFOs, through the PFO. So now coming to the most exciting part of transcatheter aortic valve intervention. In India, there was Jayadeva did a study of 13,289 patients studied over 13 years with the echo, and that reveals isolated aortic stenosis incidence of 7.3%. And out of that, degenerative was 65%, bicuspid aortic valve 34%, only 1% was rheumatic or any other cause. So active cases which can be considered best extrapolated from our Indian population of 1.35. So active cases every year we have is 281,073 patients for TAVI. But the cost is so prohibitive that all these patients do not get, we do any per year at the moment. The TAVI procedures are done to 1,000 and more patients per year. So how does it help? If we leave aortic stenosis without any treatment, on medical treatment, the 50% patient will die in 2 years if they become symptomatic. This is very high risk. But surgical AVR remarkably improved their survival remarkably. But 30% of these aortic stenosis patients are not suitable for surgical because they're high STS risk or high STS score or some other issues. So those patients are lying without any on medical management, which is causing 50% mortality. So there was definite unmet need for having a catheter-based procedure, which is of low risk. And this is provided by none other than Cribrier, Alain Cribrier, and in April 16, 2002, he deployed a catheter-based TAVI valve under GA in a patient who was very critically ill in congestive heart failure, and that was very successful. 15 minutes later, patient was extubated, and you can see both of them smiling. And in a short time of 7 years, 3 generations of TAVI valve were produced, and 9,000 patients were done TAVI in 4 RCT. And mortality, when it's compared to TAVR and SAVR, is almost equal, no statistical difference at all. And best part is it's done under the sedation and no ICCU treatment, 1-day stay and patient can be discharged. So when it comes to surgical AVR, it is far better procedure and rewarding procedure in terms of coming to long-term durability of surgical valve and TAVI valve. They're identical. Hemodynamically, this is better. The mortality wise, it is better, and stroke rate reduction is significantly better with TAVR. So access is standard access is transfemoral, but if there is an access issue, then we can consider transaxillary, transcarotid, and of course transcaval now, or transapical, transiliac. But nowadays apical and the aortic route is not considered favorable. So coming to a partner trial of using SAPIEN TAVI valve and core valve, that is Medtronic valve. One is balloon expandable, second is self-expandable. And both have shown 50% reduction in mortality in patients who were not denied surgery. And those are all very sick patients having a STS score of 15 or more, and several other problems they had. They were not suitable for surgery at all. And if you see the all-cause mortality in TAVR and SAVR is almost identical, but the stroke reduction is remarkably low in the TAVR group, and it is further improving. And this produced a statistically significant difference in the two lines of procedures. 4 trials which were done, meta-analysis done, is showed the mortality and the stroke both are low, and it produces better hemodynamic, and long-term durability of valve is identical in surgical AVR and TAVI. So mortality kept on reducing over a period of year with improvement in technique and improvement in device. So why not consider in low risk, surgical low risk TAVI? So patients with STS score less than 4% or maybe 3%, less than 3%. And 3 trials were started in 2014, past 8 years back, and partner, core valve, and Notion trial. And results of these trials were highly favorable in favor of having a TAVI rather than SAVI. So it's not something which is very, very remarkably good and cannot be believed. I remember patient roaming all over for surgeon who will operate them, but they were not ready to operate. Those patients were dying. So definitely it has improved the mortality. Now Notion trial has clearly shown the surgical valve over a period of 5 years, they were followed, and it showed on echo, it showed that the valve orifice was 1.37 as against with TAVI 1.66, so remarkably better. So orifice wise, TAVI is superior. Then coming to gradients was much lower in TAVI valve as compared to the surgical valve. And then coming to deterioration in structure of the valve, and surgical valve 26.1% deterioration as against 4% deterioration in TAVI valve. So remarkable benefit with the TAVI. And we all know now only major problem with the surgical AVR is mismatch, particularly seen in 54% patient with a moderate orifice, and severely narrowed orifice 11%, And this is a major problem in which if it is bioprosthetic valve in valve can be done in this patient using TAVI valve. Now bicuspid and tricuspid, another interesting area. So bicuspid and tricuspid valve, in bicuspid valve, the fluoro time and procedure time was significantly higher as shown by p-value, but all other, the annulus rupture, aortic root injuries, second valve, paravalvular leak, all these were lower, all these were statistically insignificant, all these differences. So even in bicuspid, it is a boon for bicuspid aortic stenosis patient, and 1 year mortality is identical, SAVR versus TAVR in bicuspid aortic valve. In valve, there is a registry which is done, and it's particularly used for smaller degenerative aortic valve associated with greater mortality. So depending on smaller the size of the valve, surgically done. If smaller the size of the valve, higher is the mortality. More intermediate, again mortality is higher, but in large, mortality was low even with the SAVR. So valve was tried in this patient with the TAVR, and 30-day mortality remarkably low, 2.7%, 30-day stroke 2.7%, 1 year mortality 12.4%, and pacemaker 1.9% as compared to the redo AVR surgery. So paravalvular leak can be an issue, but it is now remarkably reducing, and with the improvement in the devices. And overall projection is by 2025, we'll almost have 3 lakh cases, 3 lakh, every year 3 lakh TAVI valve will be deployed across the world, globally. And various devices which are available, currently more popular is Evaluate R, Evaluate Pro, and Sapien valve, currently popular. And of course, our Indian valve has also become popular, and these valves are also either FDA approved or CE approved, and they are also being tried in various trials. And as we said, the paravalvular leak can be there. So there is a device, there are several devices which are existing, and new devices have been developed to reduce the leak in a patient who had a TAVI or surgical aortic valve. Both can have a paravalvular leak, and that can be closed using these devices which are there. So by guideline, who should get a TAVR? All patients above the age of 80 should get TAVR. 65 to 80, they should have a heart team discussion and decide TAVR or SAVR is superior. And every time we sit, we should have a primary cardiologist. His opinion is of critical importance. So there is expanding indication for the TAVR, as we see that it is done for the low risk, intermediate risk, and high risk. Now, we knew that STS score more than 15%, these are inoperable surgically. So all these valves will get a TAVI valve and prolong their life. The very remarkable benefit has been provided to them. And in this TAVI procedure, normally we start with the simple and then go to serious or very complex lesion. Here, it started with the complex lesion. TAVI started with the complex lesion, inoperable cases, and it has proved the test of the time. And when the STS score is high and low, between high and low, we need a hard team discussion to decide whether TAVR or SAVR. So once the patient becomes symptomatic with severe aortic stenosis, then prognosis remains very poor. So if patient has demonstrated by echo and other tests that the valve is severely narrowed or severe aortic stenosis is there based on criteria of 0.8 millimeter of aortic valve opening and mean gradient of 30 to 40 and velocity more than 4 meters per second. So these patients can be considered for TAVI rather than waiting for them to become symptomatic, because that will prolong their life and give better survival. So this hypothetically, it is being constructed like that as young as 40 years old, we can consider a TAVI. then second TAVI at the age of 50, and then surgery, and then again TAVI. So this may be a projection at the moment, but future seems to be in favor of this. So who should get TAVI and who should get SAVI? That's the most important question we need to answer. So it's the anatomy, not the age, should determine TAVR or SAVR. So small annulus, TAVR. Unfavorable anatomy with high calcium, LVOT as SAVR. Then bicuspid, low, moderate calcium, no RAFE, TAVR. Bicuspid, large annulus, SAVR or TAVR, any one of the procedure is fine. But patient with bicuspid, heavy calcium, RAFE is there, aortopathy is there, those patients should be considered for TAVR, SAVR. So coming to surgical intervention, coming to mitral valve intervention, we know that there is unmet need in mitral valve also because prevalence is very high. The incidence is very high, 250,000 cases per year. And prevalence shows that 2 million patients are there. Only 50,000 surgery could be done. So there is unmet need for catheter-based procedure, which is for the mitral valve, which is very difficult valve to intervene because the delivery is a problem, fixation is problem, sealing is problem, and function is problem. So there are several devices which have been considered, but lately MitraClip has picked up very well, 42,000 patient deployed mitral valve, and it shows that in heart failure patient, it is much better device to use, and it is better than ICD or for that matter CRT. So selected patient of this MitraClip can be considered, but all other techniques of my TMVR are still in the pilot stage. So there is nothing because mortality is very high, 30-day and 1-year mortality is unacceptable with this procedure. So they are being developed. Coming to transcatheter aortic valve, these are again tricuspid valves, sorry. And tricuspid valve, TR can be primary or secondary. And there are various devices which are available. Tricuspid valve, leaflet, it can be also, the MitraClip can be used here, or annuloplasty can be done, or orthotopic valve can be employed in the position of the existing tricuspid valve, or the valves are deployed in IVC and SVC to reduce the mortality. So it is called as heterotopic. So MitraClip is also used. So over a period of time, next 10 years, I see that from open chest, it will go to PCI setup in the cath lab, even for structural heart disease. So all in all, there will be a coordinated work between surgeon and the interventional cardiologist with the heart team approach to consider in structural heart specifically to consider any intervention. Thank you very much for your kind attention. I'm happy to have delivered this oration. Thank you.
Thank you, Professor Bank. Because it's an oration, we won't have any questions. We thank you very much for spending a Saturday morning with us. Though we would have loved to have you here physically, probably next time. We'll
thank you.
With this session. Thank you, sir.
Thank you very much.
Vascular can introduce, who doesn't require any introduction, Dr. Ramesh Babu Garu, and this session.
Shall I leave? Hello?
This will be a recorded. This will be a recorded session. So take a couple of minutes for the stage to come up. Just you to please.
Yeah, thank you, Dr. Ramesh sir, for a very lucid presentation about calcium score and as well as the role of the CT angio. Yeah, we have to apologize to Dr. Barwa sir for rescheduling his talk, and sir is very patiently waiting for his topic, that is Rota versus IVL. And all of us know that coronary calcium and is very challenging for the interventional cardiologist. And rotablation has come into almost 1998 into the interventional arena. And most of us know Rota has its own limitations because it requires a lot of learning curve, and there is several complications associated with the Rota. And now we have IVL, and especially IVL is a very few limitations and a very short learning curve, and the risk of complications associated with Rota like neuroiflophenomena, everything won't be there for the IVL. And most of the time they are complementary. And Dr. Barwa sir is going to discuss about these two topics. And now we welcome Dr. Barwa sir. Sir is an interventional cardiologist, Apollo Hospitals, Vizag, and sir doesn't need any introduction. And most of the conferences and live cases, sir is very well known to all of us, and especially not only national, even international cardiology community.
Good morning, Chairperson, and organizers for giving me this opportunity. Dr. Harita, thank you very much for this opportunity. Actually, this was supposed to be a debate about what Dr. Harita told me, but subsequently my friend Pratap could not come here. That's why the responsibility comes to me for both the procedure, rotational atherectomy as well as IVL. As Dr. Sivanarayan told that calcium is the real enemy in cath lab. Once calcium is there, all of us become worried how to go about. We have rotational atherectomy since many years. It is there in the cath lab, and most of us familiar. If somebody is not familiar, I think as a interventional cardiologist, if you want to do complex angioplasty, you need to know about that rotational atherectomy. This is very important, and I think this is, although it needs some training, but not required aggressive training. If you have some exposure, you can do this procedure. As you know, when you talk about the rota versus IVL, it's something like an old and new technology. We need to revisit the old one, and you should again understand the new one. You cannot just discard or accept without any kind of consideration. And at the same time, you need to consider whether it can replace the new old one or it is a complementary. As a chairman has told already that whether it is a complementary or it is a kind of replacement. Rotational atherectomy, as you know, it is, as I told you, it's very, very essential, and it is unreplaceable. Nobody can replace this particular system because you need in the cath lab, and that has to be learned. If you see the principle of rotational atherectomy, is basically differential cutting. It displaces the elastic tissue, and it can remove or it can cut through the inelastic tissue. These are very, very basic principle. As we are saving, when you save, you will not get cut, but it will not cut the hair. So this is the same principle applied in rotational atherectomy. And it is a technique sensitive. This is a current technique is mostly we use for the plaque modification. Previously, we used to have a proper lumen also as a treatment. Now, but presently, what rotational atherectomy use only for plaque modification just before standing, and balloon angioplasty. And but one more thing, we should remember that this particular device is operator sensitive. We need to have some kind of experience in this, and without the experience, probably sometimes we'll end up in problem. And it is a little complex gadget, but as it looks, it is not that complex. We need to know, you need to be familiar. Before doing rotablation, you need to be familiar with the system. What are the console, what are the different parts of the console, because it is not advisable totally depend on the technicians. You should not depend on technicians. You should know yourself that what is the console, what are the different parts of the console, how to go about. And even the rota link also is very important. The advancer is very, even previously we used to have a rota where it was now you need to detach, you need to combine. That was more cumbersome. But now we have a rota link plus where you can get the advancer with the rota bar. You can directly connect that and you can do that. So it is more easier. Although it looks simple, but still there are some kind of knobs and the connector and all those things. We need to be familiar with that, and this is most important. And of course, finally, you need to have a familiarity of the rota bar itself, how to go about. So these are how to choose the rota bar, the different sizes available, what are the catheters should be used for the particular bars. These are very, very kind of common and essential parts before starting rotablation. Then what is the protocol? Protocol is what is my concept of rotablating a lesion. That is most important. By that, we can have a protocol. Whether it is to debulk the plaque or to modify. Previously, we used to debulk the plaque, but nowadays, before standing, only modify. We want this little modification of the superficial calcium before going for stanting. So this is the second one is the most commonly used nowadays. This is the purpose used in rotablation nowadays. And what is the protocol? Well, different protocols have been investigated in an attempt to obtain the highest acute as well as a long-term success rate with the lowest risk of procedural complications. And it depends on whether it's a primary therapy or lesion modification. As I told you, primary therapy, as a primary therapy, we are not using nowadays but as a lesion modifications, we need to use frequently this particular device. And of course, you need to have a particular attention to burr size. Burr artery ratio in a lesion modification, it should be 0.6 to 60 to 70%. In a debulking, previously we used to go even up to 80% now, but we should not go to more than 70% for a lesion modification. Previously, we used to go to this RPM, the revolution of the burr, almost up to 2 lakhs. But nowadays, we usually prefer to have around 155 or 160, not more than that. There are some regions we'll come back later. And motion pattern is also very important. You should not just cross the lesions. You will sometimes get a stuck bar. You should always go gradually. Proximal part of the lesion should be modified first and gradually distally with a packing movement. This is a basic principle to prevent complications, because you need to sometimes have complications in rotablations. These are some tricks by which we can reduce the complications in rotablation. Important procedural tests are very, very important when you go for rotablation. This is very draw test, what is called. The first, the drip, need to have a saline infusion continuously through the seat of this advancer. It should be dripped, and you should check that the fluid is coming. Second, need to check the rotational burr, whether it is rotating or not, or what is the RPM. You can set the RPM with this console. That has to be done, that has to be checked. And the advancer is very, very important, whether advancer is moving freely or not, because advancer, as you know, there is a plastic sheet will be there over this rota bar. Sometimes that can get stuck and will not allow the advancer to move. It is very, very important to have this. And of course, whether wire is visible, the brake is functioning. These are all important tests to be checked before starting the rotablation. And this is a drip. This is way you can check it whether it is flowing or not, because this is a lubricator. If it drip doesn't flow, then probably advancer will get stuck. Bar positioning also very, very important. You need to lock this, but the lock advance knob 2 to 2 centimeters forward before advancing the bar into the guide catheter. Advance bar forward while holding the wire. That, of course, sometimes need to help from your assistant. When bar is proximal to lesion, relieve any forward tension on drive and stop by unlocking the advancer knob and pulling it back. So you need to have that unlock this and you can pull it back to reduce the tension. This is really for wire tension is very, very important. And Dynaglide is not advocated or not recommended when you go advance the bar, because as you know, this bar has got a diamond shape, so if you advance, it can damage the catheter. So Dynaglide should not be used in advancing the bar, but when you pull out the bar, you can use the Dynaglide. What is the ablating technique? This technique you can find out by various sensory method. One is the feedback during ablation is very, very important. That feedback come by the visual, even by the auditory. This is very important. If you're not looking at this, you're doing something, then even auditory, this feedback can be very, very important. Of course, you can have a feel when you advance the bar. So these are all different important kind of feelings or sensory, information by which you know that you are going the right direction. Pitch changes related to resistance encountered by. This is also very, very important. When this bird is speed is coming down, you can feel that your pitch is also changing. By that also you can make out that how much pitch is changing, whether it's 10,000, 5,000. If you keep on doing that, without looking at the speed, you can find out, okay, it has come down to 5,000, 6,000. Advancer knob resistance also important. Feeling is also you need to be very careful. And excessive drives and vibration sometimes happen when you go very high speed and cross in the middle of the lesion. Sometimes it can happen, and this is not a very good information. When you get this, sometimes you can learn with a stuck bar or a trap bar. This is sometimes that is one complication which is very, very difficult to handle in cath lab. And the problems with the rotablations is that this is basically atherectomy has a steep learning curve. You need to have some kind of learning curve, but it is not that difficult. It is not that difficult that you need to a lot of training on this. If you see or if you do some cases in a cath lab, gradually you learn this. It causes thermal injury. This is the reason why you can get a stuck bar when it goes in very high speed. So when something is moving, there's this friction coefficient will be less. So burr can suddenly, there will be little expansion, friction will be less, it will cross suddenly. So if you go very fast, sometimes without ablating, this burr can go distally, and when coming back, it will get stuck. So this is the kind of things can happen because this part of the burr is not coated. There is no diamond coat, so you cannot pull it back. But this is a smooth one, so you cannot. Sometimes it will get stuck there. So this is another reason why you can get stuck burr or cohesive phenomenon, what is called. Unable to protect the side branch, this is another disadvantage. Suppose there is another wire, we have to remove the wire, then you can do the rotablation. Of course, there are some methods by which you can do it, but I think in general, we cannot do a rotablation when one wire is sitting in the side branch. Potential to transit the wire by large dissection or a perforation, especially in the tortuous anatomy. So tortuous anatomy is another very kind of difficult situation by rotablation, where you can get a kind of perforation or injury to the artery. And as you know, this is actually there will be distal embolization because rota will produce some microemboli of the plaque that will go into the small vessel, and that is the cause, that can be a cause for no reflow or slow flow. So these are the disadvantages of rotablation. Apart from that, we need to be very careful when there is a thrombus in the lesion and tortuous vessel, large vessel, you may not be able to do rotablation because it is a contact. Unless it is come to the contact to the artery, you cannot get a rotablation. Immediate post-stenting is not recommended to do rotablation. And if another problem is that because we are doing for radial nowadays, if it's a bigger or more than 1.75 bar, you need to go for 8 French and this again sheet. So that is another problem. And needs a separate guide wire microcatheter sometimes required to use this rotablation. Need of lesion preparation even after ablation. So always, because we are doing that for the lesion modification nowadays, so always you need to prepare the lesion with a balloon angioplasty following rotablation. So these are some kind of problems in rotablations. Now, this is the tortuosity. You can see that when there is tortuosity, there is wire bias. Wire bias because the rota wire is a very stiff stainless, kind of steel monofilament, and may not be centrally oriented and in a tortuous vessel. So it will be abutting to the wall. What is called this, because of that, the rota can have can damage the artery with a furrowing effect. You can see that they can damage the artery. You can have a perforation or dissection. This is another problem. This can be to some extent can be prevented by putting the wire little proximal and pull the wire. The tension should be reduced and soft part of the rota wire should be near to the lesion. By that, you can make some kind of unfavorable kind of bias to a favorable bias that you can do in clinical situation. And if sometimes you can see that when there is a perforation, you will end up with massive perforation in your tortuous vessel. In that case, probably you need to go for a very lot of major situations where you need to put another guide, go a balloon wire, which is a very, very difficult, serious situation in the cath lab, which should not happen for this, but still we can have it. This is one case. You can see that this is one lady who came with a calcified lesion. And you can see after rotablation, you can see her rota, although we are doing very carefully, and after doing the proximal part of rotablation, there is no flow in the artery. She actually is of unstable angina, but she was treated properly before doing intervention. And you can see that there is no flow. This is not uncommon in rotablation. You can have this kind of situation, but things that we need to know how to bail out. See, problem here is that situation will become totally different. Suddenly, one stable patient becomes suddenly unstable. So this is a time you need to be very careful. You need to go keep your cool and you find out what exactly has happened. And many a time there's a big branch. You try to if you can pass a wire, save the branch is always better. And what you can do exactly sometimes it can because of the thrombus or because of dissection it might have happened. We do not know what has happened exactly when this kind of situation arises. Try to pass a wire or pass a balloon over the same rota wire and with a small balloon, 1.5 millimeter balloon, and dilate this area and see exactly what has happened. If you can pass a microcatheter, you can give a distal injection very carefully. You can see also, but I think that is not very ideal because that will take some time. So better put a balloon and dilate little bit and see what exactly happened. If there is a dissection, obviously we will know that there is some flow distally. So that's what we did. We pass another wire quickly to the diagonal and put a balloon and finally we stand that we came out from the bailout situation. But it is not always can happen. Sometimes, if we cannot cross, cannot do something, sometimes we need to send the patient for surgery as well. This is another very difficult situation of rotablation. As you know, this right coronary artery cannot be coaxial. To do angioplasty, it cannot be impossible to make a coaxial guide in the right coronary artery, because as we have done, we have seen that in LOB, always we do in LOB, most of us, and we feel that catheter is coaxial. But in 20 minutes time. So this you can see here, because this particular case, you can see that when rotablating the AP view, it is not coaxial actually. So this is another difficult situation where this rotablation is difficult. This is one case with a heavily calcified lesion. You can see in this kind of this unfavorable bias with a tortuous proximal lesions, you need to be very careful. You can go in a packing movement. You can go with a rota very slowly. Then probably you can tackle this kind of patient. And this kind of situation, IVL may not be very comfortable because heavily calcified small artery, so we may not be able to cross with IVL below. And this is another 68-year-old person, diabetic, STEMI, LV dysfunction. You can see sometimes this kind of situation, small vessel, rota is more useful than Indian procedure. It's heavily calcified, and you can get a rotablation and come with an acceptable result. This bar entrapment is very, very important. This is the problem we can face in rotablation. And in this case, when it happens, you have to pass on a wire by the side of the bar if possible, or you can get even a second guide catheter, can pass on balloon, by pass on a wire, which should be hydrophilic wire or very powerful wire like a strong support wire like a compressed flow. You can go distal to the rota and put a balloon and open it, then maybe you will be able to pull out from the entrapment. In conclusion, rotational atherectomy requires adequate training and experience, relatively complex procedure, contraindicated in thrombus-containing lesion, and severe complication can accompany procedures. I just do a few slides for IVL because I was told that both should be taught. And this is, as you know, Shockwave is a new armamentative in calcium treatment. This is basically, it gives some kind of sonic waves by which sonic wave will travel to the wall of the artery. You can treat the deep as well as superficial calcium. You can see the cracks here. This is a more useful, user-friendly, because it's a balloon. It's basically a balloon therapy. Anybody can balloon angioplasty. This can be done. It doesn't require a lot of training. And this balloon should be placed there, and you can give a shock and crack the calcium. Subsequently, you can go for kind of stanting. Very useful. Even side branches can be protected. There is no major complications. Usually not there. Many times balloon can get ruptured, but still. So, but you do not get major complications here. And if you see the talk about science, this disrupt study, 3 study have shown that a good gain of the lumen. And in fact, this is a paper published by Jonathan Hill, so that there is almost 1.7 millimeter gain after IVL in the luminal diameter. This is very, very useful because it is a left main disease, it's a dissection, and this is following the balloon. There is some dissection, but it's not open that much. But after IVL, you can see good luminal gain, and after stanting, you can have a better luminal gain in this particular case. So this is the novosity also proved that. This is another case with a big vessels. Rotablation may not be useful, but IVL is useful. You can see bifurcation lesion, circ and calcified lesion is a focal calcification. You can see the waist, even IVL at least 7, this almost 6 cycle required to crack this calcium. And finally, you can go for kind of stanting with the OM, the double stanting, and finally you can get a good result. This is another case. You can see this 83-year-old lady who has this calcified aneurysm. This is a difficult situation where you cannot do rotablation here. It's a big artery, calcified. You can do this case was treated with IVL, and you can see that after 1 year, you can see the aneurysm regress and the patient is doing very well. I think this kind of cases, rotablation is difficult. This is the advantage of IVL in this kind of difficult situation. And this is this is another last case. Probably this is a severe LV dysfunction. who has only one artery, functional artery, circumflex, which was treated severe LV dysfunction because the rota in this kind of cases, big artery is difficult. So IVL was used, and this is the final result. This particular case, even after 1 year, the LAD had a total, kind of total occlusion. You can see the waist here, even after the dia wire, 2 wires, there's a waist, a normal balloon. It was IVL was done, and finally you can have a good result. With you can see the after IVL the crack here in this. So superficial and deep calcium, both. Finally stenting was done. This patient is doing very well. This is the last case. You can see the severe calcification of this particular lady. She's a 78-year-old lady, had a MI recently, 3 years, 3 months back. Again, she came with the acute rest angina. You can see that severely calcified diffuse disease of the LAD. You can see that. And you can see that everywhere there is a calcium. You can there's a focal calcium, even there is a round total concentric calcium. So this is the case where you can see the proximal LAD is big, distal LAD, we thought it would do balloon angioplasty, proximally we do the IVL and come out. And finally, you can see that this particular balloon could not open, so we need to do a rotablation in this particular case, distal part. And proximally we did this IVL, and finally we have an acceptable result in this particular case. You can see that whole artery has to be stented with 3 stents, and we can have a good minimal stent area from distal to the proximal, which is acceptable. So this particular case shows that rota and IVL can be complementary. We cannot replace both for the other. So IVL is a minimized, it is a minimized trauma, optimize outcomes, as well as simplify the procedure. This is the biggest advantage of the IVL. Finally, in conclusion, rota and IVL, 2 different tools to treat vascular complications. Rota works by differential cutting, IVL is via sonic waves. IVL can modify the both superficial and deep calcium, whereas rota only superficial calcium. Chances of complications are high with rotablation. However, these 2 technologies cannot replace each other, and each has its own merits in different clinical and anatomical situations. Both are only complementary to each other. Thank you very much for your time.
Thank you, sir, for a very nice presentation. You have covered all the important aspects. What about nodular calcium? Which one do you recommend? Is IVL or rota?
Yeah, nodular calcium. I've shown the one left main, this shaft of the left main. Actually, that is the nodular calcium. This particular case, IVL, actually I use, which could open the artery, but I could not take this image of this one OCT because there is a dissection. One important thing, if there is a significant dissection to the proximal artery, you should not take a OCT because you need to inject, kind of very fast or forcefully you need to inject the contrast to have a good picture of the OCT. So with a proximal dissection, I think OCT is relatively contraindicated. That's why I could not put the OCT. But in a balloon, as a whole, it's a balloon, it is IVL balloon open very well. So IVL sometimes it works for the nodular calcium, but may not always. Similarly, even rota also cannot always will work for the nodular. Calcium nodule is a difficult situation. Even both kind of tools may not work. But sometimes what happens, one trick to work for this nodular calcium is that you can take a more of a support wire, extra support wire for the rota. Instead of taking a flop, most of the time we are using a floppy wire. So you can take an extra support wire. So you can make some kind of unfavorable bias to a favorable bias. So extra support wire make the rotablation, the bird come in contact with the calcium nodule, maybe in that case. There's only one way to sometimes you can do for the calcium, this nodule.
IVL can be used in CTO lesion, sir. CTO.
Yeah, this is the last case we have shown is a CTO lesion basically. So on CTO lesion, you can use that. Once you cross with a balloon, then I suppose it's a calcified, you can use for. But
what about the status of eczema laser angioplasty? That doing regularly eczema laser angioplasty.
Eczema lesion, one way it is coming to India now, but it's not readily available. This is useful in not as a severe calcification. It's a more of a moderate calcification. Eczema laser is used mostly moderate calcification where you cannot cross with other devices. But severe calcification, and these are the 2 modalities for
combined with the IVL as a laser.
Can be.
Sir, if there is no question from the audience, can you close the session? Thank you.
Thank you.
Thank you, chairpersons. Thanks, Dr. Bhatt.
is a interventional cardiologist who is very familiar to most of us. Many of us have learned many things in the past from his lectures in South Korea. Delegates today have industry. Students have learned a lot. Without wasting much time, I request Shivakumar to proceed with his talk. I thank the chairpersons, the Andhra Pradesh CSI organizing committee, Dr. Harita, everyone for the kind invitation. When we look at the atrial septal defect closure in an adult, a brief introduction about what are the types of defects. We know that secondum defects contribute about 80%, primum about 10, and sinus venosus about 10. And why should we think about a catheter closure? Catheter closure avoids cardiopulmonary bypass, cross clamp, it reduces hospital stay, morbidity, effusions, transfusions, rapid return to employment, scarless. So the next question is, who is not amenable? If you look at the anatomy of an atrial septal defect, around 60% of them can easily go to the cath lab for a non-surgical closure. But what cannot go to cath lab will be secondum ASDs larger than 35 to 36 millimeters. ASDs with deficient inferior posterior margin, multiple ASDs, ASDs with borderline PVR, ASD in the elderly with restrictive LV physiology, patients who don't have a femoral vein access, patients who have, for example, a sinus venosus ASD or combined sinus venosus and secondum ASD. Let's talk about all these unconventional areas. Secondum ASD more than 35 to 36 millimeter. American guidelines permit use of device up to 38. In fact, 40 device is not recognized in USA. European guidelines are a little bit more liberal. They accept 40. So automatically only 35, 36 millimeter defect should be possible to be closed by a device. And moreover, whenever defects are larger than 35, most of the time, 1 or 2 rims may be deficient or absent. And it's invariable in adults more than 30 years who have a large ASD who will be referred to surgery because of this criteria. So what is the experience of devices more than 40? Fortunately, a lot of Chinese vendors started manufacturing devices at much larger sizes. So we looked at what is the data of devices that are more than 40. This period of 2013 to 2018, 62 patients between who received devices between 40 to 48. Of course, in the next 3 years, 34 more patients got added up. And so now we have a cumulative experience of close to about 100 patients who had devices that are more than 40 millimeter. The usual age group, weight, the defect mean diameter of the defect was 38.3 plus or minus 4.7, and almost 50% of them had deficient margins. We are talking about adults, so a fair number of them had atrial arrhythmias already. Pulmonary hypertension, flow-dependent pulmonary hypertension in almost 40% of the patients. However, they all had operable PVRI. The QP by QS is quite high. We all know that it's a dependent shunt. The QP by QS can be 2:1 in a child of around 10 years, but when the child becomes 30 years or 40 years, with associated coronary artery disease, associated hypertension, being a dependent shunt, QP by QS will increase. And that is because of slightly elevation of left ventricular end diastolic pressure. So this is a 46 millimeter device that's going in a 42 millimeter defect. The other one that we are showing is a 48 millimeter. You can see that this patient has a sick sinus syndrome, AV nodal disease, is having dual chamber pacemaker. It's a 48 millimeter. So what we find is that devices of larger size are also reasonably safer, provided we choose the appropriate patient. In fact, custom devices are available even up to 54 millimeters, and this actually removes size as a criteria for selection of the patients. The second one is defects with deficient margins. We don't choose patients with posterior margin deficiency because there is a high chance of device slipping out, inferior margin due to device embolization, anterosuperior margin due to device erosion. So what is an absent margin? This is a, I'm showing two planes. One is, this is the bicaval plane, and the other one is the horizontal plane. You can appreciate in this bicaval plane that there is no inferior margin at all, but in the horizontal plane, there is a small posterior margin. So
our previous idea was that if suppose there is one margin deficiency, they are absolute contraindications, but we can realize that if you are able to anchor the device about 300 degree of a 360 degree circumference, that should be good enough to take care of stability of the device. So this is a 46 millimeter device that is running in a patient whose ASD is about 41 millimeter. You can see this frame here. So these procedures sometimes can be safer, but what we need is a careful understanding that the other margins are adequate. So this is the same patient who had an absent deficient inferior margin in the same bicaval view there. We're able to see that the left atrial disc is actually hitched on properly. Just another example. This is an absent posterior margin. This is a horizontal plane imaging, and this is a bicaval plane imaging. In bicaval, we have a small inferior margin, but in horizontal plane, we don't have a posterior margin. The same principles. If you have an anchor in the other zones, it may be possible. What we need is a thorough understanding of the transesophageal echocardiography. So you can achieve a closure. This is showing the same absent posterior margin, how the device hitches against the walls of the atria and ensures a closure. So what did we learn? We know that there are certain margins, but a deficiency or absence of one of the margin can be compensated by adequacy of the other margin, and hence it may do the work. Multiple atrial septal defects is another problem. If they are thin strands, then they can be closed with a single device, but if they are quite far away, they will need multiple devices. And if they need multiple devices, the questions that come to our mind is device stability, device to device interaction, and how to assess their size precisely. So this is 2 devices deployed. So we looked at our results of patients who needed multiple devices. So a group of around 25 patients over 6 years. What is the conclusion? It's feasible and safe. A careful echocardiography, sometimes even a balloon interrogation is important for successful closure. Sometimes it needs to be simultaneous, which means you should have bilateral groin access. And in fact, there were, contrary to our expectation, there were no additional new complications. The next question that comes in adults is ASDs with borderline PVR index. What is the definition of an acceptable criteria for a closure? The QP/Q should be more than 1.5 with the PVR index of less than 5 Wood units, PVR-SVR ratio of less than 0.3. If these patients have high values more than this, they should have an acute vasodilator testing with nitric oxide, and patients who get a positive vasodilator response, which means a 20% reduction in PA pressure or PVRI or PVR-SVR ratio, should have a partial closure. What is the meaning of partial closure? Using a fenestrated device. So this is a fenestrated device which is seen on fluoroscopy. This is the fenestration, and this is seen on transesophageal echocardiography. This is the fenestration. So leaving behind a 6 to 8 millimeter as a pop-off, so that in case if there is a future elevation of the pulmonary vascular resistance, this pop-off will ensure that these patients do not have progressive right heart failure. Of course, with intensive pulmonary vasodilator therapy, these patients are likely to have more stable course. So this is the fenestration. 3 years later, you study these patients hemodynamically to find out what is the PA pressure, and you just cross the fenestration in order to see what is the left atrial pressure. So the fenestrations do work permanently. And this is 6-year follow-up of a fenestrated device, transesophageal echocardiography, which shows that the fenestration is still flowing. Patients with restrictive LV physiology, adults, chronically volume overloaded left ventricle and elderly may fail to accommodate the sudden closure of a large ASD. The problem is very profound. If they have an uncontrolled associated systemic hypertension, coronary artery disease with diastolic dysfunction, more notorious in renal failure, and if some of these patients have diuretic resistance, they are the maximally affected ones. But these patients are very sick as well. To show an example, a very elderly patient, atrial fibrillation, severe congestive heart failure. You can see the cardiothoracic ratio. Almost for 2 to 3 months in a year, the patient will be in the hospital receiving heart failure therapy. The patient cannot tolerate anticoagulation due to recurrent bleeds as well. So it's getting a closure of the atrial LA appendage. Now you look at the size of the left ventricle and the left atrium in comparison to the entire heart. It's truly a restrictive LV. So this is the size of the left ventricle. See the size of the heart. The entire thing is only right atrium, right ventricle. So obviously, it's a classical example of a restrictive LV physiology. So a 44 millimeter fenestrated device is going up here. The patient is having an atrial appendage that is being closed, and this patient is continued on aspirin with 4-year follow-up, is doing quite well. So the protocol in these patients with elderly, with restrictive LV physiology will be pre-treat them, control the blood pressure, diuretics for heart failure. LV dysfunction can be managed with milrinone dopamine prior to the procedure. Check LVD in every adult before closure. If it is high, check after balloon occlusion or device occlusion. Consider fenestrated device. Post-procedure, continue diuretics for a longer period. Caution to be exercised if the patient has renal failure or diuretic resistance. Another problem that comes in elderly is sometimes absence of vascular access. This is a patient who was an adult whose echo windows will be poor. So you cannot identify very clearly whether they have an IVC. Hepatic veins will look like IVC. So this patient had a azygous continuation. This patient had some chronic DVT and was collateralized. But no longer this is a problem. These patients get transjugular device closures. This is an example of a transjugular device closure. The last one, superior vena cava type of ASD, SVC type of sinus venosus ASD. This used to be reasonably common in an adult because these patients tend to be missed in their early childhood. It's not easy to pick up a sinus venosus ASD by a conventional transthoracic echocardiogram because it's in one corner of the heart. It needs a subsified view and often they are missed. So it's quite common to see many sinus venosus ASDs in adult practice. The new transcatheter option is you put in a balloon across the SVCRA junction, have a parallel catheter in the right upper pulmonary vein, and you see that the balloon is actually completely occluding the SVC ASD and the pulmonary vein is getting routed into the left atrium. You check it with echocardiogram as well. This is the balloon across. You can see that there is no flow across the sinus venosus ASD here. So these patients get a covered stent. This is a covered stent that is getting deployed. Here you can appreciate that the right upper pulmonary vein is flowing only into the left atrium with no residual flows into the right atrium. You are continuously monitoring the right upper pulmonary vein pressures. So this closure is one of the recent advance in sinus venosus ASD, which has actually created a good hope for patients with sinus venosus ASD. This is our publication in Circulation and how to do it in Annals of Pediatric Cardiology. So combination, sometimes these patients have combinations of large secondum ASD with the sinus venosus ASD, and so you just do both separately. This is a secondum ASD which is being closed with a 36mm device and the sinus venosus ASD. So to summarize, ASDs are increasingly dealt in the cath lab and rarely need surgery today. Large secondum ASD more than 40mm, deficient rims, borderline PVRI, ASD in elderly, ASD with restrictive LV physiology, multiple defects, ASDs without femoral vein access, SVC type of ASD are all possible to be taken up for a transcatheter closure. This being the commonest grown-up congenital heart disease, this recent trend is actually a welcome trend for patients as well as many of the treating cardiologists. It's very difficult to send a 50 or 60-year symptomatic atrial septal defect patient to surgery. And when we know that it can be safely be performed in the cath lab, it's actually something that is worth considering. Thanks a lot for your kind attention.
Thank you, Dr. Shivakumar, for your comprehensive and illustrative lecture. And now, if there are any questions to Dr. Shivakumar, please. It seems there are no questions, so we'll proceed with to the next talk. Thank you, Dr. Shivakumar. Now, we would like to invite Dr. Professor D. Rajshekhar Garu for his lecture on tips and tricks in PBME. Dr. Rajshekhar is well known to all of us. He is a cardiology teacher in SWIMS.
Good afternoon, everybody. Am I audible?
And he's a HOD in SWIMS Tirupati, and he has trained many postgraduates, DM students in cardiology and teacher to general medicine students, etc. And very strong academician, and we would like to hear to you.
Good afternoon, everybody. I thank the chairpersons for the kind introduction. I am also thankful to the organizers of APCSI for giving me an opportunity to speak in this meeting. I am asked to speak on tips and tricks in PTMC. As we all know, rheumatic heart disease is an important cardiac issue world over, especially in the developing countries. And mitral stenosis is the most important manifestation of chronic rheumatic heart disease. We also know that ACC and AHA have categorized mitral stenosis into 4 stages, starting from progressive to symptomatic severe, A to D. And intervention is indicated in stage D and in some patients of stage C. All of us know about the classification of mitral stenosis into mild, moderate, and severe, depending upon the mean transmitral gradient and mitral valve area. And as far as intervention in mitral stenosis goes, it started with closed mitral valvotomy long back. Then subsequently, we have other procedures like open surgical valvotomy, valve replacement, and balloon mitral valvotomy. This slide shows the management strategy in patients with mitral stenosis depending upon the ACC-AHA stage and symptom status. If we are talking about PTMC or for that matter any intervention in patients with mitral stenosis, symptomatic severe mitral stenosis with valve area less than 1.5 centimeter square comes under stage D of ACC-AHA staging and has class 1 indication with level of evidence A. So also if you have a patient who has very severe mitral stenosis, by very severe mitral stenosis, we mean mitral valve area less than 1 centimeter square. If such a patient, even if he is asymptomatic, there is an indication for doing a PTMC with a class of indication of 2A and level of evidence C. So also there may be some more patients who have mitral valve area between 1 to 1.5 centimeter square, but are asymptomatic. In such patients also PTMC could be performed provided that the valve is pliable, and there is also some other co-existing conditions like documented atrial fibrillation, and the indication is class 2B with level of evidence C. As far as PTMC goes, it started in the year 1984 with a single balloon technique. Subsequently, we have the Inaugural balloon and double balloon techniques, and later on came the metallic commissurotome of Alan Kripke. As far as in our hospital goes, we have done over 2,000 cases of mitral valvuloplasty from 1994 till date, with a success rate of close to 99% and the complication rates are less than 1%. And also we have presented several scientific papers in conferences and also published about 20 original articles on this subject. I am asked to provide tips and tricks and I can cover them under certain headings like indications, scoring of mitral valve, case selection, contraindications, septal puncture, LV entry, complications and management of the patient post-procedure. As I said earlier, any patient who has got symptomatic severe mitral stenosis with valve area less than 1.5 centimeter square and has good valve morphology and has no contraindication is an indication to do PTMC. However, even in asymptomatic patients, one can do PTMC if the valve area is less than 1 centimeter square. The newer expanding indications for PTMC will include mitral restenosis, moderate MR, LA clot, certain types of LA clot, I will come to them little later, and as a hybrid procedure before AVR or CABG in a patient who requires aortic valve replacement or coronary bypass surgery, and in patients with low-term-Bashes syndrome. The contraindications for doing a PTMC will include significant and more than moderate MR, LA clot, subvalvular fusion, commissural calcification, presence of significant other valve disease, and coronary artery disease requiring CABG. Most important thing to do before performing a PTMC is to assess the valve, and Wilkins score is the most important echocardiographic assessment tool for deciding about PTMC. As we all know, Wilkins score takes into consideration mobility, valvar thickening, subvalvar thickening, and calcification. And points are given from 1 to 4 depending upon the severity of involvement. The minimum score possible is 4 and the maximum score possible is 16. Any patient having a score of less than 8 or 10 may be considered to be suitable for performing PTMC. The most important limitation of Wilkins score is that this score does not assess the commissural involvement. Also, it cannot differentiate between dense fibrosis and calcification. Subvalvar involvement is often underestimated in this scoring system. And also this scoring system does not use TE or 3D echo, which are modern imaging tools. Then came the read index. The good thing about this index is that it takes into consideration the commissural calcification. And the other scoring system is the cornea score. Here, fluoroscopically evident calcification is to fall in the area of mitral valve. And this helps to take into consideration calcification. Calcification can be of the leaflet or the commissures or even the annulus. Then most important and the useful scoring system is the real-time 3D echocardiographic scoring system. Basically, this system takes into consideration the various aspects like thickening of the leaflets and the subvalvar apparatus involvement. And the thickening of the leaflets is again categorized into A1, A2, and A3. P1, P2, P3, these are the scallops of the anterior and posterior mitral leaflets, and the thickness, mobility, and calcification are scored. So also the subvalvar apparatus is assessed at the level of proximal third, middle third, and the distal third in terms of thickness and separation, and appropriate scores are given. The maximum score that is possible is 31, and anybody who is having a score, say up to 8 is considered to having a good valve morphology. On the contrary, if the score is more than 14, one has to be careful in doing a PTMC. It's a very useful scoring system. The other important thing is to look at the commissures. The commissures may be free of calcium. If they are calcified, one commissure may be calcified or both commissures may be calcified. And the calcification in the commissure may be confined to one area or it may extend extensively across the calcium. So we need to look at it, and the results of PTMC will depend upon this. All of us know about Dr. Manjunath's classification of LA clot. Type 1 LA clot is one where there is it is confined to the LA appendage. In type 1B, the LA appendage clot bulges into the LA cavity. And in type 2A, there is a clot attached to the roof of the LA, but it is superior to the plane of fossa ovalis. Type 1A, type 1B, and type 2A LA clots, it is considered to be possible to do PTMC in experienced hands. And any clot which is more than type 2A, that is 2B to 3, 4, and 5, it's a contraindication for performing PTMC. When we come to echo assessment before procedure, we have to look at severity of mitral stenosis, pliability, presence of MR, LA thrombus, thickening of the intra-arterial septum, and presence of atrial septal aneurysm, severity of pulmonary arterial hypertension, presence and severity of other valve disease. So during the procedure, again, echo is useful. In the sense we can use the echo guidance for selecting the septal puncture site, and we can also monitor the patient for pericardial effusion during the procedure. And post-procedure, all of us know that we assess the patient in terms of valve area, gradients, mitral regurgitation, AST, pericardial effusion, regression of pulmonary arterial hypertension, and any increase in other valve gradients after opening the mitral valve. Septal puncture is the most important step in performing the PTMC. First of all, we should place a 3-2 wire in the innominate vein. Then we should place Mullin's dilator over that wire. Then we can load the bronch-and-borrowed needle into the Mullin's dilator, and we should keep it in such a way that the pointer marks towards 4 o'clock position. We should place the pigtail catheter at the aortic wall to serve as a landmark for septal puncture. Then we should withdraw the assembly, and when there is a medial jump and the tip of the needle touches the spine, then we can assess the fluoroscopic site for puncture. We can use the PA view or the RAO view or the lateral view or LAO view for puncture depending upon one's convenience. I use the lateral view. In the lateral view, we can draw an imaginary line from the pigtail catheter up to the posterior wall of the LA, and a point at the junction of 2/3, 1/3 of this line is the ideal site for puncture if you are interested in puncturing in the region of fossa ovalis. When in doubt, we can stain the septum, or we can do an RA angiogram, or we can use echo guidance. And the Brockenborough needles are also available in various sizes. We should choose a needle depending upon the various anatomical features like LA size, RA size, aortic dilatation, presence of kyphoscoliosis, and septal aneurysm and septal thickness. Perforation is common while performing the septal puncture, and the common sites of perforation are coronary sinus, LA roof, LA posterior wall, RA free wall, and needle perforation usually does not produce any complication. However, once the dilator is passed, pericardial effusion is inevitable. And if 14 French dilator and balloon has been passed, then cardiac tamponade could occur. At times, cardiac tamponade will occur after the balloon withdrawal only. So pericardiocentesis spray should always be kept ready in the cath lab when we are doing PTMC. And auto transfusion is advisable should a pericardial effusion occur. LV entry is usually done in the RAO view, and we use the stillet and give a J stillet and give an anti-clockwise torque. Generally, if the puncture site is posterior superior portion of the septum, LV entry is easy. On the contrary, if you puncture in the anterior inferior portions of the septum, LV entry could be difficult. In cases of large LA, we can use a reverse loop technique to facilitate LV entry. And also we may use a guide wire to enter the LV in case of severe subvalvular fusion. A balloon size is according to the height of the patient, height in centimeters by 10 by 10. This is known to everybody. Then this is the Mullins sheath and dilator and the Brockenborough needle. And this is how the Acura balloon or the Inaugural balloon looks like. And this is how the J stillet looks like. And we have to shape the J stillet according to the size of the LA and the septal puncture site. And this is just an illustration of the reverse loop technique to enter the LV in case of very large LA. So here is the procedure we did. So now we have placed a 3-2 wire in the innominate vein, and then we place the Mullins dilator and the Brockenborough needle inside the Mullins dilator. Then we place the pigtail as a marker for the aortic valve. Then the assembly is withdrawn, and here you can see that there is a medial jump. That is the point where most likely puncture could take place. And I try to confirm it in the lateral view. Here you find it that the dilator is pointing anteriorly, which is not correct because it is pointing at the aorta. So we need to adjust it, and we have done the adjustment, and now we are ready to puncture. And then we confirm in the AP view also. Then we puncture, and then we can see the contrast entering the LA. Then subsequent to that, we have to place the LA guide wire in the LA, then dilate the septum, then place the PTMC balloon in the LA, and use the J stillet to direct the balloon to the LV. So here you can see that the balloon has been directed into the LV. Once it has entered the LV, you will get ectopics. Then we inflate the distal balloon, pull it against the mitral valve, and then do the dilatation. So here you can see the entire procedure video. This was done recently. Withdrawal of the assembly, medial jump, then posteriorly pointing Mullins dilator, and the puncture is being done. Subsequently, we place the LA guide wire into through the Mullins dilator. Then we dilate the septum with a 14 French dilator. Then we place the balloon into the LA. Then we use the J stillet to facilitate entry into the left ventricle. And then once there, we inflate the distal balloon, pull the balloon and dilate, inflate. So this was a typical case done recently, and this patient required a fluoroscopy of 1 minute and 49 seconds. This is how I think we can perform a PTMC. The frequency has come down, probably related to the declining frequency of rheumatic heart disease. We were also doing many more cases, couple of 10 or 15 years back. Now the number of cases have come down, maybe weekly one we are doing. So with this, any questions? I'm willing to answer.
There is no questions.
Yeah. Yeah. No, not like that. See, the reverse loop is to be used only for the very large LA. And most of the time you find in this very large LA, the catheter itself, when you are trying to push, it forms this loop. Then we try to facilitate. Sometimes we pass wire only and see if the balloon is, the wire tip is going into the left ventricle. I have also done very few cases with the reverse loop technique. If it's not possible for me to do by the standard technique, probably in the reverse loop also, we may not succeed in entering the left ventricle. Most of the times, even when the LA is large, the entry difficulties are because of subvalvular fusion or an inappropriate puncture site. So all that you can do is sometimes verify whether the puncture site is appropriate, that is posterior superior aspect of the septum. If it is not, then probably we could try one more puncture and see if the LV entry is easy. If that doesn't work, whatever techniques are as described, we can try. And it is always there because for two reasons, the procedure may not be completed when we are doing PTMC. One is the failed transeptal puncture. Even in our hands, there are few instances when we have failed to do the transeptal puncture. And this is especially true when there is a large atrial septal aneurysm. And the other one is the LV entry, especially when there is a valve fusion and large LV. No, same day you can do many punctures, 3-4 punctures also you can do. Yeah, if you want to follow that, probably the Mullin's sheath should be kept there. Then we can use the Swan-Ganz catheter to enter the LV. Then afterwards, you can directly keep that loop, the LA guide wire in the left ventricle, and you can dilate. That's a very good technique. That is especially useful when there is LA clots also, because you will not disturb any LA clot.
Thank you, Rajshekar sir, for your illustrative lecture. Thank you, Chairpersons. We conclude this session here. The next session is a live in box. Dr. Christopher Malkin is a virtual presentation on TAVI. He's ready with his presentation. So I just want to add two statements here. One is that we don't have an formal lunch break, so please try to have lunch during this session or whenever it's convenient for you. And session 4, the symposium on will be all B, which is in the fifth floor. So we will have the live in-box TAVI by Dr. Christopher. Thanks, chairpersons. You can continue to sit or you can come and watch it from home.
Hi, good morning from Yorkshire in the UK. I hope you are having a great conference and you've recently celebrated Holy. My name is Chris Malkin. I'm an interventional structural cardiologist working in Leeds, and I've been asked to present a live in the box case to demonstrate TAVI in the UK using the self-expanding May-Thurner Evolute product. For those of us that do TAVI, we have moved on from just hoping that we get the valve working in the body. It's not just getting good hemodynamics with no leak. We're now interested in durability. We're interested in making sure that conduction disturbance, coronary access, and the future options for revalving are all in play. And that requires some specific maneuvers at the time of implant. This phenomenon of implanting the valve using a cusp overlap technique is one method that allows us to do that. That gives you a one-to-one appreciation of the annulus and the outflow tract and allows you to implant the valve higher in the outflow tract and reduces the risk of heart block and left bundle branch block. And secondly, knowledge of the anatomy of the patient into the delivery catheter of the valve allows you to implant the valve much as a surgeon would do, with commissure alignment of the TAVI valve closely approximated to the commissures of the patient's valve. And that's critical for being able to revalve the patient in the future and for reaccess. And it's critical to know how the anatomy of the patient and the fluoroscopic relationships of the TAVI valve fit together. On the left panel that you can see, the commissure of the TAVI valve is directly approximated to the C-tab of the loading capsule, and that's at a 90-degree parallel to what's called the C paddle. So you can see on the cartoon in the center panel, you have the C paddle and the hat are at 90 degrees to us. And only by knowing that and knowing where you are fluoroscopically in the patient, can you get the commissure of the TAVI valve to implant next to the commissure of the patient's valve. And that involves working in this so-called cusp overlap view, where the left and right commissures are overlapped. And that means on the right side of the screen is the left-right commissure of the patient, and on the right side of the screen will be the commissure of the TAVI valve. And there are some very simple maneuvers that you need to know, which is for this product anyway, you introduce the valve system into the body with the flush port at 3 o'clock. And you have to work in this so-called ariocaudal cusp overlap view that you see on the right side, where the LVOT is seen one-to-one fluoroscopically rather than foreshortened. And in the cath lab, what you see, of course, is this. You don't see the valve, you don't see the commissures. You have to rely on your CT that you've done beforehand to know where you're working. And you can see the hat marker in the lower red circle and the C-tab on the right side of the screen and the top circle. This valve is going to expand with its commissures next to the commissures of the patient. And when you deploy the valve, what you should see in the ariocaudal cusp overlap view is the C-tab on the far right of the screen. And this valve has been implanted, preserving commissural alignment. And this is important for two reasons. One is these long valves with supraannular leaflets can, if they're implanted anti-anatomically, i.e. without commissural alignment, they can stop you being able to reaccess the coronaries. But perhaps even more importantly, they can prevent you from revalving the patient. If the commissure comes above towards the sinotubular junction, then another valve inside it could cause sequestration of the coronaries, which would lead to real patient harm. So I'm now going to share a case with you, which is a live in the box case. And that should be playing now. So I'll just turn the volume down. So this is a case that I performed with my colleague, Dr. Cunnington. So on the right panel, you can see the cath lab. Now, this is a very high volume modern TAVI center in the UK. It's a light touch procedure. There is no anaesthetist in the room. There's a nurse looking after the patient. There are 2 consultant operators working with a scrub nurse. The patient is not sedated. Patient's awake, and you'll hear me talking to her later. I remember the patient very well. She was 78. She had some comorbidity. She was intermediate surgically risked, but had very good transfemoral options. And we elected to use a self-expanding device because she had very, very small anatomy with an annulus of around 18.5 millimeters. She had relatively light calcification on the valve, but she had a large septal bulge with an eccentric and even smaller LVOT. The sinuses, as you can see in this aortogram, were reasonably capacious, so we had no concerns about coronary jailing. And you can see that the hemodynamics on the right show that she had very significant hypertension. She had a very small LV cavity, so almost a sort of paradoxically low flow physiology with a relatively small invasive gradient, but actually hemodynamically it was having a significant effect on her. She was very symptomatic. And we felt that in this case, a supraannular valve would be the key for her, giving her the best possible hemodynamic result. In fact, that we calculated that an intra-annular balloon expanding valve probably would leave her with a residual gradient and would almost certainly give either moderate or moderate to severe patient prosthetic mismatch. You'll also see on the right panel that it's a single groin access. So the 16 French integrated evolute sheath is in the right leg. In the left leg, there is a needle in the skin that allows us to do LV wire pacing. We're just talking through the setup views here and just studying the hemodynamics. Now I'm going to wind forward a fraction. I will turn the volume up. So we're now going through the regular maneuver before any evolute valve implant. You have to screen the valve to make sure that it is loaded. This is one of our other nurses who's loaded the valve for us. So you have to fluoroscopically inspect the valve to check that the paddles are integrated into the pockets. You can see that at the bottom of the screen. And you inspect the braid of the valve to make sure that it's all aligned. We elected to do a direct implant in this case. So there's no pre-balloon valvuloplasty. So my colleague here is taking out the sheath that we've used to dilate the common femoral artery and iliacs, and I'm going to go straight in with the delivery capsule, as you can see. This video is not edited. We prepared it for some teaching sessions, but actually we never used this one. So you can see that. I'll just turn the volume up, but there's a lot of chat between myself and my colleague about what we're going to do and how we're going to do it. And this is the real world of TAVI, where you have to react to what you see. And you can see how the case evolves now. Let's turn the volume off. So if you look at my hands there, I've got my left hand on the front of the delivery catheter, and I've got my right hand on the wire. This gives really fantastic control of the valve and allows me to exert pressure both on the catheter and the wire. That can be very important. Secondly, this case was a bit of a challenge. The lady was so small, 48 kilos, if I remember. She had a very severe radial spasm, and you can actually see that throughout the procedure, the marker pigtail is never perfectly at the bottom of the non-coronary sinus. And of course, that pigtail is the critical marker, so that presented some extra challenges for us. The other major problem was that there was a very wide pulse pressure. You can see that on hemodynamics. I think actually that the wire and catheter at the moment are actually causing more AR than she had to start with. So we use a period of pacing. So initially moderate pacing of around 120, and then rapid pacing. You can see that going on in a few minutes to get the valve absolutely fixed in our eye at the point of contact from the non-coronary side and the left coronary side. Finally, you can see how this implant is different really to how it was even 3 years ago. You start very, very high with the delivery catheter only just below the pigtail, and you allow the valve to slowly come down inside it. And this minimizes the engagement of the equipment in the LVOT, and it's thought that that is one of the reasons that this implant technique reduces the risk of conduction disturbance. You can see that the valve is very high now. It's deliberately very high, and I'm allowing it to drift down into the desired position. So to those of you who've got a good eye at this, you think that the valve looks deep at the moment, but that's an illusion, because the pigtail is actually being pushed out of the sinus, and the pigtail is floating about 2-3 millimeters high. Actually, my colleague's is a bit stressed about that, but actually see when I do a picture here, you can see that actually the valve is perfectly placed 2 or 3 millimeters below. And we're going to go for it now. We'll do a period of moderately fast pacing to get it. So this is a three-dimensional structure, the valve and the patient. So you need 2 images to check the position. In this ariocaudal position, we can only really confidently assess what we see as the left-hand side of the valve, the non-coronary side, which is on the pigtail side. We need to assess the other side of the valve. We do that by going LAO towards the coplanar 3-cusp view. And then we're able to assess the left coronary side of the valve. So 2-dimensional structures need 3D structures need 2 2-dimensional images to assess them. And this looks perfect to me. It's about 2 to 3 millimeters on both sides. It's a really nice high implant. And I'm going to keep pressure in my left hand to make sure that this delivery catheter is pushed towards the greater curve. And you'll see that I will pull the wire out significantly so that the wire is floating. So there's no retrograde or aortic force on the system that could potentially allow the valve to slip up. one of the things that we were worried about in this case was the very small LVOT with a minor dimension of only 50 millimeters. We had some anxieties that that might allow the valve to slide up. So keeping that push on to the system until the very last moment. So there's no rush at this point. The valve is expanding all the time. The temptation is you just want to finish the procedure, but actually this is the time to go very, very slow. The valve is in a perfect position. You don't want it to move. So we are just taking our time here. And my colleague is, you can see the tiny movements he's doing with his right hand just to bring the delivery capsule off the paddles at the top of the valve, which is happening now. And I'm looking rigidly at the bottom of the valve to make sure that it is not moving. In fact, you will see that I had so much push on the system that actually I've managed to get the distal end of the capsule slightly engaged in the top of the cell. That's quite common. It's not a problem. You just need to be able to spot that. And we're just using the fluoroscopy to make sure that we're confident it's completely off. So the worst thing to do at this stage is to pull it out, just in case it's engaged in the top of the cell. So actually it is off, but the thing to do is actually to rotate the catheter, and eventually it just comes free by itself, as you can see there. Again, there's no rushing at this point. You can only adversely affect what should be a perfect result. So we keep LV access with the preformed safari wire, recapture the capsule and the nose cone, as you can see here, and then we'll take out the whole integrated system and reinsert a short 16 French Cook. And if we need to do a post-dilatation, then we can do that, or perhaps we'll just assess the hemodynamics and see what the result is. You can see that even though it's a very high implant, you probably could not go higher. There's a few ectopics of it. There is actually a bundle branch block. It's still sinus. So, conduction disturbance is still a factor of TAVI implant, but there's no major heart block. You probably missed that, but I was talking to the patient. It's quite nice to talk to the patient during the procedure sometimes. A lot of our patients are genuinely very interested in what we say and what we do. My colleague pulled the wire out. I told you this case wasn't perfect. I think that was merely a factor of just the size of the LV cavity just allowed the LV wire to come out. And it's one of those unforgivable things in interventional cardiology is pulling the wire out. But we do an aortogram now because I was so sure that the valve result would be good. So we see. I think there is a bundle here with normal PR relationship. There was a transient period of isorhythmic dissociation, so AV dissociation, which I think was just junctional. Actually, you can see the result hemodynamically is good. The gradient has gone. There's possibly a very tiny peak-to-peak gradient, but the LV-EDP is still low. Aortic diastolic is good. The patient's still hypertensive, but that looks pretty good. So I'm going to do a pullback now. This is quite nice. If you're a radial operator, you can use the femoral pigtail to pull the radial pigtail down the descending. It's quite a nice maneuver. I will just show you one final thing, which is the aortogram in the REO caudal projection. Now, if you remember from my initial presentation, I said that if we were going to achieve perfect commissural alignment, the C tab, which you see here, should be on the right-hand side of the screen. You can see that we're actually about 15 degrees off, but that should be enough to make sure that the commissure is at least 30 degrees away from the coronary. But to have it absolutely perfect commissure of the patient to neo-commissure of the valve, the C tab should be on the inner curve on the right-hand side of the screen as you see it. So I will stop the video just to say that this patient did very well. I saw her actually 2-3 months ago. She's in very good order. She did not need a pacemaker. She went home within 24 hours of the procedure. She was on her feet actually 6 hours later and went home, at 20 hours after the procedure was finished. So I hope you enjoyed that case. I don't know whether there are any questions from the floor. I'll just quickly go back to a mini presentation. So the implant you saw was essentially the most contemporaneous way that we are implanting the evolute valve. This so-called cusp overlap technique was tested in the proof of concept Pro Plus trial in the States, which is a all-comers implant using this so-called optimized procedure using the REO caudal cusp overlap view. And in this series, they showed that performing evolute implant in an REO caudal projection does actually get the pacing rate way down from what it had been traditionally with core valve evolute devices. In the evolute low risk trial, for example, the pacing rate was around 17%. But in this Pro Plus, using this just slightly modified implant technique that I've shown you on my case, the pacing rate was under 10%. And this was the CT of the patient you've just seen. You can see the LVOT in the top right panel with highly eccentric and very small. And you can see on the bottom the key things that you do need from your CT, which is the 3 cusp view on the left and the implant view, which is the REO caudal view on the right, with the green and the red dots superimposed. And that is the working view that gives us the ability to do both the cusp overlap technique and commissural alignment in most patients. So that was one of my typical cases. It was a 23mm Evolute Pro. I think this valve gave this patient the best possible hemodynamics, and I don't think she would have had such good result with intra-annular valve. She would have been left with a bigger gradient. It's a very light touch TAVI with non-GA, no sedation, single groin access. You saw a nice demonstration of a cusp overlap implant view in ariocaudal with nearly perfect, but not quite perfect commissural alignment. And you saw it in real time. The whole procedure from skin to skin was about 45 minutes. And I think you saw around 25 minutes of that. Thank you very much. I hope you enjoy the rest of your day and have a very successful conference. I'm going to sign off now, I think.
Thank you, Dr. Chris. Thank you very much. We all enjoyed your lecture. It's a very nice case, live in box. Thank you very much. Sorry for the delay that has happened.
That's okay. Bye.
Inaugural session is going to start. Please come inside. Please. We have finished. Please come inside. Please come inside. Please come inside as the inaugural function is going to start.
Good afternoon, guests. On the eve of that APCSI 2021, today conducting the organizing the commission and inaugural function, I would like to call Dr. K. Srinivas Reddy Garu come over the dais and preside the session.
Good evening, everybody. I request all the delegates, please come inside the hall. So today, since yesterday, we're having the Andhra Pradesh Cardiovascular Society of India conference, March 2022. You know, after this COVID era with a lot of difficulties, we are supposed to conduct this program in January. And one day before, because of the increasing Omicron cases, we have postponed. So we have to congratulate Sarita for taking a daring decision one day before the conference. And finally, happily, comfortably, today we are able to conduct this program without much stress or without much problems, because the number of cases of COVID is very, very less. So we had already a very good session yesterday afternoon, good workshop and nice postgraduate quiz and nice program. So today also we had a very nice deliberations of the scientific sessions, but with a little bit of delay, which is usually expected in this type of program. So today we will have a very brief inaugural function. And I will invite the guests to come onto the stage. First, I invite our daring and dynamic APCSI State President, Dr. Raghav Sharma Garu, to come onto the dais. I will next inviting our smart secretary, Dr. Karthik, to come onto the dais. I will now invite Dr. Vasanta Kumar, President. Dr. Vasanta Kumar, next President, APCSI. Organizing President, APCSI, Dr. Vasanta Kumar, if he is there, please come onto the dais. Now, I invite our honorable guest of the evening, Chairman, Andhra Pradesh Medical Council, Dr. Samseva Reddy, a famous neurosurgeon, who is known to everybody here. In fact, he's a classmate of daring and dashing cardiologist, Dr. Sriman Narayana. Now I invite Dr. Samseva Reddy to come onto the dais. Next, we will have lighting of the lamp. Vasanta. We welcome Vasant, organizing president, onto the dais. Dr. Vasant Kumar, senior most cardiologist in Kurnool. I now request Dr. Raghav Sharma Garu, President APCSI, to have a brief address of the gathering.
Good afternoon, everybody. First of all, I would like to thank our Chief Justice Samsaya Reddy Garu and the organizing people here to have one of the best gatherings in spite of the fear of underlying fear we still have of the COVID. Actually, when for the last 2 years we've been suffering for this fear of COVID and with the series of lockdowns. It was very disheartening, when it's going to end. And luckily, it looks that it is almost end now. And hardly we see any cases, even if a few are there, which is a milder variation. So now with full enthusiasm and vigor, we started this conference and we can see a good gathering here that speaks of it. We thought of going very high when we took up this post 2 years back. But after that, we know what happened. In spite of that, sir, we can say that our Cardiology Society of India, Andhra Pradesh chapter has contributed probably very high numbers for national registry in COVID and COVID heart diseases. I think thanks to the efforts of our secretaries and the members of the society that really we churned up a lot of data, and probably ours is the largest in the national registry. And the second one is, in spite of this COVID, where the hospitals are closed down and the patients are scared to come, and all that we are treating only COVID, not cardiac much. But in spite of that, we continued our academic interests, thanks to some of our people. Of course, I would like to name few: Poonanand Garu, Sinha Garu, Gopal Krishna Garu, like the stalwarts, who continue to conduct these programs, webinars, and so that we are still alive academically, though not regularly coming into these conferences. Now the things are settled. I hope the next team probably is going to take off from this and take it to a higher level, and it's going to be colorful. I wish all the best for the new team, and thank you very much for this opportunity given to me. Thank you very much.
Next, we will invite our honorable guest, Dr. Samsaya Reddy Garu. So, Dr. Samsaya Reddy Garu is known to everybody. In fact, he is the student of Guntur Medical College. He is a very prolific cricket player. There are 3 areas where he has shown a lot of impact in the field of medical and health in the state of Andhra Pradesh. Number 1, COVID. During COVID era, we should proudly say that the state of Andhra Pradesh has treated a lot of poor patients without much financial burden, just because of one of the hard work by Dr. Samsaya Reddy. We had to, in the neighboring states, there is a lot of exploitation has gone, but Andhra Pradesh has done very good work. The second, the chairman, Andhra Pradesh Medical Council, has done a lot of reforms, and now Andhra Pradesh Medical Council has one of the largest number of medical graduates being registered. If you observe, the flow of doctors into Andhra Pradesh is enormous. The third area is in the field of Atherectomy. It was very communicable with the Atherectomy network hospitals. The doctors of the Atherectomy network hospitals has done a lot of reforms, and he made us comfortable to have a dialogue with the administration of Atherectomy. So thank you, sir, for these 3 nice words. Give him a big hand. And now I invite Dr. Samsaya Reddy to address this cardiologist, senior cardiologist, and junior cardiologist, his experiences, and as a representative of the government, his advisors also. Thank you very much.
Good afternoon, ladies and gentlemen. Thank you for the nice words, Dr. Srinivas Reddy Garu, who was our teacher when I joined my medicine, I think he was assistant professor at Guntur. And thanks for the organizing committee for inviting me as a guest for this great occasion. And it's very happy for me to come to this conference, Cardiology State Conference. And this is the second time I'm attending this function. Last year it was not conducted. Why? Because not just as a guest, I have lots of friends. My classmates have so many cardiologists practicing here, like Sriman Narayana is my classmate. Mahesh is my classmate. And Harita, who is, my classmates better off. So, and my teachers like Srinivas Reddy Garu and Babu Rao Garu, when I joined Guntur Medical College in 1991, that time itself, we used to have a centralized monitoring system, wherein that room used to be the only air-conditioned room in the hospital outside of the operation theaters. So used to be very comfortable going there, sitting and looking at those monitors as a intern. And and as I belong to Guntur Medical College, I think very happy to come over to this place. I can also see Dr. Chandrasekhar Garu, who is a senior professor and cardiologist, whom we worked with during the COVID times. We had everyday sessions and lots of discussions went on during that period. At the outset, one more reason I come to cardiology conference is I envy cardiologists. Why? Because whomever the education went into the societies across the world by the cardiologists about the cardiac disease profile is tremendous. Any patient, even if he is young also, he doesn't hesitate to say that, I underwent the angiogram, I underwent a PTCA, I am on antiplatelet, I am on a statin. Patient doesn't hesitate to come out and say about their disease, cardiac disease, but it's not the case with, say, a neurological disorder like an epilepsy, wherein patient usually don't come out and say that, I'm suffering from epilepsy or I am using a anti-epileptic. That's because I feel that the education went into the societies by the cardiology professionals. That's what matters. I think in that sense, I think cardiologists did a tremendous job. So, as I told you, when I joined the GMC in 1991, that time, the cardiology was just in the initial stages wherein the intravenous thrombolysis started, and there were only few ICU beds there, no cath lab. From that stage in 1991, I think today we have cath labs or heart-lung machines, which percolated to each nook and corner. And as I was speaking to Srinivas Reddy from Narsaraopet, he says there are 3 cath labs in Narsaraopet and 4 or 5 cardiologists practicing over there. I think tremendous improvements in cardiac services in the state of Andhra Pradesh. Though we had a problem with the partition wherein all the tertiary care services were concentrated in Hyderabad. Even then, within the short span of few years' time, we could deliver all the services which were happening in Hyderabad, including the pediatric cardiac services, both interventions wise as well as pediatric surgery is also being happening in the state of Andhra Pradesh. I think big congratulations to the team of cardiologists practicing in the state of Andhra Pradesh. So you invited me, being a medical council chairman. I need to talk about a bit of ethics as well. So bear with me as to the ethical part of it. One is, see, medical practice is unique. Although hospital is an industry, medical practice is quite unique, wherein if you go to a shop and purchase a product, you know why you are purchasing that product, what is the cost of it, and what is the use of it, whether you really need it or not. But when a patient comes to a hospital and to a doctor, he doesn't know what he is going to get diagnosed with. And even if you tell him the diagnosis, he doesn't know what exactly it is. And you ask for investigations at your own hospital, which he will get them done. And then you will prescribe medicine, which he will buy from your own hospital pharmacy. So in all these transactions, actually, he doesn't know much of what is happening. With all these conflicts of interest for a doctor, you need to be a god to not to cheat a patient. So that's what we do. We don't cheat. That's the reason why they place doctor next to God. But that feeling from the society or the patients or the public or the governments towards the doctor community, we should keep that at a high level rather than, we should not degrade that to such a level wherein they start suspecting each and every move you make or thing you do with the patient. That is what is happening now. Slowly, that faith is fading away. That trust is going off. It's our own making. It's our own making. It's not that someone else is doing it. It's our own making. As I entered Guntur from Vijayawada, what I see is big hoardings with all the doctors, dressed up in OT dresses, big hoardings about their hospital and their services, which is totally unethical. Shame on those doctors who put up such hoardings. You go to any town, you see those big hoardings. See, what you are trying to do is you are trying to market yourself and you are trying to get patients in different means. The highest happiness any physician will get when a colleague physician refers a patient to you. That's when you get the highest happiness. That is the proudest moment, when a colleague physician recognizing that your capabilities are much higher than himself and referring a patient. Not an RMP or a quack sending a patient for few bucks. This has to get percolated to the practicing physicians, and it is the elders' duty also to educate the youngsters about the medical practice and the ethics. And hopefully the elders take up this without fail. Otherwise, I think this is going to degrade further, and the attacks on the hospitals or the doctors, the loss of faith. And as you see, one more example I tell you. When I was doing my neurosurgery training at NIMS, they introduced this digital attendance system. That time I was a resident, that time 4th year or 3rd year resident. We were totally opposed to that. See, I'm working there 36 hours continuously, night duty, and then again working for another 12 hours, going home maybe once in 2 days, 3 days. Still, they want my attendance. No way. This is atrocious. So, we did not put attendance. Somehow we managed it. But afterwards, I went to UK, wherein all the managers, other staff of the hospital, CEOs also, they have to put the digital attendance, but not the doctors. Why? Why? Because we take the responsibility of the patient. We are the ones who are, who can come and ask about the patient, and we will not shy away from that responsibility. That's the reason why we don't need attendance. But now what happened? The digital attendance has become a norm in all the government hospitals. Recently, I think the selfie thing also has come up. I don't know where it's going to end up. It's all, our own making. If we had continued to take up that responsibility of the patient, if we are reasonable, probably society won't think, governments won't think in those lights. That's what elders should train the youngsters and tell them, this is not the way we used to practice, or this is the way we should be practicing. So hopefully, I think we learn from the past mistakes, and at least we as a community will stand high next to that God. And the other thing is about professional bodies, like meetings like these. These are very, very important. Like what's happening in most of the towns, like in smaller towns or even in Guntur, most of them are individual doctors practicing rather than say a institutional practice wherein you have multiple doctors practicing in the same subspecialty, wherein you have some guy watching what you do. But here, as an independent doctor, you are setting up a hospital and you are practicing. There is no one to monitor, like, you know, what you are doing, whether you're doing right way or wrong way. We really don't know. Especially in those situations, I think these professional bodies are very, very important, wherein at least a town professional body or a city professional bodies, which should be formed, and they should be regularly meeting and discussing about what they are doing. That way, at least, patients at the end of the day will get the benefits. Otherwise, what's happening is one mistake you'll do, you get away, and then your mistakes will pile up if we don't discuss that. Like we used to have one neuro interventions complications week. You know, in that conference, we only used to discuss only the complications. You never present post-ups doing something, you know, big or great. So you only present what complications you had in that year. That's it. So that's how you learn. That's how you pass on that whatever learning you had to the patient benefit. That's what we should be doing. So these professional bodies, like, you know, we used to have Twin Cities Neuro Club. Every month we used to meet all the neurologists, neurosurgeons. They come and they present and they'll have a chat, so that you will be, you know, practicing the current trend rather than, you know, practicing in what you have learned about 10 years or 15 years back. That's why AP Medical Council also is very willing to promote these activities, and that we try to give the credits whatever the conferences deserve. And even we are supporting some of these paraclinical departments with some monetary aspect as well. So, and the other aspect, before I finish, I'd like to say about the Arogyashri. See, some of the cardiac packages are definitely low. We are working on that. Very soon we are going to come up with a reasonable packages. Hopefully, I'll try my best to keep the packages at a reasonable level, which are workable as well. The other request which came up was the angiograms are not being paid for. Even that aspect where I will discuss and try my best to compensate, at least to a certain extent, may not be to the full extent, but to a certain extent, I'll try my best to get that done. So with that, I think I don't want to, you know, sort of prolong your sessions. That I thank once again the organizers, Nagav Sharma garu, Srinivas Reddy garu, Arita, and my friends and colleagues. Thank you once again, and all the best. Thank you.
Thank you, sir, for your nice presentation. And definitely think our junior cardiologists who are coming, they are very dynamic. And most of them are following the ethical systems and practicing nicely. They'll follow system. And Arogyashri, I request you to try to hike the packages and include the modern technology like IVAS, OCT, rotablations also in the package, reasonable packages, so that most of these Arogyashri beneficiaries will also be benefited by these modern technology. That is another thing we want to think. And then the payments, prompt payment as well. So three things I think we will take up this matter and discuss with the government. Thank you very much. regarding the research and all those things also, we are also planning to have, and our Secretary Karthik will have 2 words about these things. We're also having these registries and complications. We should have a complications registries, because most of us will be shying of staying away from the complications to disclose. So unless we disclose our complications, we are not complete in our profession. So because from that area where we learn, so I request the cardiologist of Andhra Pradesh to have a complication registry and come forward, discuss, and then present their complications so that the learning will be better. So I request Karthik to have few words as a secretary of APCS.
So thank you, sir. It's been almost 2 years since all of us met from Rajahmundry. It is so nice to see all the elders back and having a big academic session. And we have few younger cardiologists who have joined us in the last 2 years. And we made quite a good amount of progress representing our work in the national level. At the National CSI Registry of AMI during COVID times, we had 42,000 patients all across the world, all across India. And APCSI has contributed to 3,800 patients. And I should thank all the contributors. That is why I wanted to speak actually. Dr. Anjit, Dr. Monica, Dr. Siman Narayana, Dr. Anil Mahopatra, Dr. Sujata Madam, Dr. C.S. Raju, Dr. Hitesh Reddy, Dr. Jahangir Basha, Dr. Madhuri, Dr. Mata Srinivas, Dr. Muhammad Ali, Dr. Nishan, Dr. Ram, Dr. Ramesh Babu Garu, and Dr. Shiva Reddy, Sridhar Babu, and Dr. Vasant Kumar Garu, and none other than the leading contributor, Dr. Raghav Sharma Garu, who is our president, and even Dr. Murali Krishnan Garu, Dr. Ramaraj Garu, and Dr. Chalan. So all of us have created a voice. At least we are doing some amount of reasonable academic work from our APCSI after a long time. I hope all the newer generation and younger generations also contribute, because there are lots of registries which has been started at the national level. Various committees have been formed. I want a little bit more involvement from the younger people so that we can be represented more in various levels and at various registries as well. And thank you, Srinivas Reddy Garu and Raghav Sharma Garu and Dr. Haritha Garu for organizing this conference amidst a big, I would say, response last time, and now we pulled it off nicely. Thank you for organizing, and thank you all for making it a big successful story.
Next is a brief merit certificate presentation. Dr. Cherukuri Sarachandra, Dr. Paul Kiran, Dr. Ashok Raj Alluri, please come forward. The certificates will be presented by our chief guest, Dr. Sam Sivaret. Dr. Cherukuri Sarachandra. Come. Best outgoing students. These are best outgoing student merit from Kurnool Medical College. Dr. Saraj Chandra. Dr. Paul Kiran. Can you introduce yourself, please? You introduce yourself from which college and what? Okay. Dr. Ashok Razu Alluri.
He's been the best outgoing student from the NTR University of Health Sciences from DM Cardiology of the year 2020.
So women are making a lot of impact in the society. So there were a lot of women cardiologists are coming in the country, in our areas also. There is actually the women cardiology committee is also going on. So today we have Dr. Haritha, first women cardiologist, will be conducting a conference. So you just give a big hand to her. So she has done nicely. almost single-handedly. So now I invite Harita to close the session with vote of thanks.
All the seniors, they were so accommodative, and they used to, everything they used to say, you go ahead and we will support you. And I would like to thank and just came a long way from various distant places. And I'd like to thank Ramesh Babu, who encouraged me to conduct this. And I would like to thank the organizing committee members, especially the chairman, Dr. Angiographic. He used to wipe out all the sudden turbulences while conducting this conference with a small smile, and many of the problems within minutes he used to solve during this conference. Dr. Srinivas Reddy sir, also, he is a never no person. Whatever we ask, he will say yes. So like that, I'm very happy and thankful. My colleagues, Dr. Srikar and Somshekar, I have to mention and thank supported me regarding this one. And all the members, there is no time to all the committee members, they supported me and last people supported.
We'll close the inaugural function and continue to the academic session. Next, I think we have a very, very good and encouraging academic sessions.
Sujata madam, Vanaja madam, Hema. No madam, just one single picture. They are arranged in the madam. We will have.
Let's start the post-lent session. Moderators for the session would be first one would be NANO versus SAVR. SAVR also is Barwa sir, can you also be the moderator? I think we have we have heard about the structural heart disease treatment some time back. This is coming up kind of treatment which is really required for cardiologists. We have a very experienced person, Dr. CV, and Dr. Gopisant as a surgeon. CV is talking in favor of TAVI, and Dr. Gopisant is talking in favor of SAVR. I think understanding this difference, advantage, disadvantages of the percutaneous treatment and the surgical treatment is very, very important before we embark into these technologies. I think Dr. CV Rao is going to enlighten us regarding the TAVI, and I request Dr. CV to start.
Thank you, Dr. Barwa. Good afternoon, and thank you, the organizing committee, for giving us this opportunity. The world of cardiology had actually seen three major paradigm shifts. The first one was in 1977, as we all know, that Andreas Guntur started the coronary angioplasty. And then followed in 1986 with first coronary stent placement by Sigvart and Kuel. And then came in 94 when we were the residents, and we were very excited about these two landmark trials, that is Benistent and Stress by Patrick Serious and Fishman. And then it took almost a decade and a half for the next paradigm shift to happen in cardiology, which we call as TAVI today. Martin Leon, in his landmark article, which is published in NEJM in 2011, has paved the way for a remarkable change in the way in which we were treating our cardiology or structural heart programs. So actually, today's topic is a kind of a debate, they name it, but then the arena or the entire story is still evolving. There is no, as the previous somebody had spoken about some area like OCT or IVUS, they are each complementary. Similarly, TAVI and SAVR are both complementary, and we cannot really say that this is the cohort in which only TAVR is important and this is the cohort, only SAVR is important. There is no firm cleavage. So it is important for us to understand that there are specific situations where the TAVR is extremely useful, and there are some cohorts or rather arenas where the surgical atrial valve replacement still holds the priority in patient care. Having said that, today's debate, we have a very, very strong opponent in favor of SAVR in the form of Dr. Govichand, who is a doyen of cardiac surgery in the outstate as well as in the country. And I am supported by the world literature and the accumulated experience of TAVR and with my little experience in my own clinical practice. So let's go through the whole story. So whenever we are talking about an aortic stenosis, the patients do come, we are supposed to risk stratify them into high risk, intermediate risk, and low risk. And there are several risk scores that are available. The famous ones are STS-PROM, and then of course the Euroscore 2, and basing on which you triage the patients into risk categories. And as far as the high risk zone is concerned, only mortality improvements matter. The rest of things really do not matter because, like, for example, we are talking about an acute kidney injury or some, some bleeding and all that, because it is any treatment modality in a very high risk zone is what matters is the patient should be living, whatever you do. So it is a mortality benefit that you're looking at when it comes to the question of high risk. Whereas whenever you're talking about intermediate and low risk, host of other issues also need to be considered because it is not just mortality, because a patient who is belonging to the intermediate or low risk category will have to live and also will have to live well. Not just live, but will have to live well. So the host of other issues also need to be considered, like atrial fibrillation and paravalvular leaks, acute kidney injury, vascular complications, associated coronary artery disease, access issues, and so on and so forth. So when you are making a choice between TAVR and SAVR, so in intermediate and low risk categories, it is not just enough. If you talk about only mortality or a stroke, you have to also consider the other major issues, which make a lot of difference to the patient's life when once the procedures are done. As a snapshot, if you have to talk about SAVR and TAVR, the mortality and stroke are better with TAVR at the early time points after the treatments. For example, at perioperatively or peri-procedural outcomes, or at 30-day outcomes, or at a 1-year outcomes, the TAVR generally is far, far better in terms of mortality and stroke. But if you look at 5 years, the outcomes, they even out, and the TAVR is non-inferior to SAVR. The second important issue is, as a general rule, acute kidney injury, bleeding, atrial fibrillation, and resource utilization is far higher with SAVR as compared to TAVR. But the SAVR scores in two arenas significantly in terms of paravalvular leaks. Paravalvular leaks are significantly higher with TAVR compared to surgical aortic valve replacements because of the various technical issues. Similarly, the new onset bundle branch blocks or the need for permanent pacemaker implants are higher with TAVR, especially with balloon expandable valves, not with the self-expanding valves, not balloon expandable valves. So the other important snapshot is a very large cohort of aortic stenosis patients is excluded in the major clinical trials. For example, the low risk trials that have been published in 2019, they have an age group of 70 to 74. So if you just take the cutoff of 70 years for the low risk, anything less than 70, especially the bicuspid aortic valves and bicuspid aortic valve induced aortic stenosis and so on, they are largely excluded from all the clinical studies. So we really don't know what would be the ideal treatment choice in this particular cohort. And actually, if you really look at our own population, the aortic stenosis comprises of less than 70 years, not to a very little degree. a huge body of patients where the aortic stenosis is significant in less than 70 years of age. So the answers to this particular cohort is not very clear in the world experience. So what I'm going to do is I'm going to navigate into the next few minutes by the risk categorization and the only major landmark trials and the experience therein. Because it's very important, very difficult for me to really narrate and then explain and then expound the various trials that have come in. I'm only going to stick to only the landmark trials in the TAVR landscape. So when there is an extreme, there are high risk trials are two. Classically, partner 1 and US pivotal core valve trial. Intermediate risk trials are partner 2 and TAVI, and low risk trials which are published in 2019 are partner 3 and low risk core valve study. Coming to the high risk, partner 1 actually had 2 cohorts. One is partner 1B, where the surgery is totally unsuitable. Surgery was excluded, patients were refused surgery, and the patients were given TAVR, and then they were compared to the standard therapy, which was an optimal medical management. So obviously, the TAVR has resulted in a significantly improved death and stroke and rehospitalization and functional class. It is understandable because basically from nothing, patients did get some kind of a treatment. So that is a foregone conclusion where the very, very high risk and surgery is unsuitable, TAVR is the choice. Whereas partner 1A cohort is associated with a very high risk subset wherein the TAVR is compared to SAVR. Again, TAVR scored considerably higher or better than SAVR, except in stroke where the TAVR was associated with a higher stroke rate. But the point to be noted here is these were all very early days where the TAVR was done with a very, first generation transcutaneous heart valves. And also the technology and the technique of doing the procedures were also a little rustic. So the TAVR was associated with stroke, and subsequent experience as the story evolved, the stroke rate has come down significantly with TAVRs. So looking at the 5-year data of partner 1 compared to the standard treatment group, which was medical management, as expected at 5 years also, the mortality and stroke rates, the TAVR scored considerably better than the standard treatment schedules. The important issue here is that, of course, the other indices are the echocardiographically when the patients are looked at the end of 5 years. The durability of the transcutaneous heart valves, which is an important issue because as the time passes, there was always a doubt whether the transcutaneous heart valves are going to perform well or not. Even at the end of 5 years, the aortic valve areas around 1.5 and mean gradients were very low. So which really proved to the world that yes, the heart valves are completely durable and they are sustainable. The second high-risk study is US core valve high-risk study. Here, if you look at the 1-year mortality, there is definitely an improvement compared to the SAVR. And at 5 years, the mortality and the stroke rates evened out between the TAVR and also the SAVR. Again, the TAVR is non-inferior in this particular cohort, even at the later endpoints or time points at 5 years also. Coming to intermediate risk, then the focus shifted from very high risk because it's already confirmed and a very clear benefit that the TAVR had produced in comparison to TAVR, in comparison to SAVR in high risk zone. So the expansion and experience has got into intermediate and low risk zones. And partner 2 was published, and wherein the all-cause death and stroke were significantly lower in TAVR, but then statistically speaking, the statistics showed that the TAVR and SAVR, both of them are non-inferior to each other at the 2 years in intermediate risk. But when they're talking about all-cause death and stroke, the TAVR was done from multiple puncture sites. The TAVR was done from transclavian, transcarotid, and also transapical. And if they when they looked at transfemoral TAVR, there were low rates of death and stroke compared to SAVR. So when they included all the axes together, the TAVR was non-inferior to SAVR, but when they looked at only transfemoral TAVR, then the TAVR scored over the SAVR. And because it is intermediate and low risk, the other issues also come into play. The TAVR was associated with larger aortic valve area. There was less late fibrillation and AKI, as we mentioned before. There were less vascular complications and less PVL with SAVR, as expected. So this is again non-inferiority at the curves were merging at 2 years stroke, and then the anesthesia time, procedure time was significantly lower or less with TAVR as compared to SAVR in intermediate in partner 2. The median ICU stay and LOS, which are very important surrogates for the doctor managers today, is far better with TAVR as compared to SAVR. AVA, as I said, it is better with TAVR. Paravalvular regurgitation is definitely more with core valve, that is a self-expanding valve. So they found that moderate to severe paravalvular leak is higher with TAVR. Compared to the intermediate, in coming to intermediate risk with self-expanding valves, again, there is a lot of improvements with the aortic valve area, and aortic mean gradients were lower with TAVR, and mortality and rehospitalization is far better with TAVR. But again, in intermediate zone in the core valve also, the TAVR was non-inferior to SAVR. So coming to the low risk, this is the most contentious area, because initially after the FDA has approved TAVR as a treatment modality and gave the class 1 indication for TAVR in low risk, there were several criticisms about the decision, because people even questioned the way in which the partner 3 trial was formulated. But whatever it is, the partner 3 low risk has shown that the mortality and the primary endpoint, all-cause mortality, death, stroke, all of them scored better with TAVR than SAVR, even at the end of 1 year and also 2 years. And patients' symptomatology is also much better with TAVR, and 6-minute walk test is better, and the quality of life indices were better. And the Evolute low risk trial also has proven that TAVR is non-inferior to SAVR, including mortality and hospitalization at 1 year and stuff. So in almost all patient metrics, the TAVR was non-inferior to SAVR, both in intermediate as well as low risk categories. The only 2 issues with TAVR were, one is the need for permanent pacemaker implant, which is higher. And second is anything moderate to severe paravalvular leak is higher with TAVR. Whereas the mortality, rehospitalization, quality of life indices, patient prosthetic mismatch, AKI, and the atrial fibrillation, everything is far less compared to surgical aortic replacement. So intermediate low risk, in fact, they said there was a meta-analysis of all the low risk and intermediate risk trials, wherein they finally concluded among older low risk patients with severe aortic stenosis, TAVR was associated with the low rate of death and disabling stroke compared with SAVR. But then again, the quality of life, reduced bleeding, atrial fibrillation, higher paravalvular leak, pacemaker implant rates, they're all, as expected. So how do we go about now, which is particularly important for our patient population? As I said in the opening issue itself, there is a very large cohort of patients, less than 70 years, about which we don't have any answers. And that is part number 1. Part number 2, all said and done, there is a huge learning curve for the TAVR. And my own experience of say 8 or 10 cases, and I'm sure that other people also would agree, the learning curve is not that easy, because basically the more the number of patients that we do, the more obviously we get the experience and then the outcomes also will be better. Having said that, getting into the TAVR zone is associated with a lot of financial issues. So that also becomes an important issue when once you are talking about improving one's own learning curve or improving through that, navigating through the entire landscape of TAVR. So keeping that in view, I don't think we can just offer TAVR to each and everybody or each and every person with aortic stenosis at large. We need to have a kind of a balance. Apart from the technology itself, which is still evolving, there are so many unanswered questions. For example, they said that if you really follow the CT scans of the TAVR, post-TAVR, the leaflet thickening of a particular cutoff points may be associated with a thrombus. And whether these particular issues need to be treated with anticoagulant or no, whether they are associated with any delayed strokes or delayed embolisms, we have no data. And then when once the TAVR, the transcutaneous heart valve, got into degeneration, then what is that? What is the story after the degeneration, after the PVL? We really don't. Now PVLs can be closed. That's not a problem. PVLs can be closed transcutaneously again. We can put some plugs and then we can close those leaks. And the pacemakers, we all know what is the morbidity associated with the pacemakers. All said and done, if you really see the pacemaker implants and then with a dual chamber pacemaker, the patient's ability or patient's performance in terms of quality of life and going into a kind of a heart failure are the real world scenarios. So in other words, in short, we really don't know the longevity of the TAVR and what are the futuristic issues with the TAVR, with the TAVR. But to give a generalization, in high-risk zones, there is absolutely no confusion. The patients will do well, with the TAVR as against the SAVR, because SAVR is definitely associated with much worse performances in high-risk zones. But as well as intermediate and low-risk zones, it needs to be a kind of a informed, shared decision, including the cardiologist, cardiac surgeon, and then of course the patients and patients' families, fully understanding the implications into the future. Unless we really consider all the parameters, we can't really jump into the fray and then say that TAVR is the treatment. So because there are so many unanswered questions in this area. So that's where I stop, and then I allow Dr. Govijan to take over, and then I'll give my final verdict. So your slides.
Sir, next talk I invite Dr. Govijan Garu. Govijan Garu does not require any introduction here. Everyone knows him. He's a big name in cardiac surgery, and he is known worldwide, not only in the medical faculty but also among his patients. Everyone knows him. I hear many great cardiologists talking about him. Any complex case, only Dr. Govijan can do this. So that is his name. Sir, please take over.
Thank you. Thank you very much. First of all, I want to thank the organizers of this conference for thinking that I am eligible to talk here. I don't think there's any a single surgeon in the audience, so I'll probably be committing suicide talking here against Dr. C. Rao. But I have to say what I have to say on this matter.
Thanks. So when in structural heart treatment, there's always this dilemma. The picture on the right side is college, medical college, Guntur Medical College, and that's the TAVR guy, not even showing his face, but trying to make an impact. I hear what Dr. Sivirao has to say, and I'm sure a lot of the audience believe that we have found a new way of treating aortic valve stenosis, but there's a long way to go. The road is still very, very long and bumpy. I remind all of you, especially physicians, about William Osler's quote, famous quote: "A good physician treats the disease, but a great physician treats the patient who has the disease." So we should not lose the sight of what we're trying to achieve while we're attempting to help a patient for a better life, both in terms of longevity as well as the quality of life. Yes, we have a new gadget, but is it the right thing for everyone? So we have to strive to find the right indication for this new technology. It is here to stay. There's no doubt about it, and it has a place to play its role. But what is that is still unclear. So if each one of us have an option, then we will use only one procedure and one valve. But we're not there yet, and I don't know whether we will ever be. But that's the ideal. So against that ideal, we need to understand where we are and probably work towards it. I want to give you a couple of scenarios I faced. One is this young lady, 29 years, who has dyslipidemias with patches all over the face and other places, deposits of the lipids, has class 3 symptoms and has severe aortic stenosis and needs treatment, but she desires to have children. This is a doctor from Vizag, who's a 62-year-old. My wife is also a doctor. 2 years history of glomerulonephritis and severe proteinuria, and he's on immunosuppressant. Worse, and he has severe aortic stenosis. So the potential surgical complications are worsening of his renal function, needing dialysis, infections because of the immunosuppressions, poor wound healing, and possibility of future renal transplant. So this is the kind of practice we are in every day. Trials, randomized control trials, and individual experiences published is one thing. When we have a patient sitting in front of us, we have to make sense out of what is written and what is our practice, what is our experience versus what we do with this particular patient. This is all philosophy. But generally speaking, if you have a 60-year-old, this particular doctor, if he were to have a SAVR at the time of presentation, he would probably need 2 surgeries if it is a tissue valve, if he lives long enough. If you start with TAVR, he may end up with 3 procedures, either 2 valve-in-valves, TAVRs, and then subsequently SVR. As of now, that's the experience. And we can have 1 mechanical valve with its own separate set of complications. It's further complicated by introduction of new technologies, new ways of achieving what we achieve in terms of surgical techniques, and of course, new knowledge accumulation, and every few years, changing guidelines. So these are some of the things that we have to work with and yet customize a treatment for a given patient. And these are some of the things that we, especially the longevity, patients' expectation about the quality of life, what they want to do in their life. And of course, professionally, not all of us are exactly what we call as balanced and of course informed. Patients' expectations, gender issues. This is the current expectation life at birth in India and other places. We are at, I believe we are at 72 years, and COVID actually reduced 2 years, but it's going to get back to that level, and then we'll probably achieve the target even before we reach 2050. So coming to the published data in the literature, some of it was shown by Dr. Sirao. In my mind, I'm sure you'll agree that all these parameters, all these variables need to be addressed if you have a complete paper. What's currently happening is that people are picking a new technology compared with an older type of operation, and then coming to a conclusion conveniently for their advantage, perhaps even supported by the industry. So we cannot, as responsible doctors who need to deliver the right care for our patients, we cannot fall into these traps. It's very important that we need to understand everything that is to be there, to be understood, and then give the right kind of treatment. And for instance, in partner 3, overall mortality, stroke rate, and readmissions were addressed. And based on that, they recommended that surgical aortic valve replacement is inferior to TAVR. So go ahead and put TAVR valves in every aortic stenosis, which is not the right way in my mind. And there are other things that also need to come. So all these things and the implications of these variables on the longevity and the quality of life of the patient matters. And only then that paper is complete and that we can follow the recommendations for that particular paper. I want to show that this is an STS database publication done in 21. We're also contributing to this STS database from the last 1 year, for the last 1 year, and we will have our own data analyzed and published. This is very extensive data, more than 1 lakh patients, 1,22,000 patients are included in this. I'm showing this to tell you what's the real life surgical aortic valve replacement outcomes, especially if it is done with minimally invasive aortic valve. If you look at the two second and third, the partial sternotomy and the right thoracotomy, anterior thoracotomy, these two are minimally invasive valve replacements. In the entire cohort, they're about 1/4 of the patients. And overall unadjusted operating mortality is 1.9%. If you take a low risk group alone, it's 1%. And yet, these are some of the variables I will actually have to allude to, but the partner 3 shows that surgical aortic valve replacement has 9.3% overall mortality and stroke rate. If you look at operation mortality or the partial sternotomy or right thoracotomy, it's 1%, okay? And undisputed, this is with a large cohort of patients. Same way with permanent stroke, 1%, 1.1. Prolonged ventilation, 1.1. New onset renal failure, less than 1.7%. And postoperative length of stay is less than 6 days is also very, very good. Transfusion, new onset atrial fibrillation, all of them are 1 or less than 1%. I just wondered why the partner group, the first author is a surgeon. Michael Mack is a very renowned cardiac surgeon from Baylor Group. Why they did not consider this as an important number to compare with, and why New England Journal decided to publish it is beyond me. So it's important to stop and think, Is this what's been presented in partner 3 is correct or not? So the minimally invasive aortic valve is associated with lower rates of blood transfusion, lower rate of atrial fibrillation, new onset atrial fibrillation. Post-operative pain, of course, is very low and shorter length of stay. We've done over 200 isolated aortic valves through minimally invasive surgery, both transaxillary and enterothoracotomy, less than 4 days. As Dr. Venkatesh said, it's important. ALOS is important for, I'm also an administrator, so I also get that number. So it's 4 days or less. Some people went home in 3 days. So these are the new ways of doing aortic valve replacement. And if TAVR need to be measured, that need to be measured against current advanced technique, then only it gets validated. So this is what bothers me. Is a physician. This is published in a British Cardiovascular Society published this paper. The man says, partner 3, the death knell for surgical aortic valve replacement. Is this a way a responsible physician should behave? And that's published in a society paper. This guy is supposed to be an Indian. I don't know where he is, but the point is that people get carried away without even understanding what they're trying to do. And these are some of the, which are already been alluded to. I don't want to spend a lot of time, but all of them shows, I mean, partner 1, I would say we should exclude it because it's very high risk and even not suitable for surgical patients. But we're not even talking about that. But we are definitely talking about partner 2 and partner 3. And I'm going to show notion trial also. This has already been, okay. Partner 2, Martin Leon published it and says that it is non-inferior. I want to highlight 2 points here. The trial has recruited patients who have STS score between 4 and 8. But in the reality, only 20% of the patients have beyond 4, STS score beyond 4. 80% are under 4, which is low risk, yet called as intermediate risk, and show that it is non-inferior, which is not a correct thing to do. You state upfront something and you do something completely different to achieve the goals of what you stated is not also correct. So the results of partner 2 trial raised concerns whether the findings of these randomized controlled trials reflect real world outcomes. It's been pointed out time and time again, but being ignored. And you keep wondering why. This is another point. So this is a partner 2 group published 5-year follow-up. It's a very busy slide. You can see a lot of paravalvular leaks and other things. And you look at this structural valve, death due to any cause and all those things. Again, it's very important. There is no mention of permanent pacemaker incidents. And it clearly says that 5 years, more patients in TAVR group than in surgical group had at least mild to moderate paravalvular leaks. Repeat hospitalization, which is again in partner 3, it says that repeat hospitalization is less in TAVR, but partner 2, repeat hospitalizations are more frequent with TAVR groups than surgical groups. Yet, in the conclusion, among patients with aortic stenosis who were in the intermediate risk group, no significant difference. How do we get to a point where you state something and then they infer something else? That's also another question. I mean, partner 3, I want to tell you, Dr. Zero has shown this study design. I don't know how many patients. These are 1,000 patients, 500 in TAVR and 500 in 1 to 2 patients less in surgical group. But how many patients they went through to recruit 1,000 patients is not given. So there are multiple centers. We don't know what kind of valves they use. They said they've recommended Edwards valve, which is pericardial valve, but we don't know which valve people used. Yet there is so many exclusion criteria. So without a number, a registry to say that so many people were screened for this study, and then 1,000 were picked up, which means that out of 20,000, you picked only 1,000 for your study. That means it's not a real life representation. If you only screened 2,000 and picked up 1,000, very close to real life. So without some sort of a perspective, it is very difficult to understand how many patients really end up needing TAVR in real world. We don't know because there's no registry, at least not published. And this is what I want to point out. I've already shown the operative mortality, the overall mortality, the stroke, everything is 111. I've showed you that a very large cohort of patients, yet we have this graph. And of course, and he says that I also want to point out on the other side, the positive, the TAVR is superior, almost 46% reduction in risk. And 2-year, 40%, 37% reduction in risk. Remember that these are semantics, these are play with words. Suddenly in valve thrombosis, which is leaflet thrombosis, which Dr. Procedural has pointed out, suddenly the words changed. Till now, there's a superiority. Now suddenly it says that 97% don't have thrombosis. Instead of saying 2.5% patients may have had thrombosis, they've changed it to 97% is positive. All these things in my mind are either prematurely or wrongly interpreted, or they selected a set of variables which suits them to get what they really want to present at the end. As scientists, as well as responsible people for treating our patients, it's important that we take cognizance of these things. This is another the same slide, but I want to show you in the first 30 days, nobody would want to walk 6-minute walk test. So you cannot compare surgical patients who had a sternotomy at 30 days with a TAVR patients who had a puncture in the femoral artery. So I don't, it's not a fair comparison at 30 days, but 1 year they're same. Class 1, class 2, class 3 symptoms are same. If you look at Kansas City quality score, again at 1 year it is same. There's no difference. And these are sternotomy patients. These are not minimally invasive patients. So conclusion of the partner 3, without mentioning paravalvular leaks, without mentioning complete heart blocks, procedural failures or exclusions, it is excellent for low risk. So again, is very generous in saying the limitations, but he also mentions about the problem of long-term structural valve deterioration. I hope I have 2 or 3 minutes more. I'm sorry, because it's an important, I believe, discussion. This is another paper which published by surgeons of Switzerland, Annals of Thoracic Surgery 2015, very long-term structural valve issues for surgical patients. Out of 383 patients, actual survival is 10 years, and with a structural valve preserved at 72% at 10 years, 46.2% at 20 years. And mortality for reoperation is 2.3%. There's an importance for this. If you have a structural valve deterioration and you need a replacement, second time mortality is 2.3%. But you know, if I have to explant a TAVR valve, which is happening now, is anywhere between reported published papers, 11 to 17% of mortality, surgical mortality of explanting TAVR valves, because they're all incorporated into the important structures of the heart, outflow tract of the left ventricle. So And then again, multiple papers showing the surgical valves, excellent long-term non-structural valve deterioration, 85% in some of the publications. Yet, Notion trial found at 6 years, 24% of the surgical valves there is a structural valve deterioration. This must be some kind of miracle. Why surgical valves are deteriorating in 6 years, a quarter of them, where TAVR valves are only 4% structural valve deterioration. Don't you think something is amiss here? Whether they used porcine valves instead of pericardial valves, we don't know. So I'm trying to highlight the for want of a better word, and it's a strong word, manipulation of data, misinterpretation of the statistics, because you're already fixed your endpoints and you want to fix these things, so you come up with a recommendation. So these are the structured valve deterioration statistics of UK, France, and yet Notion trial has a different way of presenting them. Anyway, I'll probably, it's too much here. In this meta-analysis of 11 systematic reviews highlights the inconsistencies about reporting and presentation of data, most notably limited clarity on effects of risk bias on trials is very, very important. I'll show you this. This is one of the patients sent to me by a colleague who had a TAVR and left-handed descending artery stenting, proximal left-handed descending artery stenting, presented now with angina, has very tight ostial circumflex and OM1 osteoproximal lesion. What do we do for that? In spite of all this data and published works, the 2020 ACCHA guidelines did not put TAVR as class 1 indication. It is still, if it is below 65 years and they can have mechanical valve is the first option. Then second option is between 65 and 80, SAVR is the first option, unless patient insists. Then comes beyond 80. You can start talking about both surgical and TAVR valves based on the risk stratification according to STS database. I want to tell you STS database, STS risk score and Euro 2 risk score, both over predict the risks. We've done this in our hospital with our own personal experience. Both scores currently over predicts the risk, which means what you call as intermediate and high risk according to STS score is not really intermediate score. It could be even lower risk groups. It's also evolving science. In spite of that, there is the algorithm, and this is another important paper, STS and ACC registry. Both of them, in spite of all the data presentation, finally came up with the same recommendations: mechanical valves, tissue valves, surgical tissue valves, and then TAVR. So in summary, a lot of things that these are published data. I have also mentioned the references next to it. I'll just read them out and then close it. Greater than moderate paravalvulitis and permanent pacemaker implantations or conduction abnormalities was higher among TAVR group. After 5 years, 1/3 of the TAVR patients had at least mild paravalvular leaks compared to 6% of SAVR group. Within 2 years, cerebrovascular events, mostly ischemic strokes, occurs 5% of the patients in TAVR group. Durability is a question still. There's a substantial number of low-risk TAVR patients, 15%. Future coronary reinterventions, valve-in-valve operations are almost impossible and extremely challenging. These operations are challenging because of the hardware that is in our way to perform a safer operation. Operative mortality for surgical explantation of TAVR, as I mentioned already, is 11%, and in some papers it's 17%. So I'll leave that with you with this thought. Selection of procedure or valve. Important is aspiration of the patient and their life expectancy, socioeconomic conditions. I did not even touch the cost. So I thank you for the opportunity.
Thank you, Dr. Gopisan. I'll request Dr. C.V. Rao to come up and answer some queries he has raised. So it's what? So it's what natural Dr. Gopijan, as the lead surgeon, has to talk what he has spoken. But he also agrees that basically it's a work in progress. We have not heard a final say. It's a unfair comparison between SAVR and TAVR. TAVR is just about a less than decade phenomenon. And then SAVR is already 40, 50 years of experience. So we can't really be sure about, what is happening. But there are two things which I wanted to show for your clarity. I'm going to give you the final word, which is published in Annals of Thoracic Surgery. Given the variability in structural heart training, this is the words from surgeons. Given the variability in structural heart training, we urgently recommend the establishment of a standardized curriculum and pathways for surgical trainees to gain proficiency in transcatheter technologies. So I think that answers all the questions. And the very fact that surgeons are talking about minimally invasive surgeries, they're also agreeing that the treatments have to become less invasive. So full thoracotomy or partial thoracotomy, essentially you're also coming on to the philosophy that it has to be less invasive, less traumatic. So we score over at the end of the day. Thank you. Thank you, Dr. Gopisan and Dr. C.V. Rao. Definitely, this is a new kid we compare to Dr. Gopisan. I think this TAVI is just 1 decade old. I think surgery has got a lot of experience in this field. So obviously it's evolving, I should say. All of us are convinced that a high risk patient, definitely TAVI has got a definite role. There's a moderate and low risk yet to be vetted, because we don't have a long-term data on low risk. But we have convinced, all of us have convinced that the high risk situation, I think TAVI is definitely helping us in the clinical situation. And I request Dr. Gopisan, what will be your approach in your hospital, being an administrator, being a very high profile surgeon in a hospital where patient coming with a moderate to high risk patient, I mean low to moderate risk patient. What will be your approach? Will you lead to cardiologists or need to have a heart team discussion before taking up these cases in clinical practice?
We always debate on this. Yeah. We work closely, both of us, my cardiology team and ourselves, and even for coronaries or stenotic patients, we offer both. Where it is appropriate, we offer. Because we are offering minimally invasive surgery quite frequently, a lot of people choose that rather than. I'm not refuting the fact the TAVR is here to stay. It is there. There's no things about it. It has a role to play. What's being promoted, the way it is being promoted, is not correct without data backing up the promotion. The last slide C.V. Rao showed, Michael Mack is also part of that. So I don't know if it's wrong.
Any question from the audience?
Sir, one last question, sir.
Thank you very much. If there is no other questions,
Sir, I have one last question. Sir, Gopijan, sir, actually the patient process mismatch in small and patients, we are getting a very significant gradient sometimes. Even immediately post-operative gradient 40 to 50 mm gradient. Even some patients, they get SAVR patients, the aortic wall, tissue wall is getting degenerated within 6 to 7 years. These are few practical problems actually. I don't know your opinion.
One is we have to say that before, based on the body surface area, minimum is 19, and based on the surface area, you can increase it to 21 by enlarging the root, which we really do even through minimum dose. Enlargement is not a big deal. Second is it's important to understand whether the tissue pericardial valves or porcine valves. Pericardial valves wrap design versus inside mount design now has a difference of longitude. So it's important they're using tissue valves which try also matters. The big valve is in the porcine valve. Different as a pericardial valve, but it's a wrap design again. And if you don't use the right kind of care, you can bend those titanium frame that will cause paravalvulitis. Abrasion of the leaf causes recalcification. That's why I'm using only Edwards right now. Edwards valve. Edwards gives a larger.
As we are running out of time, can I move on to the next session? Okay. Going on to the next session.
Thank you, Chairpersons. Next is the presidential oration. Dr. Sharma will be speaking on the intervention of acute ischemic stroke, cardiologist perspective. I request Dr. Chandrasekhar Garu to honor the gold medal. Now Sharma starts his oration. Good afternoon, and interventions in acute ischemic stroke. What's the role of the cardiologist? Now, as interventional cardiologists, we have vast experience in coronary interventions, peripheral interventions, and venous, and so on. And most of you must be very familiar, and you must be doing a good work in carotid stenting also with ease, with good numbers. But when it comes to interventions in acute ischemic stroke, probably one should have a good understanding of the anatomy of the cerebral circulation and the hemodynamics of it, which are slightly different from cardiac interventions. And of course, a specialized hardware.
Now, we know stroke is #1 cause of disability worldwide. And in 1970s, probably some of you are there with us, those days when a person comes with stroke, then we used to do an LP. And if it is hemorrhagic, then we used to brand it as hemorrhagic stroke. And if it is clear fluid, then we used to say ischemic stroke and give only Lomodex. Not even aspirin was available or recommended for strokes in those days. So practically no treatment used to be offered to the patient in those days with stroke, and this used to be the consequence of it. You know, this classical hemiplegic rate. And thanks to the advances in the management of stroke, this scenario is a rarity now. Unlike myocardial infarction, we know stroke really takes away the pride of the person. You have to imagine somebody gets heart attack, still he leads almost a normal life externally. But somebody gets a stroke with the gaits like that, or sometimes bedridden states, it really takes away the pride of the person. It makes him depressed. Not only the patient, but a long-standing burden to the society and also to the family. We see a lot of families, a bedridden stroke patient, you know, probably most of these family members also become sick because they have to do so much of service. Patient. Now, this, of course, everybody knows, be fast is the slogan. So this is for early recognition of the stroke. This is given even for laymen. They should be able to understand the early signs of stroke and get him to the hospital because time is brain. The reason is in stroke, roughly 2 million neurons die every minute. You have to see the magnitude. And the goal is to restore the tissue perfusion as early as possible so that you can salvage a large number of neurons. Most important thing in the management of stroke is to determine at the earliest if the patient is a candidate for thrombolytic therapy and or endovascular therapy. You can give thrombolytic therapy, still take him for mechanical thrombectomy also, provided he fits into the recommendations. We all know that intravenous thrombolytic therapy has become a gold standard if the person comes in less than 4.5 hours. This is a gold standard, no debate about it. But the only problem is, of all the stroke patients, only 3% of the stroke patients are eligible for intravenous thrombolytic therapy, even with a lot of awareness about the stroke. So because it's a negative symptom. If it is a myocardial infarction, he gets up from the sleep and he gets pain, he runs to the hospital. But if he gets a weakness in the upper limb or lower limb as a negative symptom, he won't pay much attention. Always they think that we can see tomorrow. So that's how the time is lost. Only 3% of the strokes, they are eligible for thrombolytic therapy. And also intravenous thrombolytic therapy is not very effective for large vessel occlusions. We say large vessel if it is basilar or vertebral or middle cerebral artery or internal carotid, not the lacunar strokes. But so this is not effective for large vessel occlusions. Now, if you see the recanalization rates of intravenous thrombolytic therapy, only 1/3 hardly get recanalized. But if you see interventions, there's 100% recanalization rates, provided you use the correct software and expertise. So this is a journey in the interventions in the cerebral strokes, starting with 1999, the PROACT study, which showed intra-arterial thrombolysis, to the present generation stent retrievers and penumbra system. Now, ideally, a stroke patient, like in coronary care units, he should be treated in stroke care units, where it comprises a stroke neurologist. In neurologists also, there are stroke specialists because they work more with the stroke patients. They understand the disease better. So ideally, a stroke specialist should be there and interventionist should be there, and the rest of the paraphernalia like stroke expert nurses and physiotherapists and so on. This is our stroke team. And what are the intervention strategies which are available? One is clot lysis, we know, and there is clot retrievers with Mercy, penumbra, and stent retrievers. And of course, as in coronaries, we do stenting or angioplasties. Now, who are the people who can perform this? As on today, a person, a cardiologist, of course, is well versed with the interventional techniques, is eligible to do interventions in strokes, and interventional neurologists and interventional radiologists. But let me tell you, I think who else can be a better person to tackle these interventions, be it in coronaries or cerebrals? I think cardiologists will have a better, techniques and skills to perform these procedures. So that's the reason why I present this topic, because some of you cardiologists, stroke is such a common disease that if you get some good hardware and some expertise, probably we'll be able to save this devastating disease. It is not life or death. It is the depressing disease. This person is bedridden for years together. You have to imagine. That is worse than a myocardial infarction, cardiogenic shock. Now, unlike stroke interventions in like acute myocardial infarction, ischemic stroke interventions, one should remember that it has a unique set of complications which we don't see in coronary interventions. That is hemorrhages, or massive cerebral edemas, and hyperperfusion. This is because of disruption of the blood-brain barrier. So any of these complications can lead to a catastrophic consequences. Here I would like to say one thing. In acute myocardial infarction, if you get a TAVI gate free flow and a good cosmetic result, usually the prognosis is good. But in acute ischemic strokes, it's not like that always. We have seen, we want our fingers. You get a very good flow, very good result. The vessel looks normal, but the patient is sinking, so it is not equal. That's what I always say, myocardial infarction and stroke, both are not same, as somebody says. They're not just the same. There's a lot of difference. That's the reason why you require a team there. Now, it's because the selection of the case. Here also is the difference. If you see a myocardial infarction, hardly any contraindication, unless there's a myocardial rupture or VSDs, every patient of acute MI is more or less eligible for primary PTC. Whereas in stroke, it is not like that. Every stroke, though he comes within the window period, it's not that he is eligible. So there is the role of a neurologist. Which patient we have to lay our hands, which patient, to what level, what modality we have to attempt. That's the purview of a neurologist. A good neurologist should be able to even prognosticate which patient is going to get up and walk. Now, this is one thing. Mind you, this is after intervention. Such a ghastly sign, if you see this, because you're making the patient worse than what he is. The other complication, as I said, you have a successful recanalization, but you can produce severe cerebral edema. And mind you, we know that the name I forgot, because the brain is in a cage. So if one side there is cerebral edema, it compresses the normal brain also. So the total brain is gone. So there is absolutely no chance for the patient to survive if you really miscalculate the decision. Now, we require some specialized hardwares for neurointerventions like DSAs and roadmaps. And most important thing is soft guide sheets are required. In coronaries, what we have is a firm guides, which require sturdy ones which stand in the ostium. But when you go into the cerebral circulation, it's very tortuous vessels. So our routine guide catheters will not go there and they may cause some dissections. So you require very soft guides, but yet they should be trackable. That's the reason why actually one of the major problems, for brain strokes here is the cost. Prohibitively expensive, those hardwares are. I'll come to that later. Now, this is NOI catheter. I suppose most of you are familiar with this catheter. The tip is very soft. So this can be used. Unfortunately, 8 French doesn't come in there. All that we could get a 6 French. I tried, but 8 French is not available. Fubuki catheter, sheath. And this is very important, Neuron Max sheath. The sheath is so soft that you can go to the terminal part of the internal carotid artery. The reason why we require this type of things is we have to have a good support to pass on your subsequent catheters, otherwise they bump back because of the tortuosity. Now, we require a specialized neurocath lab to decrease the complication rate. Routine cath labs also we can do, but if you have a dedicated neurocath labs, then to a great extent we can reduce the complications. which have a large detector so that you can minimize the dye, have a roadmap, 3D pictures and 3D angios and dynacity, all these things, they will reduce the complications. Now, this is the panel which it comes with neurocath labs with the 3D imaging simultaneously. So with one injection, we will be able to know where is the location and extent and length and everything will be able to calculate so that our job becomes easy without doing multiple injections. This is a DSA roadmap. You know, you can see that you have a map over it and your guide wires and guide sheets, you'll be able to pass it. So that, you know, all these things, you are minimizing the dye, you know, which has a strong bearing on the complications. I don't want to go into the anatomical details. This is one thing when you perform neurointerventions, you occasionally face this problem. There is a bovine arch. It is like you see the horns of the bull. It creates difficulty in cannulating, especially the left common carotid. Now, some of the important considerations, the anatomical considerations are cerebral vessels have no external elastic lamina and a thin medial layer. This is very important because in coronaries, we take appropriate size of the balloon to the vessel diameter and then you dilate to high pressures. In cerebral circulation, always, if at all you have to use balloons, you have to use lesser size diameter balloon and don't go beyond 2 to 4 atmospheres because they can cause perforation, dissection or rupture. And absolutely no concept of high pressure dilatation in cerebral circulation, unlike in coronaries, which by default you have to do in every case. We have to minimize the dye by diluting the contrast, use DSA and roadmap liberally. And most important thing, especially the beginners, if they want to do, always do a, aortic arch injection so that you can see the ostia of the vessels, neck vessels, so that you don't perforate or, it cause dissection or embolization. And you always take a long runs because this is important because to see the collaterals and also, to assess the tissue perfusion. These things will have a bearing on the outcome. So, but there's no good, tissue perfusion, then the results are not going to be good. And also, if you take long runs, rarely you'll be able to see collaterals at the end phase. If person is having good collaterals, we have to be less aggressive. I mean, don't be very aggressive because God forbid something you do is dead. Collaterals at least are making him to survive or something like that. If there is no absolute collaterals, then those are the patients, maybe you have to be more aggressive because you don't lose much. Now, these are the criteria that when you want to do any thrombectomy or mechanical interventions in the brain, it should be a large vessel stroke. You don't do for lacunar infarcts, small vessels, you don't do it. And infarct should be less than 1/3. That's what I'm saying, the selection of the case. Patient comes and half of the cerebral hemisphere is gone, but there's internal carotid artery occlusion or MCA occlusion by your MRA. It doesn't mean that you go and do something about it. So if the infarct has to be less than 1/3 and there should not be any hemorrhage, even small hemorrhage. That's why when you take up the patient for interventions, plain CT is enough. You may not require, very detailed imageology for it. CT just to rule out, hemorrhage, and even however small it is, CT will be able to pick it up. The second one is the earliest signs of infarct, probably for an inexperienced person, they miss. But a good person who has got an exposure to a good number of neuro cases like neurologists, they will be able to make out the subtle signs of infarction. Sometimes the CT may look normal, but carefully look at it, the infarct is already formed. So those are the patients. I don't think you have to lay your hands on that. And of course, patient should be within the window period. Generally for mechanical thrombectomy, the window period they say is 6 hours, but it can be extended up to even 24 hours if you have advanced imaging. Like there are certain things called diffusion perfusion mismatch. I'll come to that later. Now, like TIMI grade flows, we have TC grade flows. That is the same. 0 is no flow and 3 is a good flow. Now, routes are commonly, we can choose either radial or femoral. Radial is now catching up. I'm not much experienced in radial route for cerebral interventions. But thanks to that angio seal devices and all, because I have to put 8 French shields, put an angio seal, that's it. I mean, at least vascular complications are not there. Now, local previously we used to give intravenous thrombolysis like NINS trial, which has been from 1995, but then evolved into intra-arterial thrombolysis. So you can give a lesser amount of thrombolytic agent. Recommended dose is around 20 milligrams of RTP or tenacteplase, which is around 0.2 milligrams per kg body weight. The results are much better than intravenous thrombolysis because higher concentration of the agent there and higher recanalization rates, which have been documented. But mind you, with intra-arterial thrombolysis also, the maximum is around 50 to 70%. Now, this is, I'll show some cases where it is done intra-arterial thrombolysis. This is a 58-year-old male. Window period came at 5.5 hours, something like that. So he's ineligible for intravenous thrombolysis. Came with dense hemiplegia on the left side. And you can see MC on the right side, which is 100% activated. Now, after intra-arterial thrombolysis with the microcatheter there is a good flow. And this patient has recovered in 6 weeks, reasonably well. Was not complete recovery, but he was able to do his own daily work. Now, by convention, anterior circulation is carotid system and posterior circulation is vertebrobasilar system. So this is a previous one is an anterior circulation stroke. This is a posterior circulation stroke. He's a young person actually, 35-year-old, hypertensive smoker. He came with the complete basilar occlusion. 2 vertebrals go join and form the basilar, and the basilar is completely knocked off. There is no flow on the distal basilar. He was unconscious. He was frothing. I distinctly remember this patient. We lost hopes on that. He came very late actually, but still we thought we don't lose anything anyway because he's going to be, he's going to lose his life. So we went ahead. And we did intra-arterial thrombolysis for him in basilar artery, which showed 100% recanalization and dramatic recovery. This person has recovered completely within 2 weeks. Yeah. So some of the cases are very rewarding, but mind you, it's not that what we see always is colorful. We faced a lot of problems also. Slowly we have evolved which patient we have to do. That's the reason I'm saying selection of the case is important because we'll be tempting to attempt those cases. Suppose you see, you do MRI and MR angio you do on the emergency, you see MCA completely occluded. So you think you want to go and open it up. But then there are a lot of other parameters which you have to consider before going to this. So selection is very, very important. Now, some of the cases present as stuttering strokes. You must have seen some patients. Patient gets hemiplegia in front of your eyes, and after some time, it becomes normal. Repeated episodes like that. This probably should make us suspect that there is an underlying critical lesion and small clot getting formed on it, produces hemiplegia, that spontaneously is lysed and then it becomes better. So always there is an underlying critical lesion if this scenario you face it. So he was an 80-year-old male. He came with the same presentation. Right in the hospital, he was recovering and is again becoming hemiplegic. So when we did an angio, that showed a very critical lesion in the supracranial ICA. So you can see the lesion, very, very tight lesion, guidewire across. Then that time it is suitable for coronary stent, 4 into 18 millimeters balloon mounted stent, and complete recanalization. And this person lived from 80 years to 90 years, and then at 90 years he died of myocardial infarction. But he didn't have any trouble. He was not bedridden. He was leading a normal life for 10 years. Now, the similar case of stuttering stroke, which occurred at the origin of the internal carotid, you can see very tight internal carotid stenosis, the thrombus sitting there. So what is happening is there's a tight stenosis, a small thrombus, circulation is knocked off, is becoming hemiplegic, and the story is repeating. Then this is after balloon dilatation. This is a self-expand. Previous one is a balloon mounted stent. I was trying to show an example of self-expanding stent. And after this, as I told you, there is a residual lesion there. There are 2 points. One is residual lesion and external carotid is knocked off. Nothing will happen. Even if the external carotid is totally knocked off, nothing happens. Even if bilateral external carotid is knocked off, nothing will happen except jam mastication, you get some pain. Otherwise, external carotid, don't chase and try to open it up. You have to leave it. External carotid, even if it is knocked off, nothing will happen. Now, there is a residual stenosis here. That's what I was trying to make. Now, we can't be heroic and going and putting a balloon there and opening it up like in coronaries, because post-stent, if you do dilate, especially in the acute situation in carotids, it is catastrophic. So what is the brain requires? It requires minimal flow actually, unlike myocardium, because when you do exercise, it requires more supply. And brain is, it requires very little bit of supply. Even if you produce trickle of flow to the damaging brain, that will prevent a massive hemiplegia. Yeah, this is a case, an interesting case. Yeah, he's a 60-year-old male. He came with the left upper limb pain, very interesting case, and recurrent episodes of posterior circulation TAE. He was having dysarthria and vertigo, recurrent episodes. He was treated by ENT specialists and all those people. Then we did angio. Then, of course, carotid Doppler showed complete knockoff of the subclavian and all. So angio showed a rudimentary right vertebra on the other side, and this side subclavian is gone. So is the vertebra. So we attempted PTC to the femoral route, but it looked like CTO, it didn't go. So brain puncture to the radial we went. Retrograde, and we've opened up this. The reason why is those days I was using 8-French guide catheters to pass bulky stents. So femoral, I have to make an access to femoral. Then self-expanding stent. At that time, I didn't have the peripheral stent in the shelf, so I put a valve stent for it. So there's a good flow in the subclavian, but if you see, there is a vertebral osteal tight lesion, which was fixed up again in the coronary stent. And after that, he never had any symptoms. So this was an example of recurrent post-basilar circulation PAs. Would have left him like this, maybe would have landed up in a basilar stroke. Now, what are the modalities for the mechanical thrombectomy? We'll come with some illustration. This is a Mercy device. It's a coiled wire which enters. This is a middle cerebral artery. There's a clot there. The Mercy device has gone there and then pulled into the catheter. Looks very attractive, very rosy, but it did not translate into clinical improvements in the trials. So this was abandoned. Now, what are the latest things which are available? Penumbra system. This is what we regularly use now. This is nothing but a clot extraction. You take the catheter to the middle cerebral artery till the end, wherever is the clot, then aspirate. The aspiration system is like any other aspiration system, but here the key is the catheter. I'll show you the subsequent pictures. The catheter has to traverse through all the curvatures of the internal carotid artery, go to the middle cerebral artery. So this is the importance in penumbra system. Yeah, so you require catheters which are very soft, then they should be trackable and maintaining the lumen, because when you're going through that and manipulation, if it kinks, then you don't get the aspiration. So that's why these catheters are actually, they say, handmade and very expensive. Each catheter is 1.5 lakhs. And you may have to use 3 or 4 catheters in a given patient. That is the main drawback and crux for these things, modalities of treatment we want to use routinely for all stroke patients. Now this is the catheter, you can see it, how it can just coil and go. This is what I was pointing out. The internal carotid artery is the frame of internal carotid artery. You can see the tortuosities before it gets bifurcated. I'll show this picture. Yeah, this is how it goes. What you call siphon of the internal carotid artery. The last one, especially the S-shaped bend. Sometimes it's so, we struggle so much to negotiate this. Whatever, maybe 1 or 2% of the cases we had to leave it because we are not able to track it. But thanks to this new hardware, some of the penumbra catheters, A68 and 4 max and 3 max, they go like, they slip into all those curvatures. Now, after these catheters available, probably all these cases were able to be successful and go through those bends and curves. Now, the principle here is why it is expensive is each catheter is 1.5 lakhs and the other catheters are around 70,000 or something. It's a telescopic method which you have to use. If you see the blue one, that is Neuron Max sheath. And from there, we put a 5 French catheter, A68. And from there, you go with a 3 max. So catheter in catheter, and finally you reach the level. That's the whole assembly is, that's why it's expensive because each catheter is expensive. So to go into that, isolated single catheter will not go there because it doesn't have a backup. Now, this is the patient where we did a penumbra system, 50-year-old dense right hemiplegia. Window period is 5 hours. You can see a tight lesion there. We pass a wire over that, the catheter will go. Yeah, this is a good recanalization. But if you see, there is an underlying residual stenosis. We don't want to change this because all that in an acute situation we require is, to give some blood flow to the brain. And once the patient recovers, we can assess subsequently how much is the restenosis. If it's an recurrence of symptoms, then we can fix that up. In acute situation, to stent the middle cerebral artery is definitely a risky proposition. Now, this is an interesting case. Internal carotid artery is 100% occluded with a trickle of flow. With penumbra aspiration, we could get a very good flow. But if you see, there looks that dye is getting extravasated. So we were really worried whether this patient has bled. That is why I'm saying this neurocath labs will, where there's an inbuilt CT there. So you can immediately do a CT and see hemorrhage is there or not. Because in cath lab, with injections, we won't be able to, like all of we won't be able to make out there's a hemorrhage, unless there's a lot of gush which is going out of it. Otherwise, hemorrhages cannot be made out on routine cath labs. You require a CT. Previously, we used to shift the patient to the CT scan room, and then, whereas these cath labs have inbuilt CTs are available. Of course, it's a crude CT. It's not a very fine CT there, but definitely we'll be able to make out whether there's a hemorrhage or not. That makes a lot of our job becomes easier and we'll be more confident. Now, this is a patient where there's a left MCA 100% occlusion. With this penumbra system, it was completely opened up. That's why if you select the case and if you apply this, correct technology, the results are good. The another advancement is the solitaire stent. Solitaire stent is nothing but a stent retriever. It engulfs the clot and pulls the clot back into the catheter. This is animation. The guide wire is, this is middle cerebral artery clot and a microcatheter. Through the microcatheter, this is the solitaire self-expanding stent, which engulfs the clot and then get back into the system. And the whole assembly, the catheter with the clot and the solitaire stent has to be pulled out. This is an illustration of a basilar stroke. These are very resistant strokes actually. Not all the time that we are going to be successful. This patient is a 100% basilar artery occlusion. Now, after the solitaire stent with the stent retrievers, there's a good recanalization and a good recovery of the patient because the patient has come well within the window period. Sometimes you may have to combine the modalities like stent, you have to deploy the stent and also aspiration. So this patient has got, if you see internal carotid artery, there's a fresh clot, probably underlying lesion. And from there, the clot has migrated to the middle cerebral artery. So it has lesion at the internal carotid, which is thrombotic, and probably artery to artery embolization with the middle cerebral artery occlusion. Now we did a limited dilatation of the internal carotid. And then with the catheter, penumbra catheter, here actually I captured the picture. You can see the catheter tip in the middle cell. I zoomed it. You can see the catheter here on the right side, on the left side. There's a catheter, that bore is there, and we start aspirating it. And there's a good recanalization of the middle cerebral artery. We came down and fixed up this internal carotid stent. Yeah, these are the clots which are being pulled out with penumbra adult system. Now, there are some more advancements have come that this time doesn't permit, so I just leave it there. Now, we know endovascular therapy with stent retrievers like solitary stents or penumbra system or any mechanical thrombectomy has become a gold standard therapy if the person comes within the window period now. This is a class 1 indication now. Now, this is our published data on various multimodality treatments in strokes. And World Stroke Organization Award of Excellence was given to us for last 2021. Thank you. Now, the key to good outcomes in stroke, myocardial infarction is pretty simple. Simple means at least you need a technical skill. Here, definitely you need a lot of thinking, not by one, but a team. Now, apart from interventional skills, the selection of the case is what I've been repeatedly saying, because I got some phone calls from my colleagues that they have done and the patient did not recover. The reason is it's a selection of the case, for which if you do 10 or 15 cases, anybody will be able to reach there and pull out the clots. But you really have to know which patient you have to pull out those clots, because sometimes if you recanalize a brain which is already infarcted, that is catastrophic. Now, successful recanalization could be there, but I told you as catastrophic this is one slide which I want to focus. What is called diffusion perfusion mismatch. If you see, diffusion is nothing but an area which is necrosed. The first frame. The second frame is perfusion. Perfusion is how much is the area which is getting less perfusion. Now, if you see a mismatch is there, these are the ideal candidates to go for interventional therapy. That's why the so-called digital window period is no more actually accurate. See, some of the patients can come at 24 hours also, but there's a good diffusion perfusion mismatch. They are still salvageable. The reason why we have to be aggressive in, again, I want to emphasize is that sometimes it's completely, you can make the person normal, or at least he'll be able to do his own work. Otherwise, I don't know, you must have experienced in some families where one patient is there bedridden, they're gone, lifelong, with aspirations, bed sores. Life is a hell for them. They can't leave him. They can't get him to the hospital. Miserable. We have some couple of patients like that. We also couldn't do anything because they're all burnt out cases. So that's the reason why if you act very early, at least some of the patients, we'll be able to salvage. So it's always, it's a team approach that not only our skill, when we go and do that, somebody has to guide us which patient, because in course of time, we may acquire the same experience which patient we can lay our hands and all, but it's better that a teamwork of neurologists, cardiologists, and a good radiologist can make a lot of difference. Stroke management cannot be simple like one cardiologist goes and does angioplasties. It's not that simple. Thank you very much.
Thank you, sir. Being a presidential oration, there won't be any questions here. So we directly go to the peripheral intervention session. Dr. Karthik, Dr. Pere Chaudhary and Dr. Vijay Lakshmi is requested to chair this session, and Venkatachalam sir is here, and Dr. Purnanand is requested to moderate this session. So we have 4 cases, 4 topics to be discussed today. Over to the chairpersons and the moderators.
So good evening, all. It's been a long day. I think we are running short of time as well, and we are almost gone through half of peripheral interventions by our president. It's been something out of the box that you see every time that he presents. It looks like a walkthrough, but it is pretty tough. So we'll start our peripheral interventions with me. I have Pere Chaudhary Garu, and I request Dr. Vijay Lakshmi Garu and our moderator, Dr. Venkatachalam Garu, and Purnanand Garu also, if he's around, to be up, please. So we will start our session. We will have live in the box by Dr. Srimanarayan Garu. He's been an outstanding person who does his interventions in Andhra Hospital, who has been doing a lot of structurals as well. And let's see what kind of EVAR that he is going to present. He had a couple of EVARs in his place.
Yeah, thank you.
And he is from Guntur Medical College. He is a classmate of our APMC chairman, Samsava Reddy Garu as well.
Yeah,
So
you.
coming back to Guntur.
Yeah. Today I'm going to present you about piping box as endovascular IoT repair. This endovascular IoT repair technology is continue to evolve, especially for the past couple of years. All over the world, the cases are increasing. They are alternative to the endovascular surgical repair, and sometimes even hybrid procedures. For the treatment of the thoracic aorta as well as abdominal aorta, they are found to be very useful. So this is my first case. 42-year-old male. He is hypertensive since 6 years. He had acute onset chest pain, and that is a history of angina, and the troponin was positive, and the ECG showed ST elevations. He was diagnosed with CAD, acute anterior MI, and ejection fraction 45%. He was thrombolyzed. He underwent coronary angiogram. This is the coronary angiogram. It showed proximal RCA, there was a plaque, and even distal RCA, there was a plaque. And if you see the proximal LAD and the arterial LMC, there is critical narrowing. Diagonal is diffusely diseased, and proximal RCA is ectatic, and even arterial LMC was ectatic. And, he was advised CABG, and he was admitted in cardiothoracic unit for the. Then he continued to have chest pain. Then, further evaluation, he was found to have massive depth proliferation. Then he was re-evaluated whether something is coexistent along with his coronary artery disease. Again, we brought him to the 2-day room, and here you can see RWM in the LAD Italy with mild pericardial effusion along with the massive effusion. And this is the suppression view. We can clearly see the dissection flap extending from the left subclavian artery. Even the epigastric view, you can see there is a flap in the descending thoracic aorta. So, any patient with acute onset chest pain, it is very important not to overlook the diagnosis. IoT dissection is sometimes we can miss unless we have very strong suspicion. At the juncture, I will ask our moderator Karthik how to approach this case.
So here you have a dissection and a very critical disease. I think it should be a heart team approach that you call up your surgeon and see what he wants to do. I think you have an ECMO with you. I think you can support your heart and as well as you can do your lung procedure of building up your aorta and as well.
Yeah, but basically aortic dissection, you have to confirm the diagnosis by either CT scan or MRI or transesophageal echocardiography. And medical management of the aortic dissection is very, very important, especially to control the heart rate and blood pressure, because you have to reduce the aortic shear wall stress. You have to reduce our dP by dt to prevent the propagation of the aortic dissection, and you have to assess the various organs whether there is any significant malperfusion, either elevated left, elevated renal perfusion. And as Karthi already discussed, it is like a team approach. You have to involve intervention radiologist, anesthesia, critical care specialist, and as well as your cardiothoracic vascular surgeon. Here we have done all this, and this patient definitely has a complicated aortic dissection. That means he has a significant rupture with the hemorrhagic pleural effusion. And what are the other indications for surgery in type B aortic dissection are? One is refractory hypertension, that is requiring more than 3 drugs, and uncontrollable pain. And next thing is impending rupture that we already discussed. These are the 3 indications for the intervention in type B dissection. Here, almost 30, only type B dissection, only 70% of the patients require only 30% are complicated. These patients only require aortic intervention. These are the very high risk conditions. Any patient with aortic dissection, you have to rule out Marfan syndrome and connective tissue diseases, as well as respiratory conditions like euphragmocytoma, cocaine abuse, weightlifting, or any other valve removal, trauma. Sometimes you have to take proper history. Any disintegration injury can predispose them to aortic dissection. Here, vasculitis, especially this patient looks like inflammatory vasculitis, and he had involvement of coronaries as well as proximal aorta is diseased. And once you suspect the aortic dissection, and you have to confirm the dissection by CT scan, CT angiography. Especially the advantage of CT angiography is this is totally non-invasive. But the problem with CT angio is we have to do contrast, and it cannot assess aortic incompetence as visualize coronary dissection. And unless you specifically ask for CT coronary angiogram, and these are the various findings on CT angiogram. And compared with the MRI is time consuming and but less nephrotoxic. The patient cooperation is very important for the MRI. This is the CT angiogram of our patient. Here you can see the top image. You can see the descending aorta. There is a dissection, and as well as left pleural effusion and collapsed lung we can see. And there are several important issues. After confirming the dissection, we have to see the entry point as well as exit point of the tip. And what is the SAVR diameter at the origin of the entry point? Whether is it involving subclavian artery or it is away from the subclavian artery? What are the vessels which are arising from the true lumen? What are the vessels which are arising from the thrombus? Whether your vertebral artery is dominant or vertebral artery is not dominant. All these things we have to answer. Dissection with internal iliac or renal artery, everything, all this abdominal aortic branches, everything should be evaluated. And here, the next moment, we have to see whether we can reduce the intraspinal pressure. You have to put, before giving heparin, you have to give an epidural catheter to reduce the CSF pressure. That will prevent the neurological complications like post-operative paraparesis, especially if you are putting a very long stent. And this is again PSA, which showed over here. This patient had a dominant right vertebral. So we need to we can sacrifice the subclavian artery, and this was the transesophageal echocardiography. And here most important step is cannulating the true lumen, because the true lumen is wider at the subclavian artery and it is very narrow in the pulmonary artery, iliac artery. So always you have to cross from the right subclavian into the true lumen, and you have to snare it through the right femoral artery. That is very, very important. And if you stent the false lumen, that is the end of the story. And patient may die collapse on the table. Here we have to do transesophageal chromatography. These are the very clinical points to identify true lumen versus false lumen. Here we can see the catheter, the wire in the true lumen. And almost false lumen is entirely thrombosed. And that is the shape of the true lumen as well as the shape of the false lumen. And after that, this is the angiogram. You can see the false lumen as well as true lumen. Almost true lumen is compressed, and there is a guide wire in the right supply vein artery. And even if you see the abdominal angiogram, you can see all the branches. And here we have put life tech endovascular 34 into 200 mm length stent, graft stent, and across the left supply vein artery, because it is like right vertebral artery is dominant, so we are able to sacrifice the left supply vein artery. Here the proximal fixation is very important, because at least we need to have 50 millimeters of fixation zone. And one more important thing, you need to study all the anatomical features of the graft, what we are using, the endo process, especially where are the you can see 3 markers proximally on the graft. Proximal to the 3 markers, there is an uncovered portion of the stent. Even your uncovered portion of the stent, it can come across the left common carotid. Only covered portion starts from the left supply vein artery. And even though temporary pacemaker is not required, but preferable to have, because sometimes even while you deploying the stent, even minimal dislodgement can land up in the complication. This is the various advantages of graft, like retrieval, everything you should study, and you have to go to the CT scan room, discuss with the radiologist. You should have all the measurements, and then only, because here like coronary, if you this we can put one more stent, but here you have to put one more stent for prevention of either endo leak or missing the this one, like almost 4 to 5 lakhs extra amount patient have to spend from his pocket. This is very, very important. And this is about the deployment of the stent. This is the post procedure, and almost this patient is doing well for almost 1 year follow-up. And this was the following after ICD. Surveillance CT angiograms are very important for the follow-up to look for the any type 1 and type 2 endo leak and total resolution of the endo leak. And coming to the coronary, he had significant left main disease and heart team approach. And initially we thought of sending for CABG because of the critical left main disease. But after discharging him within a few days, he has come to casualty with again a severe chest pain. And our surgeons are not very happy in immediate post-operative to take him for CABG. So we have decided to do TAP technique, and the diagonal was pre-dilated. And LMC was stented with 4 into 32 mm stent and post-dilated. And here the big problem was because of the angulation, that circumflex for pinching up, there was a significant pinching of circumflex ostium, and the stent we are not able to track. But after with very difficulty, we were able to pass a stent, and finally LED and the LCX TAP technique and kissing balloon was done, and with the 4 into 8 and 4 into 4 into 12 mm balloons. And this was the final result. Almost 6 months follow-up, patient was doing very well. And coming to the second case, this is a 56-year-old hypertensive. He had angina and hoarseness of the voice. And this patient is a priest in Durga temple, and he used to, because of the hoarseness of the voice, he is not able to perform his duties. And you can see X-ray, there is significant, not the fusiform, this is sacral aneurysm, especially to the left supply vein artery. And this was the you can see the aorta, and there is a filling of the sacral aneurysm, the contraction is filling. And here the problem with this patient is the patient had a dominant left vertebral artery. This patient had a dominant left vertebral artery. Here you can see this was the filling of the, you can see contrast leaking into the aneurysm, and that is the dominant vertebral artery. So he also had the critical LED disturbances, and the LED was stented. So this we have done in the cath lab, and we have put all the lines, femoral line, right radial line, left radial brachial line. Then we took him to the theater. We have done carotid supply and bypass, and then we have again brought him to the cath lab and finished the endovascular aortic repair by 20. This was also, I think, Ankura graft. This is our second case, and this is also 34 into, I think, 160 centimeters. 34 mm window was 120 centimeters. This was. For dissection, we need to have longer stents because this is aneurysm. We put 120 endovascular graft, and so was you can see there is no endo leak. So there was a mild hematoma following PTCA versus endovascular position in the left supraclavicular fossa, secondary to the post-operative complication. Again, he required drainage, and he had endo leak from the, you can see the subclavian injection showed the endo leak into the graft that was closed with the 10 mm vascular plug in the subclavian artery. You can see that the third film there is a 10 mm vascular plug was deployed, the endo leak has come down. This was the endo leak from the middle film showing endo leak into the aorta. And this was post-operative surveillance and almost patient 1 year follow-up actually. Even LAD stent was patent. This is my case number 3. He has 68 years, hypertensive since 10 years. He also had significant angina, and he has only vague pain abdomen, and he was had through the surgical medical gastroenterology evaluation for the pain abdomen. And he has a long segment LAD disease that LAD was stented. And this is the CT angiogram of the thoracic aorta, 3-dimensional view. It showed 5 into 5.5 centimeters abdominal aortic aneurysm. And the problem here is even the left renal artery ostium also showed 70 to 80% stenosis. And the distance between the left renal artery and the neck was a little narrow. And he had one more CT angio 1 year back that was showed almost neck was more than 10 mm. But after 1 year, he had neck has reduced because of the progression of the aneurysm. And his patient daughter is the MD internal medicine in USA. And actually, I asked him to close follow up. But doctor, she's worried about the rupture, and the moment aneurysm increases, the procedural complications also increases. Once it becomes 5.5 to 6 centimeters, even the procedure may come down. There may be a complete sacrifice of the left renal artery. She's worried. Finally, she actually forced us to do endovascular aortic repair for this abdominal aortic aneurysm. And this is a very important 3-dimensional analysis. We need to have all the diameters, aortic neck, aortic length, and iliac artery length, iliac artery diameter, and where is the landing zone, where is the what are the branch vessels. These are very, very important. And here if you see what the risk of rupture, if the aortic aneurysm is more than 5 centimeters, the risk of rupture is 1 to 11%. If it is more than 6 centimeters, the risk of rupture is 10 to 22%. And if it is more than 70, the risk of rupture goes very high, almost 30%. And the next, this is very, very important. Morphological criteria. That means what is the neck diameter, what is the angle between the suprarenal aorta and the juxtarenal aorta. These are the very, very important parameters. So we need to master them. Then only we can improve the outcome in these patients. If you see the first picture, this is about suprarenal aortic aneurysm, and whereas second one is juxtarenal aortic aneurysm, the third one is infrarenal aortic aneurysm. If you see the third one, the length is 10 millimeters. And next more important is whether it is a sacral aneurysm or fusiform aneurysm. Then whether aneurysm extended to the iliac artery or not. Almost 10 to 20% of the abdominal aortic aneurysm have extension to the even the iliac artery. Next most important thing is these are the scores. Depending on the severity of the procedure, risk of the procedure increases. That is aortic neck length, aortic neck diameter, and aortic neck angle, and aortic neck calcification for thrombus. If you see here, this is aortic neck angle. Okay, this is the aortic neck length, this is the aortic neck angle, and this is the aortic neck calcification, this is the aortic neck thrombus. All these parameters are very, very important for the evaluation of the intervention. Once you see the suprarenal part, then you have to come to the evaluation of the aortic aneurysm. Here, aortic aortovelocity index, aortic angle, and any thrombus in the abdominal aorta, and aortic branch vessels, and the pelvic perfusion. Pelvic perfusion is very, very important because if you knock out the bilateral internal iliac artery, you will develop bilateral thigh claudication, buttock claudication, and sometimes even erectile dysfunction. All these complications are will land up. Okay. Again, once it comes to the after that abdominal aortic aneurysm, you have to assess the iliac artery. What is the any calcification? What is the diameter of the iliac artery? And what is the aortovelocity index? What is the iliac artery angle? And what is the iliac artery length and iliac artery diameter? If you see iliac artery diameter less than 12.5 is very good. If it is more than 17 mm, there can be endo leak from the distal limb of the iliac artery. There we have to use one more iliac occluder, or sometimes you have to block the iliac artery. These are the very, very important points. This is how we calculate iliac artery index, whereas iliac artery angle. And here we have done the chimney technique, or what you call chimney EBR or snorkel technique. And these are the various type of the graphs. And all these graphs, where are the markers? What is the marker at the contralateral limb? Where is the marker at the junction? All these things we have to master it. Then only we can go ahead with the procedure. You see the procedure. This is the endovascular. This one. Okay. 20, 16 into 14 into 116 mm, 160. And left renal artery stent was 7 into 26, I think 7 into 26 endovascular stent, left renal artery. Left renal artery stent we have to take it from the left brachial approach. Left brachial approach. This is a 28, 16, 14. And 16 is for the right iliac limb, 14 is for the left iliac. Left that contralateral limb. And while deploying the stent also, you should be very careful which side we are going to put. And this is the contralateral limb. You have to again access to the contralateral limb. You have to building size. And this is the post procedure. You have to look at the, not only the aorta but also limbs, whether there is bleeding from the iliac arteries. And these are the types of endoleaks. This is the type 1 endoleak, that is from the both from the top and bottom. Type 2 is from the retrogradely, either to the branch vessels. Type 3 is from the graft porosity, and really type 5 endoleak. And always remember the successful of the endovascular depends on the not only the selection of the patient, and especially on the basis of the vascular anatomy like angle and the choice of the correct endo process. And that you need to discuss with the technical person as well as with the interventional radiologist, and the familiarity with the technique and the procedure specific complications, and always pre-procedural imaging and the ancillary procedures and graft placement and the post-procedural medical therapy and post-procedural imaging surveillance are very, very important for the longer outcome of these patients. Thank you.
Thank you. So how frequently do you monitor your
first surveillance CT is after 1 month. After that, first 1 year, 6 months, and then after that, every 2 years.
Any questions from the audience? Okay, thank you. Thank you for your presentation. Now we call upon Dr. M. Karthik for critical limb ischemia. He's been a student of Guntur Medical College. He went on to do his vascular surgery residency in the University of Pittsburgh, and he is an assistant professor of surgery in Stanford Medical Center, and now also consultant in AIG. So I request Dr. M. Karthik to come on and share his experience on critical limb ischemias and his interventions as well.
Good evening, everybody. So I'm going to talk about chronic limb-threatening ischemia or critical limb ischemia today. Very happy to be here. And do I press this one to get this? Okay. So the first thing first is my topic today is going to mostly discuss about how do we treat limb ischemia and what are the new paradigms, because there are very few cases I'm going to talk about, but the first thing is the nomenclature has changed. We no longer call it critical limb ischemia. It is supposed to be called as chronic limb threatening ischemia, because if we say critical limb ischemia, it only implies a value of impaired perfusion, but there is no continuum of it. So what is chronic limb threatening ischemia? Is a person with peripheral artery disease with rest pain, gangrene, or a lower limb ulceration. It should be greater than 2 weeks of duration. Mostly, what are the parameters? If we look at the ankle brachial index to be less than 0.4, ankle pressures to be less than 50, and if we have the equipment, the transcutaneous oxygen pressure to be less than 30. And we all know what are the risk factors. The only thing that is very important is in most of the meta-analysis studies, it has shown that obesity with more BMI has a lesser risk of having PAD, but when the confounding factors are corrected, it is showing that it is not that great. And also chronic limb threatening ischemia, when we think about it, we mostly talk about legs, but this sometimes also happens with the hands. There's a 56-year-old female with severe POD involving the hand. And when she presented, was very sick. In fact, there is no runoff. She's not a smoker. So this is a particular case which we have treated with the combination of anticoagulation, antibiotics, and calcium channel blockers, mostly similar to Raynaud's that we have treated, and had a surprisingly good result in 8 weeks. So this is one of the spectrum we have to remember when we talk about chronic limb-threatening ischemias as well. So the association of risk factors with the level of atherosclerotic targeted lesions. So say, for example, as a patient's age, you know, the disease is mostly involved in the tibials. The same with male gender, surprisingly, they involve both the iliacs and also the crural vessels. Diabetes, as we all know, it involves mostly the microvasculature and the crural vessels, and it is very hard to treat. Hypertension, they involves significantly all through the lesions, and others, as you have seen, smokers especially, mostly the iliacs are involved. So what is evidence-based revascularization? We all know that when there is a lesion, we fix it, we increase the blood flow, but when do we stop and how do we decide what to do? What does the data say? So we all know if there is a lesion in the SFA, superficial femoral artery, or somewhere, we all tend to go there, put a balloon or put a stent or do a bypass or whatever. So how do we decide? So after the global vascular guidelines have met in 2020, have realized and recognized that we should have a plan. So what is this plan? Plan involves, first is assess the patient risk. What is their 2-year survival? What are the other risk factors of the patients have to be assessed first. And next one is the limb severity. Third is the anatomic complexity. So if we have these three, the next is the strategies for evidence-based revascularization. It's not just salvage of the limb. It has to be effective and also has to be a long-term goal. So as you can see, the anatomic complexity of disease, and they also have to see limb severity on one aspect and the patient risk. Is the patient at an average or high risk? Is the complexity of the disease severe or it is amenable? So this is something which we deal with. So I urge every practitioner who deals with peripheral vascular disease to go with the Wi-Fi classification, which is now the Society for Vascular Surgery recommended one. It is wound, ischemia, and foot infection. Anybody who presents with a foot ulcer, we have to assess the Wi-Fi classification of the patient. It takes less than 2 minutes to assess. We even have apps for that. And you give a number based on the Wi-Fi classification where you assess the wound, assess the ischemia based on the studies we have done, and also the foot infection. So if there's a clinical suspicion of limb ischemia, obviously you do a physical exam. Even though the chart looks very busy, I'll just make it simple. You do a pulse exam. If there is no pulse, you go and do the investigation, whether it is ultrasound or ABI to start with. And then you measure the toe limb. And then we see the severity. And then we go with the vascular imaging. So imaging the arterial anatomy, we all know that we have one is ultrasound, we have CT angio and MRI. Ultrasound is the first line of treatment, and the next one is the CT angio. But for tibials, if you are looking for something that is applying to the tibial vessels, we go with MRI. So the global vascular guidelines propose a new staging system called GLASS. Previously, it used to be task 1 to 4, but now we have a global anatomic staging system. It is similar to your syntax for the coronary artery disease, which involves a preferred target artery pathway. So it's a simple, to just simplify this slide, if you want any wound to heal, you should have an inline pulsatile flow to the foot. And the artery we choose should be minimally diseased so that we can intervene and improve the flow. If any wound has rest pain or if the leg has ischemic rest pain, the most important thing is to improve the flow, and the target artery pathway will do that. So say, for example, this is a 73-year-old male who was referred to me in Hyderabad here, and who had a toe amputation done for the past 2 weeks. And he goes to a pretty advanced Wi-Fi classification system. And so we did the MRI and there is no flow whatsoever even on the ultrasound. So that patient underwent an angiogram. And as you can see, after the superficial femoral artery above the adductor canal, he has no flow whatsoever down below the foot. And as you can see, there is absolutely no flow down to the foot as well, even from the collaterals. Usually these people are ending up with amputations, but to do a bypass, there is no target. Even in these lesions, you know, we tend to cross the lesions, but the tools I use is we park a catheter right where the occlusion is. I'm not a fan of atherectomies because they just add the cost and the results are not that great. And for me, it has been either the overnight system, command wire works well, your BMW wire works well. And once you get an access, even if it is subintimal and we cross through, even though we do not have a runoff in this foot. In this particular case, once we have improved the flow across the SFA, as you can see, this was used, the overnight system was used, and then we were able to cross it using a CXI catheter, initially going subintimal and then was able to cross through. And once that is done, we ballooned it and put a stent across because obviously because of chronic occlusion, there was resection. And there is an improved flow, even though initially when we saw there is nothing supplying to the foot. As soon as we improve the flow of the stent placement, there is at least this partial pedal arch filling. And the patient who has been suffering with severe pain, infection, and was at risk of losing his limb. And there was a good progress in the wound, was ambulating, the rest pain is resolved. See, most of the times in the papers, we as a vascular interventionalists always say, don't just look at the angiogram. You have to look at the clinical picture as well. We can show 100 pictures showing that we have improved the flow to the foot, but if it is not sustainable and the patient does not have a good result, it doesn't matter. So now the patient has not only improved the flow into, the fourth toe is also able to be saved. So the global anatomic staging system is first you obtain a high quality angiographic image to include the ankle and foot. You identify the target artery pathway, which is the artery I'm going to improve the flow to the foot. And then we grade the disease both in the femoropopliteal system and also in the infrapopliteal system. And depending on the severity of the classification, I'm just specifying this very simply because of lack of time. But the thing is, every time you want to intervene on a leg, take 2 minutes. Assess the Wi-Fi classification. It is available online and there is an app to do that. And then see in which category this patient comes. Do I treat him medically? Do I treat him endovascularly? Do I refer him for surgery, or do I just go straight away to amputation because it is not going to improve no matter what I do based on the evidence? So, and in doing so, we also have to assess the pedal circulation, because if there is P0, that means the target vessel crosses the ankle, you have a higher chances of success. But if it is P1, whereas there's only half filling the arch, it is not going to be successful. And if there is no target artery crossing the ankle into foot, your chances of success are low. Just like the case I have discussed, it defies my own practice where, if I have seen the Wi-Fi classification, again, in that patient, I shouldn't be attempting anything and referring him to amputation because it's not sustainable. It's been 3 years now and that patient is still walking with his foot intact. So that patient comes under a very high grade classification of P2. And because of his comorbidities, I was not able to refer him for an amputation or do anything. So even our intervention there has helped him. So the global anatomic staging system in first time lower extremity revascularization in 1180 first time revascularization patients, the re-intervention event, as you see, for endovascular revascularization is very high. The 5-year re-intervention event is almost close to 70%. In my clinical experience, it crosses to 80% that most of these patients would need a re-intervention with a balloon angioplasty or restenting. And the endovascular failure to cross the lesion also goes high, but as you see, the number is not that high. So you can always try endovascular approach first. The one thing is doing only endovascular approach first sometimes destroys the target vessels to the point that they could not undergo a bypass. So we have to take a decision informed based on the evidence that we have. As you can see, the 5-year restenosis rates for endo is very high. In an advanced glass stage disease, as you can see, is almost close to 83%, and it is statistically significant. So as I said, even though you improve the flow, it looks better in the cath lab, the patient feels better in 3 months, but then again, in 5 years, it's definitely going to fail. So you have to gauge the patient risk in our plan cohort and go from there. I'm not going to go into this one. This is another patient, as you can see, that I'm talking about the target artery pathway. We have assessed this patient. There is very severe disease. Again, there is no flow whatsoever. For this, the only target pathway I can see is a peroneal pathway. But once we have improved the flow to the SFA, I can see both the tibials and also the tibioperoneal tract intact. So that was improved. And this patient's result, he had this wound for almost 10 years, and with improved flow and the maximum medical management, this was improved. And similarly, in the other leg, the patient had the same issue, which was improved with the target artery pathway. And these were all done based on the Wi-Fi classification, whether we should do the right thing in terms of endovascular approach or open. And all these patients underwent endovascular. The confession is, in the past 5 years of my peripheral interventions, the number of times I have done a peripheral bypass is close to less than 5%. So outcome of revascularization of diabetic patients, it's surprising that we all have a bias to kind of brush off diabetic patients saying that their limbs are going to fail. But the evidence says otherwise. In a national surgical quality review on almost close to 9,000 patients, the revascularization for critical limb ischemia or chronic limb threatening ischemia in diabetic patients is almost similar to the non-diabetic patients. It's similar 30-day mortality, similar length of stay, similar readmission, and they even had lower risk of major adverse limb events after open bypass than after endo repair, because we all have an innate bias saying that diabetic patients are not going to do well. So medical management, I'm going to be brief on this aspect because there's a lot of discussion going on, and the recent trials have said in the practice, if we're going to put an antiplatelet, clopidogrel is the one single agent that is preferred to aspirin, and also dual antiplatelet is not preferred. Oral anticoagulation is never the right answer. And from the COMPASS trial, even for PVD, the most thing is a combination of aspirin and rivaroxaban 2.5 milligrams has superior results after intervention. In my practice, everybody that has a stent, we use Xarelto 2.5 or rivaroxaban with aspirin. And this is the recent study trial. And finally, the surgical management, what does the evidence-based medicine say? So you do your Wi-Fi classification, assess the severity, and then the anatomic complexity on the glass staging. So people who are on the advanced stages, if you can see, sorry, can I go back on this one? Yes. So the people on the advanced stage have more surprisingly better results with open bypass. So the one with the Wi-Fi stage 4 and anatomic complexity is high. If there is an open repair that can be done, that is actually preferred when compared to an endovascular approach. But most of the patients that we see get into this gray indeterminate zone. It's never a right or wrong answer. Depending on the preference and the tools available, we always tend to go with the endo option. But sometimes maybe the patient, if he has a good runoff and a very good greater saphenous vein, if it is not already taken for a coronary artery bypass graft, can undergo an open bypass. But that being said, in the routine practice, it is rarely seen. Thank you for this opportunity. And as part of Stanford Global Surgery, we are here in India now establishing vascular centers across the country. And first space would be AIG hospitals in Hyderabad. And the next would be in Geetham's Vizag. And the other one is going to be in Medanta, Delhi. Even though these are private setups, we thought we had better opportunity of reaching out more people in establishing our care centers. Thank you so much for your time, and I'm glad to be here. I'll take any questions.
Thank you, Karthik. And I think you've become an interventional surgeon as well.
So I was just.
So we as an interventional cardiologist, we see less of surgeons doing the interventions. Now there is a new breed called interventional surgeons as well.
So vascular is that one. So vascular, the way we have formed and way we are trained, it's an integrated vascular. So from day one, my time is equally split between cath lab and the OT. So now it is mostly all cath lab. So vascular there in US is all endovascular, to be honest with you.
I think Dr. Vijay Govind amongst us is the highest number who has done his peripheral interventions. If he has any questions to him from the young guy.
Thanks, Dr. Karthik, for coming to us. We do a very crude job, actually, considering that these are extremely resource-intensive procedures, a lot of money, and especially the reason which you said you are establishing with private centers, the reason is obvious. So, can you talk us about the reusability of these? I'm sure you don't like this question, but that's what we want to know. Do you use them? You don't like it, but do you?
So we are forbidden in the US to do anything because the FDA only approved for single use, including any catheter. None whatsoever can be reused ever. That being said, when we first started in India, we started looking that where at, say, for example, AAG, the patients come, even though the Stanford pays for most of the, devices, again, there are certain patients who cannot even afford, the hospital stay and those things. Then I came to know that most of the balloons and catheters are being gassed or reused and things like that. So I think the second case you have seen was the one which we have used gassed products in. But that being said, I would certainly think, say, for example, if you're talking about your glide wire or the Terumo wire you're talking about, once it goes through a cycle of gas, I think the pushability or even the steerability across has changed a lot significantly. There has been a multiple front research on this saying that, are we just going by the company's thing to sell a product that it has to be only used once? Not only in this sector, especially for the venous sector, the RF ablation catheters here are used multiple times, whereas in the US, we throw everything away after single use. So to answer your question precisely, I think in certain areas, like say, for example, in your peripheral interventions, I don't see anything wrong in using a gas product maybe once. But when it comes to TVARs and EVARs, I had multiple times to bail out where the pigtail catheter has, with the pressure and all, has been completely severe and actually causing a damage. Because if something has happened because we didn't use the equipment properly or the equipment which is not there, then that is not a liability that we can accept. So in a resource intensity, because we have had this discussion with Narayan Hudayala, who uses the highest amount of gas products in the country so far. And they have said they had similar complications if you go through by the audit data actually, but we have to find a middle ground. I would say if you can use once, that is fine. But if you're using multiple times, then again, you only need one complications to get it be. But I would be the wrong person to answer that question.
Thank you for being honest. Yeah. So two short questions. When you said the straight line flow to the foot, you're talking about the angiosome concept.
So there is one, the new, previously we used to treat the angiosome concept wherever you see the PT, and go with the angiosome concept where the foot is located. But right now we believe the research is speaking otherwise. Most of our meta-analysis recently has said that one single line flow to the foot, say for example, from the iliac to the SFA to the POP to the foot, immaterial to whatever we see, because in diabetics, most of the time the data is saying the PT is the mostly diseased vessel that we see. The peroneal is somehow, it's always spared. And the dorsalis pedis is also almost always occluded. So even if you improve the flow all the way to the peroneal, it is bound to at least get up to the transmetatarsal amputation level. So the angiosome concept is now lacking evidence. So we're going with improving one line flow, whether it is just one vessel. We don't have to go after the two tibials, just one vessel, straight line flow, pulsatile flow to the foot will salvage whatever is there.
But often we see tibials coming down, you open it up 2/3 down, and then the peroneals pick up from there.
It does, definitely. As long as you have one flow, it actually helps. It would be preferred if you can cross into the tibial all the way up to the foot. Again, we're talking about one straight lane, but if it is going to the peroneal, then you have to improve the peroneal from up above, which is occluded. You just need one straight lane down. So whatever you can achieve through that, that will do the job. Thank you so much.
Yeah, thank you, Karthik, for your presentation. Now I call Dr. Anjit, who has been my colleague in Amrita. He's been a good intervention cardiologist working in Guntur and along with Sinus Reddy sir here. He'll be talking on venous interventions. So it's all up to you. In between, all of you can grab your tea, coffee, because we are running a little late. I think we'll just continue the session.
we see the scope of our interventional cardiology is increasing. We saw Dr. Raghav Setma sir talking a lot about stroke interventions, and they became one of the authority in stroke interventions in India and across the world. So now many of us are doing peripheral interventions in arterial interventions. Today I will be talking briefly about venous interventions, what we cardiologists can be doing in the cath. So venous thromboembolism is the third leading vascular disease. The first being MI, coronary vascular disease, which we are taking care of. Second being stroke, which also we are taking care of. And now this venous is the third most leading cause of vascular disease. This includes DVT and pulmonary embolism. The clinical presentations of DVT of the legs include edema, erythema, pain, and presence of collateral results. So many people, many patients come with complaining of varicose veins. They have got it sclerosed, got surgery done many times. Again, the varicose veins recur. And most of them are found to have DVT, chronic DVTs causing collateral veins, which present as varicose veins. So anticoagulation therapy is the mainstay of treatment for all these patients, not intervention. Anticoagulation therapy is the mainstay. So we all know we start the patients with DVTs, with acute DVTs on heparin, the loading dose of 80 units per kg per minute and per hour, and we give an infusion of 18 units per kg. It is 5,000 units we start and 1,000 units per hour we start as an infusion for 24 to 48 hours. So if the patient improves, yes, well and good, no problem. We reassess, we do the Doppler after 2 to 3 days, and if it's fine, we discharge on anticoagulants. So there are other anticoagulant methods like enoxaparin and oral anticoagulants, warfarin, rivaroxaban, apixaban, roxaban that we use in these patients. The recommended duration for provoked DVT is 3 months. For unprovoked DVT is more than 3 months, 6 months. So when we have this treatment and all of us are regularly treating these patients, why do we really need intervention in DVT? So what are the cases where we need to intervene in DVT? First of all, we need to understand that heparin is an anticoagulation therapy. So anticoagulation means it does not precipitate thrombolysis. So the clot is not dissolved by our drugs. So it just stops thrombus propagation and protects against recurrence. But these venous clots are very huge, friable, and they are not easily, like the body thrombolysis mechanism can't remove it so fast, unlike the arterial clots. So these things, when the clots are very large or in the proximal veins, we need to intervene. And one of the most important entity I want to describe is the post-thrombotic syndrome. This is because if we are not able to prevent, like we are not able to dissolve the clots with anticoagulants, these patients have to suffer their life long. So there is a lot of morbidity, there is a edema of the leg, so and ulcerations, venous ulcerations, pain, etc. So approximately 25 to 50% of the patients with lower limb DVT develop post-thrombotic syndrome despite adequate anticoagulation. So this is because of chronic venous hypertension secondary to valvular destruction. And the symptoms include swelling, pain, heaviness, and venous claudication. So normal blood flow in the vein depends upon the valves in the vein. And as we know, the calf is the second pump in our body. So whenever there is a calf pump, the blood moves upwards and the valves prevent the blood from coming back. So when there is chronic DVT, there is a chronic inflammation which leads to destruction of the valves. So there will be stagnation of the blood fluid and there will be chronic edema and venous ulcers, which are very hard to treat. So these are pictures of some patients with chronic DVT ulcers and chronic post-thrombotic syndrome. These things can be preventable because if we lose, for example, if we ask the patient to be on oral anticoagulation for 2 months, 3 months, 4 months, we lose the opportunity of treating them. Because once it is developed, it is very hard to treat. Only in the acute conditions, like after a week or 10 days, 15 days, we can intervene and we can prevent post-thrombotic syndrome in these patients. So other entity I want to discuss is May-Thurner syndrome. This is also called iliac vein compression syndrome. So common cause of iliac vein obstruction of non-thrombotic etiology is May-Thurner syndrome. It is due to compression of left common iliac vein as it traverses behind the right common iliac artery in front of the vertebral bodies of the lumbar spine. So this is the image. You can see the left common iliac vein is being compressed with the right common iliac artery, the junction where it is joining the IVC. This entity, we can't just treat with anticoagulation, because even, for example, if it opens also, the patient will have recurrent DVTs. So that is the reason why we need to treat it, we need to stent it by venous stents. Other important and rare condition is phlegmatia singulae dolens, that is very painful blue inflammation. This is because of severe edema from venous obstruction. This leads to arterial ischemia and ultimately gangrene with high amputation mortality rates. This is the thing which requires immediate, very immediate intervention, and also may require compartment syndrome may develop in patient, may require surgery. So now the indications for the DVT interventions for acute, like phlegmatia singulae dolens, and IVC thrombosis where there is renal failure, and iliofemoral DVTs where there may be occlusion of very large vessels and also May-Thurner syndrome, and rarely in femoropopliteal DVTs which are not responding to anticoagulation. So what are the options available? Few things Dr. Sharma sir also discussed, because that are used in stroke interventions also. One is catheter-directed thrombolysis and pharmacological and mechanical thrombectomy. So in catheter-directed thrombolysis, it is performed emergently, urgently, or electively. Emergently in cases of phlegmatia singulae dolens, urgently in case of inferior vena cava obstruction, especially when the patients are at risk of renal failure. Electively, it can be pursued in acute iliofemoral DVT in symptomatic patients in order to prevent the PTS. So many symptomatic patients with acute femoropopliteal DVTs improve with anticoagulation and compression stockings. Only it must be reserved for patients who does not respond to medications and also iliofemoral DVTs. So what are absolute contraindications? Like our thrombolysis in MI, the same absolute contraindications apply. That is active internal bleeding, cerebral infarction, neurological eye procedures, head trauma within 3 months, intracranial tumor, aneurysm, and vascular malformations. Related to uncontrolled blood pressure, major trauma, surgery within 10 days, GI bleed, pregnancy, infected venous thrombus, severe renal or liver disease, etc. So the procedure, actually before 24 to 48 hours, we give the patient, give the patient a heparin infusion, 1000 units per hour, maintaining APTT twice the control. So pre-procedure imaging is reviewed to determine the approximate access site in order to maximize the infusion of thrombolytic agents. A venogram is performed to confirm the patency of the outflow wheel, and angiographic catheter is then exchanged for a multi-site cold infusion catheter, and we can infuse 0.5 milligram per hour Antiplatelet or Altiplase 1 milligram per hour to the catheter for 12 to 24 hours. In addition, 500 units of unfractionated heparin is administered to the vascular sheet per hour. So outcomes, in various studies, the outcomes are good. The venous success is defined as greater than 50% reduction in thrombus burden. It occurs in greater than 90% of the patients, and but 30% of the patients, there will be recurrence. So we need to follow up the patient and put in anticoagulation and stockings. So there are very few RCTs available for patients for the use of catheter-directed thrombolysis. One is CAVEN trial. It's a 5-year follow-up results. Out of 176 patients, 87 are in catheter thrombolysis group and 89 are in control group. So 37 patients allocated to catheter-directed thrombolysis group developed post-thrombotic syndrome compared to 63. So this corresponds to absolute risk reduction of 28%. So other method we have is mechanical and pharmacomechanical thrombectomy. So there are various methods devised: rheolytic thrombectomy like angiojet, rotational thrombectomy, and suction thrombectomy like the penumbra device or Dr. Sharma sir described. So this can be combined with both lytic agents to achieve rapid clearance of the thrombus. So this is a chart showing all the available thrombolytic, most of the available thrombolytic agents, mechanical thrombectomy devices in the market. The rheolytic thrombectomy, angiojet from Boston Scientific, and suction thrombectomy, the indigo catheter from penumbra, more commonly used. This is the angiojet. It has 2 holes, proximal, distal. From the proximal, there will be saline or heparinized saline will be pushed to the vessel, which is sucked through the proximal. Along with it, the thrombus also comes inside. This is the penumbra device. It is just like a suction, what we use. Catheter is introduced into it, and there is a stylet which we can needle the clot, and the suction can be done with the device. So now presenting my case, one of the cases. I have very few experiences. I did only 5 cases. So one important case I am presenting because I want to show something in this case. This is a 48-year-old male post-COVID in May 2020. He presented with left lower limb DVT in July 2020. So he was treated with heparin infusion, but there was no improvement even after 48 hours. So Doppler showed involvement of iliac and femoral veins. CT venogram showed occlusion of the left iliac vein till popliteal vein with thrombus and no flow. So the reason why I took him for procedure. First, I took a right venous axis, right femoral venous axis, and it's a popliteal venogram showing complete occlusion of the popliteal artery. The axis was taken with ultrasound guidance. So I crossed the lesion, the thermobire, and dilated the vessel, multiple barrels, multiple peripheral barrels. Finally opened it. So at this point, I want to show when the vein is joining the IVC, we can see the compression there, the arterial compression there, just like we see in the LAD. And now there is a bridge, what we see in the LAD. Similar pattern we see here. This is very typical of May-Thurner syndrome, where the artery is compressing the vein. So I completed a procedure with multiple runs with the penumbra catheter, and a thrombosuction with the penumbra catheter. Then I shifted the patient to the ICU and put him on tenective plus infusion. Atherectomy thrombolysis was done again because there's a lot of thrombus burden. Heparin was given to the sheep. Next day again, I took for a procedure check. Showed significant resolution, clearance of the thrombus. However, the proximal part of the vein is completely occluded. So again, I crossed it and again ballooned it. I want to check where is the occlusion because the proximal part is open. Then that is open. So down the occlusion is near the head, at the location of the head. So again, in the angioplasty, with a balloon, open the vessel. Open the vein completely. So after achieving the forward flow, in this case, it requires a venous stent because it will again close. Because the proximal part, the where the vein is joining the IVC, there is a tight compression there because of the artery. So this case requires venous stenting, but unfortunately, that's a COVID-19 pandemic. Stent was not available in India. We tried a lot. However, the patient improved drastically, and within 2 days, the swelling decreased, and he was discharged on anticoagulation DVT stoppings. So repeat CT venogram for 1 month showed a lot of thrombus clots, but still the vein is flowing. It's not completely occluded, and the patient is better. So we prevented this patient from going into PTS. So now, take-home message. So venous interventions for DVT must be considered in iliofemoral DVT post-thrombotic syndrome. It is feasible with routine catheters available in the cath lab. It gives instant results. So I have experience of 4 more patients. So all patients have very instant results. They're very happy because the swelling, which like 4 days, 5 days old swellings also come down drastically, and they're happy with that. And it prevents development of post-thrombotic syndrome. It also prevents long-term morbidity after successful procedure. The procedure must be done within a week post unsuccessful anticoagulation for optimal results. Patients with May-Thurner syndrome needs venous stenting, and post-venoplasty, the patient must be kept on anticoagulation and stockings. Thank you.
Nice talk, Ajit. I request Karthik to share his experience on venous stentings as well, because we do less of venous stentings here, and because they're predominantly not available, and less of venous interventions as well. That's what you'll be.
Karthik, I have one. All these years we were managing medically iliofemoral DVT with the anticoagulation. Do you really feel that there is a significant difference in the outcome of these patients? Because now we have put IVC filter, he may need lifelong anticoagulation. See, do you retrieve the filter anytime? How many? In case we remove the filter after 3 days. As for the procedure, we put a filter because it's a very large thrombus, but I don't know.
I think in this case, you should be retrieving because it's going to be a long-term problem because it's a May-Thurner, there is a compression. You yourself have seen it reoccluding very short off. I think I will not retrieve this at least for 6 months.
15 days, you would at least after 6 months maybe.
6 months or 1 year. I mean,
what is the time for retrieval? Do you think it is after some time it is difficult to retrieve or something?
that is why international data says 85% are not retrieved, and that is why they are more incentivized to retrieve them for legal issues. So thank you very much, Karthik, and thank you, Anjit, for your intervention on venous side. Thank you. And now I call Dr. Akula Siva Prasad to talk on. No, he's not there. So that ends the session. Thank you very much for joining, and we will continue with the next session. The chairperson, you want me to announce? Thank you, sir.
Dr. Baji Babu, Ranaji, Naveen Krishna, Naveen Krishna. Thank you. Chairperson. Kalyan Chakravarti. Kalyan Chakravarti. Rao, please chair the session. Thank you very much, Chair.
Srinivas Reddy. Anuka, Srinivas Reddy. Not there, sir. He's going to speak. You're going to chair the session. You will speak, he'll chair. Thank you, Sinus.
So, can Manjakshma madam please come on to the screen? Was rheumatic heart disease, is there a research? Is what I've been able to hear from.
Respectable chairpersons, moderators, dear faculty members and students, good evening to all of you. So at the outset, I would like to thank the organizing committee and Dr. Harita for giving me the opportunity to present. So this topic I will present under the following headings: introduction, little introduction about rheumatic heart disease, diagnostic criteria for the screening of rheumatic heart disease, and SWIMS data, what are the preventive measures, and what is the take-home message, and what are our initiatives. So coming to the introduction about rheumatic heart disease, it is the most common cause of acquired heart disease in children and adults globally. It is due to the sequelae of acute rheumatic fever, and it is a disease of poverty, poor sanitation, overcrowding, malnutrition. These are the contributing factors for this disease, and clinically it ranges from clinically silent disease to severe permanent valvular damage, and it is associated with risk of heart failure, arrhythmias, cerebrovascular accidents, infective endocarditis, premature deaths, and poor maternal and fetal outcomes. So these are the Jones criteria, major criteria, minor criteria, laboratory findings, and evidence of supporting evidence of antecedent gas infection. And coming to the criteria, two major, one major, two minor criteria, associate along with the evidence of gas infection. And sometimes when there is indolent carditis and chorea, supportive evidence of gas infection is not required. Recurrent episodes require not stringent criteria, one major or few minor criteria along with gas infection evidence. So World Heart Federation, today I will talk about what way we can screen for rheumatic heart disease. So mostly on preventive aspect, I will focus on the preventive aspect. World Heart Federation has given diagnostic criteria for screening of rheumatic heart disease. That is definite and borderline. Definite criteria, pathological MR plus 2 morphologic features, or mitral stenosis with gradient of more than 4 millimeters of mercury, or pathological AR with 2 morphological criteria. Any one evidence is required to diagnose rheumatic heart disease asymptomatic children. And to say borderline rheumatic heart disease, 2 morphologic features, pathological MR, pathological AR are required, any one. So coming, when we say it is pathological MR, so it is seen in 2 views: jet length more than 2 centimeters, velocity more than 3 meters per second, pan-systolic jet. Pathological aortic regurgitation seen in 2 views: jet length more than 1 centimeter, and the velocity more than 3 meters per second, and pan-diastolic jet. So to say morphologic features of mitral valve, anterior mitral leaflet thickening more than 3 millimeters, caudal thickening, restricted leaflet motion, excessive leaflet tip motion during systole. Morphological features of aortic valve, irregular or focal thickening, coaptation defect, restricted leaflet motion, prolapse of the leaflet. So when the criteria met for definite or borderline, we can consider as rheumatic heart disease. So this is WHO criteria where the importance was given only to pathological regurgitations, both mitral or aortic regurgitation. So source of data for to screen the patients. The first one is which is not available in our country, that is hospital-based registry data or population-based registry data. And next one which is available is to detect the burden of clinically significant rheumatic heart disease. Here, hospital admission data, the various studies report the prevalence between 25 to 15%, and hospital outpatient data is another source where studies are not available. And the following two gives the burden of true disease. This by prospective population-based active surveillance studies and individual investigator-led survey studies in school children. Among these two, certain studies are based on auscultation and another studies are based on echocardiographic examination. Here the prevalence ranges between upper one between 1 to 5%, various studies report in between the two. And the school children, the range is between 1% to 11%. Earlier studies are based only on auscultation, later echocardiographic studies were also there. This is ICMR based prevalence study, ICMR multicentric studies. They showed, they have given the declining trend in the prevalence of rheumatic heart disease 70 to 75 between 84 to 87 and 2001 to 2007. So in this, the data shows there is a declining trend in the prevalence of rheumatic heart disease. So now we'll see what is there at SWIMS. So this study was done by our BSc cardiovascular technology student. As part of their internship, they will do one project. This girl studied the retrospective data from echo register, 1 year rheumatic heart diseases she collected from the echo register from November 20 to October 2021. She has done retrospectively. So this is the distribution of her data, and totally in 1 year during COVID period, we have seen 549 rheumatic heart disease cases, not children with acute rheumatic fever. They are the cases of chronic rheumatic heart disease. This is the distribution. Because of time, I will not go into the details. And the commonest age group is between 40 to 50 years, and females are more in her study. And this is the distribution: mitral stenosis, mitral regurgitation. Among them, 439 are having mitral stenosis, 418 mitral regurgitation, and that is the severity of the disease. So this is about aortic stenosis, aortic regurgitation, tricuspid valve disease. Tricuspid stenosis, 1%, tricuspid regurgitation was seen in 99% of the patients, and tricuspid regurgitation. This is the statistical distribution of the study. I will not explain all these things. Multivalvular diseases were there, and 283 patients are having MS-MR combination, followed by MS-AR, MR-AR. Among the mitral valve disease MS patients, 439, 58 patients are suitable for PTMC. Remaining 381, they are having mild or moderate disease, or it is part of multivalvular disease where they were advised surgical advice. And among the valve replacements, 32 patients underwent double valve replacement, and remaining patients underwent mitral valve replacement. So this is the data of PTMC from SWIMS. Data is from 2010 to 2021. this is statistics, and 2020 there was less cases, maybe because of COVID. And wall replacements data from SWIMS. This is both the aortic wall, mitral valve, and double wall replacements overall. Again, it also shows some decline during the last 2 years. The reason may be COVID. And this is the prosthetic wall clinic data from SWIMS 2011 to 2021. Because of initially when we observed many people, patients with stuck prosthetic valve, we started free prosthetic valve clinic last Sunday of every month. There every Sunday around 300 to 350 patients will come. We will do free PT INR test along with free acetram tablets to the patient, so that this stuck prosthetic valve problem has a little bit come down in our institution. And this is the data. Annually, this many patients are coming to our prosthetic valve clinic. And here also some decline in 2020. So another study is MSc echocardiography student, prospective study, 6 months study, and she studied the demographic, clinical presentation and management of patients with acute rheumatic heart disease. 6 months from November 2020 to April 2021. Again, this is the divide. 200 patients she studied during that period. Mitral stenosis division of the cases. So this is to emphasize that 1 year, that during COVID period, we have seen this many cases in SWIMS. And every day, even today, we are average getting 10 patients, approximately 10 new patients with rheumatic heart disease. Income, majority are belong to low socioeconomic status, where the family income is less than 10,000 rupees per month, and majority of them are staying in villages. And nuclear families and mixed diet, they are there in that study 6 months period. Among the 200 patients which she studied, this is the other aspects which we collected. So coming to about prevention. So again, other places, few years ago, I have gone to Kottayam to attend rheumatic heart disease summit, where they told they have not seen rheumatic heart disease over the past few years. And last week, gone to Chennai as examiner. There also they kept one 70-year-old lady as long case rheumatic heart disease. They were telling they are not finding rheumatic heart disease cases. But in SWIMS, the case is reverse. We are seeing daily, we are seeing many cases not seen previously, new to us, and reasons we have to think. So because of accessibility to healthcare, the people who are having the problem ignored earlier, they're coming to hospital, are still rheumatic heart disease is going unnoticed. These things we have to see. That's why we'll talk about the preventive aspects. Primordial prevention, primary, secondary, tertiary prevention. So time is also coming down. So what is the need for prevention? So in India, if we go to population divide, less than 30 years age group, more than 50% of Indian population is below 30 years of age, and 26% of Indian population is below 15 years of age. That's why if this younger population gets affected, productivity and potential of our country comes down. That's why it is imperative to focus on preventive aspects in our country. So for any disease, in addition to organism and host, environment plays important role, both external environment and internal environment of the individual. That is the immunity of the individual. Two aspects we have to address. So World Heart Federation 2013, the position statement is 25% reduction in premature deaths from acute rheumatic fever and rheumatic heart disease in individuals less than 25 years of age by 2025 by implementing comprehensive and effective national programs. The major impediments for this is lack of true estimate of disease burden, little research in this aspect, few initiatives which were undertaken, wide socioeconomic disparities, and many gaps in our knowledge of the pathogenesis of RHD. So 5 key targets were enumerated by World Heart Federation. Development on comprehensive registry-based control programs, providing global access to benzidine penicillin, identification of RHD champions to deliver messages for prevention, better training of healthcare professionals for RHD management, and support for vaccine development. So, this topic mainly focuses on the burden of the disease which we are seeing at the Tirupati, and the what way we can prevent this disease which is affecting the younger population of our country. So it is a disease of poverty which is preventable, and that's why we have to promote the well-being at all age groups by improving the external social conditions of the community and improving the immunity of the individual, and echocardiographic screening so that we can estimate the true burden of disease in the community, and evidence-based primary and secondary prevention programs. So in Tirupati, we are doing some initiatives. It is a perspective undertaking some initiatives. Nearby one village we have chosen, and that school on Tirupati TTD support school is there. We started working on the school teachers and school students, took the population statistics of that village to educate the people, and other things, educating the teachers of TTD schools. Many schools are there in Tirupati, started educating that also. That side, educating the teachers of Tirupati Tirumala Devasthanam school teachers, and now MSc Echo students are there for us. Another project which given is to screen the students based on World Heart Federation echocardiographic criteria. We want to screen the school students. Want to take up government schools and TTD school students, and some projects we are doing on pregnancy, so that it starts working on the immunity of the child which is going to born, and involving other NSS NGO groups also to help us in these aspects. Thank you.
Madam, no, rheumatic heart is seeing less cases. Is it decreased or increased?
We are seeing more cases.
See the liver area.
We are seeing
Belongs to West Godavari. We are seeing less cases.
We are seeing more cases. That's why
15 years back it is more.
even today we are seeing more cases. Daily average 10 new cases we are seeing. That's why we want to screen through project works, and simultaneously we want to educate the students, teachers, and family members also.
Sampath sir, is the traumatic heart disease decreased or same or increased now?
So we are talking about the statistics of chronic rheumatic heart disease.
So, sir. We are giving penicillin, madam. That's you are telling what after 35 years you can stop.
So sir, we are giving up to 40 years of age because all the patients with chronic rheumatic heart disease, they are having only skin and bones. That's why you are facing difficulty and even patients are telling unable to take the injections. We give oral tablets, again complaints is coming down.
And also the relevance of benzoyl penicillin is also present. Patient having chronic valvular disease, was 35 or 40. How long we are giving?
That's what India, because of the more prevalence of infections, we can give lifelong, but it is not practicable. Patients, one problem is skin and bones, very difficult to take give benzoyl penicillin for them. Another thing is most of the times the penicillin is not available. And sometimes it will be available, sometimes patients, so many places they will move around, they are not getting penicillin. That is also there. Tablets, pentates, complaints again. Tablets, sometimes we are giving tablets, patients who are not willing to take injections, again compliance, we cannot trust everyday tablets.
Thank you, madam.
Okay. Thank you.
The next session will be ACS management during COVID-19 pandemic by Dr. May-Thurner.
Senior members of the profession, colleagues and friends. So today's topic given to me is the ACS management during pandemic and also post-COVID antiplatelet therapy considerations and what is relevant to the present situation. So this is a fully sponsored lecture. The disclosure is this is company sponsored lecture. AstraZeneca has sponsored this lecture. So you have to bear with the slides which show a particular molecule. Next one. Next slide, please. You have to change from here. So there is nothing much academic achievements from my side. Passed out with PM in 1995 and from 1996 I'm into the practice. So not much academics, only economics and commerce and cultural science. So there is no entity which is being affected by the COVID pandemic. And from the beginning, the cardiologists have been in the forefront. First, they were seeing the acute coronary syndrome patients, and most of them had a COVID infection, which has precipitated the acute coronary syndrome. And the other thing was immediately after that, many of the cardiologists have become positive because they were treating ACS patients. Many of the STEMI patients had a COVID infection and they became positive. Almost most of the cardiologists who were into private practice or in aggressive acute critical care practice, they became COVID positive. So COVID-19 is one of the dreaded pandemic which we have come across in our times. So it is a primarily respiratory disease, but many patients also had CVD, hypertension, acute myocarditis, and the lung disease with its hypoxia caused heart failure by itself or aggravated the pre-existing heart failure. The ACE2 receptor and the RAS receptor, which was very important in COVID, precipitation of COVID infection, had a lot of controversy and made many of them to stop ACE inhibitors in the beginning. It's also an important aspect in the CV system, in the vascular and the heart, leading to myocarditis, congestive heart failure, sudden cardiac death, and still the negative effects of COVID are continuing even after the third wave. So in the initial days, if a patient comes, it was a big problem. If we were previously we were only searching for the ACS patient, but during COVID times, we had a problem. If a patient comes, how to handle it? If he has respiratory infection, history of travel, or if he has any family member who has a COVID infection or who died of COVID, then how to go about it. So it was the triage which was developed during the early COVID days, which is not very relevant, but still an acute patient who has respiratory infection. If there is no COVID only, then immediately subject him to the ACS management like a primary angioplasty or a fibrinolytic therapy. If there is any suspicion or COVID infection is possible, see that the patient is kept in isolation and follow all the protocols where you are not spreading the infection to the staff members and other colleagues. And the PPEs and all those things were in the initial first wave and the second wave, but which now are not relevant after the vaccination. So STEMI patients in the initial days, they had COVID infection, and many of the patients who were treating acute STEMI with the same intent as normal infection, when there is no history of respiratory infection, there is no history of travel, and there is no contact also, still they had COVID positive infection. And in all those days, primary PCA was never an option. Fibrinolysis was considered as the most option during that days in the STEMI patients. And was trying to intubate them or trying to do an acute cardiac massage was a very big problem. I too had an acute myocardial infarction patient. We resuscitated him, but I became COVID positive after resuscitating him. So that was the situation where we were not spared of COVID infection during the times where we are treating acute STEMI patients or acute coronary syndrome patients. So STEMI, even our CSA has given flow chart how to deal with the COVID positive confirmed patients, suspected patients, and low probability patients. So confirmed COVID patients have to be treated in isolation, and suspected patients are also to be isolated. And previously there was a problem with getting the RT-PCR test done and the reports which we used to get. Now most of the things are now not very relevant. Now we can get a RT-PCR test done within 8 hours and you get the report. And antigen tests also in highly suspected cases helpful in isolating the patients and treating them accordingly. So if a patient is COVID positive as STEMI, the best option is to do the fibrinolytic treatment and then follow it up with primary angioplasty in very rare cases and angioplasty at a later date once the COVID infection is subsided. So in all the patients who had a COVID infection, existing or previous, there is an increased risk of thrombogenicity. There is a higher risk of being diagnosed with acute myocardial lesion first 14 days following the laboratory confirmed COVID-19 diagnosis. The first phase of the infection, we had a lot number of patients of STEMI who turned positive when we got a CT scan done or a RT-PCR test done. So COVID-19 infection has created a lot of myocardial infarction in the first phase. There is an increased risk of stent thrombosis. It has been very clearly demonstrated in patients who had STEMI and treated with PCI between March 1st and May 20th. They demonstrated higher rates of multivessel thrombosis and higher rates of stent thrombosis and higher modified thrombus grade leading to thrombus aspiration. So initial days when we do primary angioplasty, knowing that he is a COVID or non-COVID also, the COVID infection which has come after the stent implantation or during the patient if he has a COVID, there is a very high risk of patient dying of stent thrombosis after the procedure. So then the clopidogrel was not the very good choice during that time. They thought about Procedural, and many of the patients in the initial days has got Procedural, which is an efficient antiplatelet agent. And the recommended dose we already know and you have been using, but it is more potent than clopidogrel. So that is one thing. But the only problem with clopidogrel when compared to Procedural was there is a higher risk of bleeding, and many of these patients had a fatal bleeding leading to intracranial hemorrhage and many other complications. So you have to be very careful in giving patients who are of low body weight and age more than 70 years. So this has not been considered, and already there is a high risk of COVID infection and related thrombogenic and bleeding complications. So Procedural was not very good choice during these pandemic days. The other one is ticagrelor, which has been extensively used, is a reversible direct acting PE2Y2 inhibitor, which now many people are very commonly using in most of the patients who are planned for PCI, both in ACS condition and post-PCI or during PCI conditions. So just look at the evidence, how it is very effective when compared to the already existing antiplatelet therapy. So this is the data which has shown plateau as the one trial which has shown that there is a significant benefit in ACS patients at 12 months when compared to clopidogrel. So the events are less when you do clopidogrel. The definite stent thrombosis if the patient has a PCI done during the non-COVID times. These data can be extrapolated during the COVID times also. That ticagrelor produces less stent thrombosis. So during pandemic times, there is a need to give a better antiplatelet agent so that the risk of stent thrombosis, which is very high during pandemic, can be reduced. So it has also shown that when compared to clopidogrel, the bleeding risk is almost same. So you have an effective antiplatelet drug with better antiplatelet efficiency and with a less risk of bleeding, which is irrespective of treatment strategy. When compared to clopidogrel, it was more effective in reducing overall mortality, morbidity related to the CV death and other risk secondary endpoints. So making it as a more effective agent and with evidence and with a less bleeding risk. And the ticagrelor benefit was maintained throughout the year, 360 days. So ACS management in a patient who is medically managed or PCI or after thrombolytic therapy, ticagrelor scored over clopidogrel because of its better antiplatelet efficiency and a better evidence saying that it is better in CV death, reducing the CV death, myocardial infarction and all cause death. So when you compare with ticagrelor, compare with clopidogrel, ticagrelor is more effective, safe, and has a less bleeding risk. So then the next one is it was not evaluated very effectively after fibrinolytic therapy because already there is fibrinolysis with the newer form of fibrinolytic therapy. It is going to cause more bleeding or less bleeding, or it is effective as clopidogrel. So this is one trial which has been done in the recent times. The TREAT study which compared clopidogrel across ticagrelor in patients who have undergone fibrinolytic therapy for a follow-up of 12 months, and they compared the bleeding risk. So the bleeding is comparable to clopidogrel, and in many patients who are on clopidogrel, they were switched on to ticagrelor after randomization, and they didn't show any significant increased risk of bleeding even after fibrinolytic therapy. So it has been effective without causing significant increase in risk, and also there was no significant risk of intracranial hemorrhage or fatal bleeding, which is a very good aspect. And the majority of patients who have already on clopidogrel, when they are switched on to ticagrelor, even if they are less than 75 years age, they didn't have any significant risk of bleeding. So it is beneficial during pandemic to enhance antiplatelet therapy to reduce the incidence of ST segment elevation even after fibrinolytic therapy. So all the boxes are ticked. So in both post-MI, ACS, with PCI, without PCI, with fibrinolysis, without fibrinolysis, in all the segments, ticagrelor scored over clopidogrel, and in this setting of pandemic, it has found to be more effective than existing clopidogrel therapy. So even after COVID, that's post-COVID status also, we have platelet dysfunction, which was causing problems related in patients who had I had 2-3 patients who had a acute stent thrombosis. After the 3 months after stent implantation, they had a COVID infection and the patient died of acute stent thrombosis. So we were very scared to even put stents in patients who had a very critical lesion. This is because in post-COVID status, there is early platelet activation. There is a changes in platelet population profile, and there is an alteration in platelet factor expression. So this is one of the photographs of the platelets which are in the mice after post-COVID infection. They had greater platelet aggressibility and lesser response to the routine antiplatelet agents. So take that, you have to see that you get not only ticagrelor, but give a very effective ticagrelor so that the benefits of post-stent thrombosis are not seen in many of your patients. So this is a complex molecule with so many possible 64 possible stereoisomers. So we try to find out a drug which is pharmaceutical equivalence and bioequivalence and therapeutic equivalence to ticagrelor. Try to give a drug unless it is very much bioavailable and effective and the quality is maintained. You don't get the same results as the major molecule. So you can see that with clopidogrel, many of the brands available in India were not very pure and very effective. and which is causing 40% clopidogrel resistance. So try to choose a drug which is effective and probably manufactured by the when compared to the original manufacturers, and see that patients get effective clopidogrel so that they don't die of stent-related thrombosis related to both to the increased thrombogenicity status in the COVID times and also in the post-COVID. Thanks for the patient hearing.
Thank you, sir. Any questions from the audience?
So, sir, the first phase, there was a lot of usage of Aspirin, and that continued more with second phase also, and there is now still indiscriminate use of Aspirin in the patient. Both dual antiplatelet therapy and Aspirin are not indicated. So, if you are putting the patient on Aspirin, give only one antiplatelet drug. So that is, you have to give two antiplatelet drugs, and Aspirin is a big contraindication, leading to significant increase risk of bleeding without causing significant benefit in prevention. So the other thing is, Aspirin and it's been used like water actually, not even like acid. Still being used, but in the second phase, if you are really looking at the best outcome with Aspirin, see if the D dimer and all those things are raised and they continue to be raised after 2 weeks, probably after 4 weeks, then probably think about giving. The patient has significant lung involvement of this CT scan and continues to have symptoms related to breathlessness and hypoxia, then probably should be Aspirin. Thank you, sir. Thank you very much.
Next session is how to evaluate a patient with pericardial effusion by Dr. Karsan Srinivas Reddy, sir.
Good evening. I'm going to talk about pericardial effusion and more emphasis on tamponade. In our practice, we routinely see pericardial fluid, which is only seen on during systole and which is not seen on diastole, which is common finding during echocardiography. When it is abnormal, the pericardial space is normally contains 15 to 50 ml of fluid, and the presence of abnormal amount of fluid or abnormal nature of the fluid in the pericardial cavity is called abnormal. And we define cardiac tamponade as acute heart failure from rapidly accumulating pericardial effusion. Rapidly accumulating pericardial effusion as seen in perforations, cardiac perforations are during PCI or blunt trauma chest. Even 100 to 150 ml can cause tamponade. Whereas very large fluid accumulations can be accommodated without much symptoms if it is slowly progressing. Clinical manifestations are depends on the rate of accumulation of the fluid in the pericardial sac and nature of the underlying disease. The pericardial effusion, if it is rapidly accumulating or in a very large proportion, it causes markedly increased pericardial pressure, which overcomes the ventricular filling pressures, resulting in the underfilling of the ventricles and reduces stroke volume and further decrease in cardiac output. The most common causes in India for the pericardial effusion with tamponade are tuberculosis and followed by malignancy. But these days, statistics are changing. For the past 4 months, I have done 5 cases of pericardiocentesis. 4 were malignant. And another important causes we come across is acute MI, that is immediate post-MI pericarditis, usually between 1 to 3 days, and late pericarditis, that is Dressler syndrome. It is usually after 1 week to 6 weeks, and free wall rupture. We regularly see free wall ruptures in the acute MI presentation. Whenever patient comes late, out of window period, suddenly patient develops bradycardia and arrest, and electromechanical dissociation. When we put the probe on the chest, it usually large hemopericardium, resulting in death. The chest pain, the classical symptoms of this pericarditis is chest pain relieved by sitting up and leaning forward, and aggravated by lying down. And this classically radiates to the trapezius ridge. Important findings in cardiac tamponade is hypotension, decreased muffled heart sounds, and elevated JVP. This classical triad is called Beck's triad. And another important hallmark of cardiac tamponade is pulsus paradoxus. That is more than 10 mm Hg of fall in systolic BP during inspiration. Another important finding in JVP is absent Y descent. And these are routine investigations. Apart from renal parameters are important because uremic pericarditis is one of the important viral markers, cardiac markers, and CRP, thyroid profile. Hypothyroidism is one of the most important cause of pericardial effusion in our clinical practice and other investigations. Chest X-ray shows classic bottle-shaped heart. This is taken yesterday. We had large pericardial effusion case. And classical ECG changes of pericarditis is PR segment depression and ST segment elevation. In case of cardiac tamponade, low voltage complexes and electrical alternates are common due to swinging motion of the heart in the large pericardial sac. Echocardiography, whenever this is the best test to diagnose pericardial effusion and tamponade. And one has to mention the amount of fluid, either posteriorly, anteriorly, 10 mm, 20 mm, or more than 20 mm, because it is easy to quantify the pericardial effusion. Less than 10 mm is mild, and it is majority of the times limited to the posterior part. And moderate effusions are 10 to 20 millimeters, generally circumferential, and more than 20 mm is large. More than 25 mm is very large. And the echo signs of tamponade is diastolic RV collapse and late diastolic RA collapse and IVC plethora. The patient has all the signs of tamponade with IVC more than IVC compression during inspiration more than 50%. We think patient is dehydrated and give hydration. And another important hallmark of cardiac tamponade is ventricular inflow variation, that is tricuspid inflow variation of more than 40%, and mitral flow variation of more than 25% is significant. The management: patient is sick, give oxygen, and if the IVC is not plethoric and it is size is decreasing more than 50% during inspiration, give fluid. Pericardial centesis is only when it is indicated, whether it is tamponade is definite or impending tamponade is there. Otherwise, it's a risky procedure. It may lead to death of the patient. Pharmacology, generally, we tend to give diuretics whenever the patient JVP is elevated. Please avoid diuretics. And majority of the pericarditis patients respond with NSAIDs, commonly ibuprofen, colchicine, and steroids rarely. And usually we give ATT for ATT tuberculous pericarditis for 12 months. But recent studies has shown 8 months is enough, 2 months of 4 drugs therapy followed by 2 months, 6 months of 2 drugs therapy. And this is one thing is intra-pericardial fibrinolysis. Whenever we put a pigtail catheter in the pericardial space, if the pericardium is markedly thickened or there is loculations and there are a lot of fibrotic strands, give fibrinolysis with streptokinase, local installation of streptokinase are urokinase 2 to 6 lakh units, and it will stone that it is completely drained. Loculations are break, and pericardial effusion is completely drained, and progression to the further cardiac constriction is significantly less in these patients. So kindly consider giving pericardial fibrinolysis in patients with cardiac tamponade with loculations. Pericardiocentesis usually done through the subcostal route. Whenever a patient has large pericardial effusion or moderate pericardial effusion with tamponade, kindly rule out aortic dissection, type A aortic dissection. If you do pericardiocentesis in this setting, patient may rapidly deteriorate and death will die. And pericardiocentesis can be done through apical route and anterior para-sternal route, but echo guidance is more important. If you have echo machine, you yourself see the pericardial effusion approach, which is more safer, and direction of the needle is important. It guides us to direction of the needle. Classical teaching is through subcostal route. The direction of needle should be towards the left shoulder, but it's not always correct. Whenever you going to pericardiocentesis, kindly yourself see the echo. Send a pericardial fluid for analysis, including ADA, cytology, and TB PCR. This is done last month when middle-aged lady came with cardiac tamponade. We aspirated straw colored fluid. We thought it was tuberculosis, and empirically started ATT also. But we found to have a surprise at malignant cells. It was metastatic adenocarcinoma. Referred to oncologist. And if the pericardial effusion is recurrent, we can give local therapy, local cisplatin, doxycycline, tetracycline for the sclerosing agent, which obliterates the pericardial space. And if the patient has frequent recurrent large effusions, pericardial or peritoneal shunt and pericardectomy can be done. This is large pericardial effusion with thick visceral and parietal pericardium. In these cases, intrapericardial fibrinolysis will help to prevent further constriction. This is another case of acute MI with three-wall rupture, cardiac tamponade. Within few minutes, patient had brady and arrested and died. This is very common scenario in the acute MI setting with post-implant. There is one case operated in this our hospital. The patient of free-wall rupture, inferior MI, presented 48 hours later with recurrent syncope. Seen pericardial hematoma is there. We immediately took for surgery, CABG with clot evacuation. Take home message is idiopathic moderate effusions are common. Don't go after them. If you evaluate patient is asymptomatic, by incidental finding of moderate effusions, don't go and do pericarditis and all those things. And you is stable and asymptomatic, do other tests to rule out other malignancies. And if it is normal, keep quiet and follow. Pericardiocentesis only if necessary. And ultrasound guidance is preferred, and intrapericardial fibrinolysis can be considered in case of loculations or thick pericardium. Thank you. Thank you very much.
Thank you, sir. Any questions from the audience? If there are no questions, come to the next session. Aspirin, where does it stand in primary and secondary prevention? By Dr. Sahab, please, sir.
Good evening, all of you. So today we are to have a patient hearing because this is the most common and the most disturbing topic for all the cardiologists and physicians throughout the world. Because we are studying this molecule from induction to the MBBS, where we are dealing with aspirin, but still research is going on. Still there is no clear-cut decision regarding whether to give aspirin even in primary or secondary prevention. So, which is initially described as a wonderful drug because it is a very good painkiller, very good anti-inflammatory agent. It cuts the cancer risk and it helps in the prevention of the dementia. So everything described in the medicine is being treated by the aspirin, which is wonderfully praised by the father of the molecule, especially the promoter of the molecule, Bayer company, which shows that it very gentle as a mother's kiss. So it promoted the molecule as such. It is the only molecule which treats all diseases. So, but still, we are discussing this molecule. So why the aspirin has got any role in primary prevention or secondary prevention? Coming to the various stages, primary, secondary, and tertiary of the CVD. So the role of aspirin in primary prevention. So long history has been developed for the aspirin, especially the molecule initially developed in 1897. Though it is developed in 1897, but it came, we come to found the antiplatelet activity in 1967. So almost 70 to 80 years has been taken to identify its antiplatelet activity. Initially it is treated as an antipyretic anti-inflammatory agent, but in 1967 they found that it has got antiplatelet activity. So finding the antiplatelet activity, slowly it came into the practice, and a lot of trials have proved in the early phases of 1988 that the molecule is very beneficial even in the primary stages or primary prevention of the atherosclerotic cardiovascular disease. Finally, in recent era, that is almost up to 2018, where three predominant trials of aspirin, arrive and ascend trials, they came into the place, which shows that these molecule in primary prevention, both giving the benefit of preventing the atherosclerotic cardiovascular disease events, but at the risk of giving more bleeding, more hemorrhagic events to the patient. So this molecule, it comes into the question whether we can continue the molecule or we can stop taking the aspirin in elderly patients or even low to moderate risk patients. So these are the three classical contemporary trials of aspirin, which is hugely discussed in various trials, in various guidelines also, which shows that here almost double-blinded randomized control trials, and also recently a open-label trial is also going on. So where most of them are elderly individuals with risk factors are added in the trials and followed up for long time, almost 6 years, 7 years, 5 years, and sometimes even driven are also got into the trial. They found that there is little or no benefit. Little benefit in means of reducing the ischemic events, or sometimes they prove that there is no benefit when compared to placebo. So if you see the ARRIVE trial, where the moderate CVD risk patients are included, and the aspirin, where the elderly patients more than 65 years are included, both compared with the aspirin versus placebo. So if you see, the placebo has been proved to be somewhat beneficial when compared with the aspirin in preventing the CVD death, MI, unstable angina, stroke, RTI. So if we see the ASCENT trial, it shows a modest benefit when compared with placebo, but this modest benefit has been hampered by, if you see the harm, which is clearly proved in the ASCENT trial, the bleeding events are very, very high when compared with the benefit. Even the meta-analysis, which are recently published in higher journals,
JAMA 2019, EHJ 2019, and JAC 2019 all proved that though the benefit is mild to moderate in form of myocardial infarction or ischemic stroke, but every meta-analysis proves that the ischemic events are more. So all these things, they bring to our notice that giving the aspirin as a primary prevention in the elderly individuals or at low to moderate risk individuals has proved that they are developing more hemorrhagic events or bleeding events than preventing the ischemia. So coming to the various guidelines and what are the recommendations, the 2016 ESC guidelines and the recent 2021 ESC guidelines, they clearly mention that antiplatelet therapy is not recommended in individuals with low to moderate severe risk due to the increased risk of major, the classical class 3 level A indication. Even the 2019 ESC guidelines for CVD prevention, so they give a class 2B and class 3 indication for the initiation of aspirin for the primary prevention. So the low dose aspirin 75 to 100 mg orally daily might be considered for primary prevention among adults 40 to 70 years of age who are at higher ASCVD risk but not at increased bleeding risk. That point we have to note. Especially for adults more than 70 years, the low dose aspirin should not be administered on a routine basis. So this point is very, very important because most of us prescribe aspirin, even take low dose aspirin, you are above 70. That is also a class 3 recommendation. So primary prevention, then coming to the secondary prevention. So we all know that for secondary prevention, especially the dual antiplatelet therapy is the cornerstone or is the main treatment. So why aspirin is the cornerstone of DAPT? So if you see the meta-analysis of 70,000 patients from 16 RCTs who are at higher cardiovascular risk. So all this prove that treating 10,000 patients with aspirin for 1 year, you are going to avoid 100 to 200 ischemic fatal and non-fatal events. Meanwhile, you are going to develop 10 to 20 major extracranial bleeding events and 1 hemorrhagic stroke events. So these prove that the aspirin is definitely the choice of antiplatelet along with another antiplatelet in secondary prevention or in the treatment of especially patients who have gone for PCM. That why a need for aspirin-free strategies after PCM, because we have seen that the chances of developing the hemorrhagic events are more with dual antiplatelet therapy for longer period. So is there any chance or is there any choice of going for a single antiplatelet without aspirin? So because the aspirin has got more side effects or more adverse effects when compared to the other antiplatelet agents. So the main important concerns regarding the aspirin is one option is bleeding. So the bleeding risk, especially the major bleeding events like GI and intracranial are high. Then other options which we got are the newer antiplatelet agents have come into the market. There is the ticagrelor or Procedural, so which helps us in modifying the treatment of pattern for the especially post-PCA patients. And the newer therapies like statins or SGLT2 inhibitors or other ACE inhibitors or ARBs that came into the market, which can seriously influence the risk of the patient post-MI or post-ACS patient. So we have got a lot of armamentarium for the treatment of the patient. Then why we should give our patients a chance of bleeding even though we got a better alternative. So the major pitfalls of aspirin therapy. So the initially, which is proved to be a wonderful drug, now the wonderful drug has lost its glorious. So most of the physicians or cardiologists are going into the era of retiring the aspirin. That is, they are not willing to give aspirin along with the another antiplatelet agent. So what are the major pitfalls? First and foremost is gastrointestinal toxicity, because most of the aspirin intolerant or aspirin taking patients, they present with GI foods. Now, many companies, they tell us our brands are entry coated, so you can give safely. But though the entry coated, because the process of digestion of the aspirin though it is not in the gastric, but it is taken in the duodenum. So most of the people, though they are not presenting with the gastric dish, they are presenting with the duodenal dish, because the bleeding is definite, whether it is observed in the gastric or in the duodenum. So, and also the duodenal area, it impairs the absorption of the aspirin, so it leads to poor antiplatelet activity. So if you see the various pharmacodynamics and pharmacokinetics of aspirin, when compared with the newer antiplatelet agents, especially the in vitro assessment of platelet aggregation with 4 agonists in the presence of aspirin or procedural active metabolite or aspirin plus procedural active metabolite, you will see there is very little additional platelet inhibition following stimulation with several agonists in the presence of potent P2 white cell receptor. So because we are getting many potent receptor blockers, P2 white cell blockers recently. So the addition of aspirin has getting very little antiplatelet activity. So why should we subject our patients for having a little antiplatelet activity with major adverse effects? So then came the concept of the P2 white cell receptor, which is very, very important, playing a very important role in platelet activation and amplification. So this has been studied in the Plateau trial, where the ACS patients are studied with clopidogrel and ticagrelor, where the ticagrelor has proved to be more beneficial when compared to the primary endpoints like CV death, MI, or stroke when compared to the clopidogrel. Especially when compared to the bleeding, most of us suffer that the procedural and ticagrelor is more potent, so there are more chances of bleeding. But it's proved in the Plateau trial that the bleeding chances are very minimal or equal to the clopidogrel. So initially, before the initiation of the low dose of aspirin, many physicians or cardiologists, especially worldwide, they are prescribing high doses of aspirin with ticagrelor. So they found that adding a higher dosage of aspirin with the ticagrelor causing more bleeding events when compared with aspirin lower dosage. So they think that addition of aspirin 75 mg or up to 100 mg is enough whenever we are giving a higher potent antiplatelet agent like ticagrelor. So somebody may thinking that, so why should we give the 75 mg aspirin? Because we are giving higher antiplatelet agent, higher potent antiplatelet like ticagrelor, we can stop the even 75 mg aspirin. So the New York guidance, they have taken the alternative treatment of choice that most of the patients after giving 1 to 3 months of dual antiplatelet therapy going for single antiplatelet agent. So a study has been done with stop DAP2 with clopidogrel and smart choice. They found that, so the stop DAPT2 ACS trial, here a 1 month DAPT is given, both aspirin plus clopidogrel for 1 month, followed by clopidogrel only for next 1 to 5 years, randomized with dual antiplatelet therapy up to 1 year. So they found that, so the death, CV death, MI, large MI, definite stent thrombosis, any stroke, or BARC 3 to 5 bleeding events. So all of them, they are very minimal difference in between the single antiplatelet therapy versus dual antiplatelet therapy. So in ACS patients who underwent successful PCI using drug-eluting stents, clopidogrel monotherapy after 1 month DAPT, it failed to attest the non-inferiority to 12-month DAPT with aspirin and clopidogrel for the net clinical benefit, with a trend toward increase in CV events despite reduction in major bleeding events. Then came into the study, the Twilight trial, where most of the high-risk patients are included in the study. Almost 9,000 high-risk PCI patients, they are randomized to the study. Both these 9,000 patients, they have given ticagrelor plus aspirin for 3 months. After 3 months, they are called again back, and the events, ischemic events or hemorrhagic events are studied, and the patients who have not developed any events, they are randomized into 2 hands. One is continuing the ticagrelor plus aspirin for 12 months. Another hand is only ticagrelor with a matched placebo. So they are called back after 1 year, and they are observed for three more months. So the main key exclusion criteria in this study is STEMI, salvage PCI, and the need for chronic oral anticoagulation, prior stroke, or planned coronary revascularization. And this trial, it proved that the ticagrelor plus aspirin, especially the hemorrhagic events, the BARC 2, 3, or 5 bleeding, the ticagrelor plus aspirin has more chances or more incidence of bleeding when compared with a single antiplatelet, that is ticagrelor. Almost it is 4%. So almost 44% reduction of bleeding has been found with a single antiplatelet. Coming to the key secondary endpoints like death, MI, or stroke, if you see both the lines or both the curves, they are hugging each other. They are going almost same. There is no major advantage of ischemia when comparing with the bleeding. Then another trial, there is the TICO trial, where ticagrelor monotherapy has been compared with the ticagrelor 12 months DAPT. It also shows that among patients with ACS treated with DES, ticagrelor monotherapy after 3 months of DAPT compared with the ticagrelor based 12 months DAPT resulted in a modest but statistically significant reduction in the composite outcome of major bleeding and CV events. So the 2020 ESC guidelines, they have given an alternative approach for especially non-STMI ACS patients. So after 3 months, patients, even though is a low bleeding risk, so better to give a single antiplatelet agent in the form of ticagrelor or potent antiplatelet agents. Another trial, especially the host exam trial, where aspirin versus clopidogrel for chronic maintenance monotherapy after PCI has been studied in Korea from 37 centers. Especially, they have given a dual antiplatelet agent for 6 to 18 months, and they studied aspirin only for 24 months and clopidogrel only for 24 months. They found that the clopidogrel only after 12 months of DAPT, the primary outcomes, especially all-cause death, non-fatal MI, stroke, or readmission due to ACS, or major bleeding events are less when compared with aspirin. So it is 5.7 versus aspirin 7.7. Coming to the other special category individuals, AFPCI. So NOAC plus single antiplatelet versus VKA plus DAPT. So there are many trials which are undergone for this category of patients, Pioneer AFPCI, REVD-LPCI, Augustus, Entrust AFPCI trials. All showed that the stent thrombosis stroke is very minimal when compared to the hemorrhagic events with the NOAC plus SAVR. Though the stent thrombosis is somewhat little bit higher when compared with NOAC plus SAVR, the bleeding events are there. So the North American consensus has given the default strategy of triple therapy peri-PCI followed by double therapy, that is one oral anticoagulant with P2Y12 inhibitor up to 12 months, then followed by oral anticoagulation agent, especially in AF patients post-PCI. So the take-home message is, so in patients with no overt cardiovascular disease, the large-scale clinical trials found no or little benefit with chronic aspirin use. So in patients with established CAD or prior ACS or PCI, aspirin is currently the standard of care. But the novel strategies are emerging, especially in select high-risk patients. So the P2Y12 inhibitor monotherapy after a short course of DAPT following PCI, the novel strategy that reduces bleeding risk without compromising its function. And dual pathway inhibition with P2Y12 inhibitor and OSA may be the therapy of choice at least 1 month after ACS PCI in patients with it. So almost now coming days, the aspirin may lose its gloriousness in the near future. Thank you.
Thank you, sir. Any questions from the audience?
Say what drugs you are giving? Aspirins per column. We are practicing for 12 months. 12 months. After that, you are giving only aspirin, or after 12 months, clopidogrel. We are going for aspirin and clopidogrel. Mostly monotherapy we are going. Only clopidogrel. Only clopidogrel. That is better. Yeah, hope so, sir. Near future we can. Because all these trials are telling that giving the aspirin along with the higher antiplatelet agent may not give much protection as per ischemia driven. If you see the ischemia driven, we are getting more bleeding rather than protecting from ischemia. No, sir, what they are saying is, yeah, sir. Yeah. Yeah, yeah. Especially in a special scenario like the complex PCI, sir, they tell that complex PCI where the ischemia is more, especially if you go for single antiplatelet, then better give for bioreference for 1 year, especially like bifurcation strategies or 3 stents or the 3 vessel PCI or calcified lesions or long segment lesions. Sometimes they are using DAPT for longer duration. So patient 40 years may acute MI recanalized LAD. They are advising single monotherapy or DAPT. Or which is better? 3 drugs: aspirin, clopidogrel, or Vascular. That's not possible. Young male, we can go with single antiplatelet, sir. Recanalized, yeah, you can go for single antiplatelet. Which is your choice?
Sir, there is no role for ticagrelor. There is no data in ticagrelor in recanalized parts. So it is only for stented patients. So nothing in ACS for ticagrelor as of now. And ideally, dual antiplatelet therapy in ACS for at least a month. And there is still a data there which suggests a longer DAPT will be beneficial because it's a young patient. Why is he prothrombotic is more important. Looking at other causes of prothrombotic state as well. So definitely at least 6 months or even a year of DAPT in a young fellow. We don't want him to come back with another MI.
Aspirin and ticagrelor.
So that is one trial. Is it in guidelines is my question. There was only one trial, if I remember, on ticagrelor. But is it in guidelines is my question. Not in guidelines.
What is your opinion? In future, maybe aspirin role is decreasing.
Thank you.
Sir, that is the answer, sir. My last slide. Thank you, slide. The leader of NAGM, they told that the studies are changing. Initially, they think that aspirin is good. Now, aspirin is bad, or stop the drug. So they are not able to believe the research is going. Sir.
Thank you, everybody. May I request Dr. Veera Shankar Agalu to please one of the speakers and chairpersons and one Lakshmi. Sinus ready? Sinus ready? That's on. Sahib, please. And to the chairpersons, Dr. P. Venkateswara Rao. Dr. G.S. Sinus Reddy. Dr. P. Naveen Krishna. Thank you, sir. In 5 minutes, we'll start the general body meeting. I request all the APCSI members to please comment, you know. I request all the ఏ ప్రేమ పోయి నువ్వు రావి పోరబడుతావు భలే ఉన్నాను వినోద్ కూర్చోడా Ask, please, pass the please.